Hi, I'm Dr. Sam Lamb, facial plastic surgeon in Dallas, Texas. Really excited to introduce this master video series with QMP, and it's been a lifelong dream. This is one of those things that I've been teaching for many, many years, close to 20 years, run my own course in St. Louis. But even as the administrative chair for that course, I had to be part of a larger vision. Now I'm able to give all of these lectures, and it's exactly what I wanted to convey to the students out there, to all of you who are getting this video series. I wanted to tell you exactly how I see it, not to say my way is better, but it is exactly how I see every component of hair restoration. Today, in the world of hair, it is changing rapidly, and part of that technological change has to be reflected with new information. So I had a book that came out last year, and a new one coming out by QMP this year in 2023. And this video series is part, sort of that bundle, if you will. That book really talks specifically about surgical technique in a long text narrative form with a ton of surgical videos. This video series enhances that knowledge in a different way by giving you a long, luxurious, I would say, didactics where I can spend that time and really explain it to you, sort of like a professor would in a lecture hall about how things are. And that's what I learned when I was in college, and I learned from a professor. I got so much more out of it than just reading a book. In addition to that, you're going to see this lab beautifully and elegantly videographed so that I can not only show you sort of master dissections of how I do it, but also interact with the students and show you in a Socratic method when errors are made, because errors are going to be made at a junior level. What are those errors? How do we correct those? And I think that's part of the fun of the educational process. So I hope that this video series inspires you to be better surgeons, more ethical, to be more passionate about what you do, and really to love hair, because that's really what it's all about. It's not about just making an extra dollar out there, but it's about giving your best to the patients who deserve it. And when you see those eyes light up and see the lives that you transform, I think it's going to inspire you to be even better than you think you could be. So to begin with, thank you for coming. I'm really hoping this is great. I put my blood, sweat, and tears into this to make sure this is a good experience for you. And Andy will tell you, being in St. Louis, a large part of this is not you're watching me, is my watching you. I really noticed that, when I've done a pro section or done something to teach you, it will seem like you got it, but I don't know you got it until I watch you do it. And once I see you do it, I'm going to use some Socratic methods. In other words, I'm going to, if you draw a hairline a little off, don't worry about it, right? We're all in a learning process. And so I'm going to start working and having you guys look and go, hey, what's wrong with this hairline? And there's no judgment here, okay? I draw a hairline, it takes me sometimes 10 times to get it right, And so part of it is I want to work with you and getting your hands wet on this. So it's going to be very hard to take what you hear here and get it into the lab and be able to meld it. That's part of the goals or objectives of this weekend, are for you to get this academic knowledge and apply it. And so I'm going to try to not talk a lot of esoteric. The first lecture is basic intro, because you don't know what you don't know. I'm going to assume you don't know anything. So the first lecture may be so easy that you're going to fall asleep. If you do, I'll wake you up. But anyways, that's about all I wanted to say here. So the other thing is, I can't teach a passion, right? But I want at the end for you to get excited about this, because hair is exciting. It's fun. It's not boring. It's not making little holes in the head or pulling holes in the back of the head. It actually can be a lot of fun. And so I'm hoping after this initially slightly boring lecture that when we start getting into technique, you'll be stimulated and interested in this field that I'm passionate about. So we'll start with no further ado. So basically, we have to first understand how hair grows on the head. They don't grow in individual single one hairs. They grow in what are called follicular units, and they're clusters of 1 to 6 hairs, generally 1 to 4 hairs, and generally actually mainly 2 to 3 hairs. Whereas Asians have more clusters of 2s. Other races have more. Maybe African Americans are also on the lower side, but there's other races that have more 3s, and sometimes some have 2s, some have more 3s, or not many 4s, oftentimes. And they're very, very rare to have a 5 or 6. And those are sort of like special occasions you'll see that. And there's often a decent number of 1s. So every individual person has different numbers. But Headington in 84 found that these hairs grow in individual clusters of 1, 2, 3, 4 hairs. And they're groupings, which we'll talk about on the next slide, of what's involved with each of these. So why is that important? Because in the old days, we took these huge 4mm plugs out, that term you remember from the 70s, which encompassed 16 to 20 hairs. Now each graft is between 1 to 4. So that's what we're transplanting, are these follicular units that really Bobby Limmer in 89 made popular, and has become, whether you harvest through what I'm going to call linear strip excision, or LSE for short. That's basically what is a strip. You probably know it by FUT. I still use that term. It's not semantically correct, but anyways, I'll try to use LSE. If it's confusing, just raise your hand. It's the strip. I may say strip as well. So in terms of the anatomy, this is a lot. It's a busy slide. I want to also thank Mason Goth, who's an artist, has done all these. These are from my new textbook coming out. They're absolutely stunning, absolutely gorgeous illustrations. So the ones that are not gorgeous are the ones that Mason hadn't completed yet in this, and the ones that are gorgeous are his. So what I want you to take away from this slide, well, I'm not going to talk about inner root sheath, medulla, and cortex. I'm going to talk to you about some of the key things you need to know about graft survival. So there's a bulge and a bulb. 2 words that I want you to remember: bulge and bulb. Bulge is in that midsection, which is where that erector pili muscle, you see that pink muscle coming in. That muscle you have to transect to release on an FUE. If you don't break that muscle, that graft won't come out. Or you're going to pull it out and you're going to strip it and you're going to kill the graft, or it's going to be very denuded. Okay. So that right where that muscle inserts, the sebaceous gland is there. In fact, you can't see really the muscle very well. You really can't see the bulge area, but you're going to see the sebaceous gland sometimes. You'll see this little area. I have some slides later on if you do want to see it, but I won't go into it right now. So you want that bulge is a huge percentage of dynamic stem cells. All right. And so that area doesn't get transplanted. Your graft may not survive. The bottom portion, which is the hair bulb, is also what's called the dermal papilla. That's the area. I'm a very practical guy. I don't like esoteric research. I want to talk about why does this matter? Because that bottom portion, if it's not there, the graft may not survive. In fact, Kim and Choi did some really elegant research where they actually cut grafts and put in like the bottom half, the top half, the bottom third, the top third, bottom 2/3, top 2/3, and they figured out what survived. And they found that some of the data here is that when they just took a third of the top or just a third of the bottom and put that into a graft, there was no survival. It didn't work. So you have a third of the graft, probably don't bother transplanting. Certainly not in critical zones like the hairline. If you had the upper 2/3, you had about 60% survival, and if you had the bottom 2/3, you had about 80% survival. So that bottom portion is very critical. Not to say the bulge isn't, but remember, if you take the bottom 2/3, you got both the bulb and the bulge. You take the top 2/3, you've only got the bulge, not the bulb. And then if you took the bottom half versus the top half, you get about 40% survival if you had only the bottom half of the graft, and 20% survival if you had the top half. So this is why treating that graft with absolute respect is a predicate thing to have these grafts survive well. Hair anatomy, hair cycle. Why is this important? Well, first of all, you need to know the academics, right? I mean, if you don't know the academics, I think that's a fundamental flaw in this. You get so involved in just the practicality, but we need to know this. But the anagen phase basically lasts a long time, about 2 to 6 years on the scalp, okay? But it lasts shorter time on other parts, like the eyelash and eyebrows lasts about 2 to 3 months, and for the chest and other areas, it lasts only about 30, 45 days. So that's why if you're transplanting other areas to the scalp, they're not going to grow as fast. Or if you move hairs into the eyebrow, they're going to grow very fast, right? Much faster than we're used to. And the the catagen phase, which is basically where that hair follicle begins to separate out and begin to fall out, that early phase only lasts a short time. It's about 1 or 2 weeks, and it's about 5% of the time that's in catagen. So you're not going to really see that. Telogen phase is a little bit longer, it's about 3 to 5 months, and that's about 10% of the time that hairs are in there. And then the last phase, which is not on this diagram, when it actually falls out, is part of telogen, and it's known as exogen. That means that the hair shaft is actually out. And telogen, usually that 10%, could be longer. So in androgenic alopecia, or AGA, or also known as male pattern baldness, that hair loss, that's why you're here in this room, there is a shorter anagen, longer telogen phase, and maybe a higher percentage of telogen hairs. But what's part of AGA is that it's not necessarily just shedding. It's actually a process of shifting toward telogen, shortening anagen, and a miniaturization. We'll talk about that in the next slide. And that, so it's, people think, people always ask this question during consultation, how much hair shedding do you have? Well, that's a great question you'll hear when I talk about female hair loss, because it's one of those requisite knowledge I need to know. But for men, I oftentimes don't ask a lot about shedding unless there's something going on, like they had COVID recently and they're having a lot of pathology with that. But with male pattern baldness, what I want to know is how long has it been thinning? Okay, so thinning is the miniaturization process, which is captured in the slide. So I use the terms miniaturization and vellus interchangeably, but for semantic purity, miniaturized hairs is a description of a hair that hasn't undergone full change to a vellus hair. A vellus hair basically is this. If you guys have, if any of you guys are thinning, I'm thinning a little bit too. We all thin a little bit as we get older. And as you, if I get out of the shower, it's a little bit more see-through because I'm showing those vellus hairs. And those vellus hairs are hairs that are very transparent. They're very thin caliber. They're very short. They don't grow very long. And that's the end product before full baldness occurs. Miniaturized is just a process where those hairs are going to full baldness. And so you're going to hear me use those terms interchangeably. It's not semantically correct. And to be honest with you, vellus is not even correct because vellus is what occurs in the neonatal period. It's actually vellus-like. But just, I'm also a pragmatist, so I'm going to say miniaturized vellus. I would just use those interchangeably. Sorry, it's not in the book that way, but I'm just going to tell you, I'm going to use those terms interchangeably. But so what we're trying to do with medical therapy, and we'll have a whole lecture on that next, is slow down, retard, and reverse the process. Now, if you look at the bald. Can you see there's still a follicle there? A lot of people think you see this guy with a shaved head is a slick bald head. There's no follicles left, right? No, they're there. If I took a histologic section, you have a hair shaft in there. So there's a chance, even for slick baldness, for hairs to grow back with medical therapy, where the odds are very low, but sometimes I'm surprised there's some growth. Now, to be honest with you, a guy comes in with, Norwood 7, very slick bald. I'm not going to push hard on the medical therapy. I know the success rate is incredibly low because that guy, if I can do surgery safely, which we'll talk about more, then it's more surgery. So when you get to baldness is surgery. Miniaturization or vellus changes are going to be medical therapy. You want to save those hairs. You want to bring those back. Then there's a percentage that will start reversing in the right direction. So we need to know this. And this is over. You're going to see the slide about 4 more times during this whole talk, so don't worry too much of memorizing the slide. It's just an introduction to understand the fact that the parts of the scalp have different regions. Why is that important? Because there's anatomic, there's cosmetic benefits, and the hairs grow in different ways. And so I've made a simplified version of this that I love this because I think because I came up with it, but it also is a way to communicate because we get so complex with this that it's impossible to really remember all this. The head like a box basically means, think about the scalp in terms of horizontal and vertical planes. The horizontal plane is the mid-scalp, okay, and it ends here where it transitions to the front, which is the forehead. So where's the transition between these two planes? The hairline. Okay, and again, don't worry about truly understanding all this. The key to good education is redundancy. When I talk to my patients in consultations, key points I repeat 5 times, and I document it. But I'm going to repeat a lot of these ideas so many times that it will drill into your brain. All right, I've been teaching for almost 20 years, and I know how to get this in your head. So don't worry too much that you can't get all of this in yet. The sides, the lateral hump right here is the vertical plane. From a horizontal vertical plane, it's called the lateral crease. We'll have a whole lecture on that lateral crease, on that whole lateral hump. So don't worry. I'm just introducing these concepts. And in the back of the head, the crown, where the circle is, that's on the vertical plane. And that transition from mid-scalp to the back is called the vertex transition zone. Okay, that's oftentimes the posterior limit of where I transplant before I hit the crown. Okay, so Norwood scale, we look at this in a textbook and we flip by it. We go, I know it. But do you really know it? You need to know this. Why do you need to know this? Because it helps you write down the right diagnosis and it helps you progress where things are going. But if you don't understand how nature evolves, you can't replicate it surgically. So what are these Norwood patterns? I'm going to go through it in a basic scale and just so you understand. So Norwood 1 is a prepubescent hairline. It's not really prepubescent now because prepubescent is almost transgender. There's actually a downturn of the angles. But for the sake of understanding, post-pubescent, zero aging at all, zero hair loss is a 1. Okay, straight across like this. Okay, now of course African Americans have oftentimes this design. I'm not talking about that. We'll talk about that in hairline. But there's no recession. A Norwood 2, I'm Norwood 2. It means I'm getting under recession. And that's the goal, is to try to get you a transplant where you're a 2. You don't want to recreate a 1 in 99.9% of cases. So a 2 is because it's aesthetically good. It doesn't look like you're balding, but there's a frontal temporal recession. Okay, a Norwood 3 is now a justification to consider going to a 2 if you can. Sometimes the 3 is your end because you don't have enough grafts to get you to a 2, and that's, you don't want to create what's called a front heavy result where everything sits up here and it looks weird. Okay, it looks like a toupee because it looks weird. So a 3 basically it's about 2 centimeters anterior to the external auditory canal, and if anything farther back behind that, that's really where you start getting to a 4. So 3 is either early recession coming back far enough, and how do you know that? Well, you just look and go, oh, that guy needs a transplant. That's a 3, or they can be an isolated vertex. Okay, now the A patterns are just linear loss coming back this way instead of recession, so we're not going to go through those. A 4 basically means now they're thinning throughout the top, but they still have a good bridge in the middle. Okay, so when I look, I see they have a good bridge. That's still a 4. 5, that bridge is almost gone. Okay, so 4, strong bridge, but thinning throughout. 5, the bridge is almost gone, but it's still there. And 6, the bridge is gone. Okay, so 4, good bridge. 5, almost gone. 6, gone. That's the way to help you, just so you can look at it, go, that's a 5 or 6. Okay, you should be that fast to figure out. You shouldn't be sitting there going, I gotta go back and get that reference book. This is easy shortcuts to remember this. All right, it's what I use. What is a 7? That's 6 dropped. Now you got a horseshoe. That's, and then something about 8's not a joke. I mean, really they're miniaturized, right? We'll talk about that. And then there's so many scales for women. Let's not worry about all the complicated ones. This is what I use. Literally. Okay, what is it? Basically, a 1 is they're barely thinning, or you can see through it. 2 means they're pretty moderately thinning, and 3 is, oh my god, they're really bald. Okay. Now there's all variations of understanding frontal temporal loss, traction alopecia. We're going to talk about that under women. But just to make it easy, don't worry if the hairline is retained or not. If it is or isn't, that is an aromatase hormonal influence. I'm just talking about is the area thinning to what extent? Mild, moderate, severe. That's it. Ludwig 1, 2, 3. All right. The other thing, as Billy was saying, what makes this fun is design. This is artistry. If you really start to understand that hairs grow in all different angles, the goal for this is to recreate it in a beautiful way. And nature has no abrupt angles, okay? And that's why I'm going to teach you that in lab, et cetera, throughout this whole process and through lectures as well. And if you look at how hairs grow from a profile view, they go up higher and then back down. You're going to see the slide 2 or 3 more times, so don't worry. But I'm just giving these intro ideas. So understand that hairs grow differently all over the scalp. The point of the slide is just to introduce that concept, not for you to memorize this. Don't go there and go, God, I got to burn this in my mind, or I'm going to forget this. I'm not going to get this in the course. No, you're going to see the slide twice more when it's pertinent. I just want you to get big picture thinking in this talk. And here's a really easy one. Sorry, this is too obvious, but we're taking hairs that are not genetically programmed for loss. This guy called Norman Orndrike in 1952 came up with the idea that he published in 59 that hairs that are not genetically sensitive for loss move to another zone will stay. That's called donor dominance. Okay, that may be such a basic basic idea, but I realized when I taught St. Louis, I didn't even talk about it. It's too basic. No, it's not too basic. If you don't know that, then you don't understand hair, because that's how hair transplants work. Okay. This is the slide that's a little different in your handout. I just added this because I didn't have it for the, my textbook. But basically, the concept here is that Unger originally defined that for strip harvest, because that's all we had back in the day, is that there's just a narrow band that's safe. Because he took Norwood 7s and said, okay, this is what is safe. But then, of course, when you do FUE, you can't take a little area because you're going to have this moth-eaten empty area. You got to take it wider. So now Cole has expanded this and said, guess what? We need to harvest wider. Well, is that safe? We'll have a whole lecture and help you understand what is safe or not safe with FUE. How do we choose a candidate for FUE? How do we choose a candidate for a strip? Why would we choose one or the other? Whole lecture on that. But I just want to introduce this now. In my book, there are all these details of how many millimeters. Guess what? I don't memorize that. How do you figure out what's SDA, safe donor area? It's judgment. How do we have judgment? I'm going to look at all these heads. We're going to look at heads together. And I'm going to show you this is miniaturized, this is not. This is how I predict. This is the age. It's qualitative. All right. So you can go ahead and memorize it. I don't even think I was the president of the ABHRS, and I don't think that's even on the exam. If it is, I'm going to erase it because it's stupid. You don't need to memorize these numbers. Okay. All you got to do is get a judgment to understand what is safe, what isn't, based on parameters of looking at real people. And we got to do that. And we're going to do that in lab. Okay. So summary. Understand that we're moving follicular units, okay? Understand that I would love for you to understand every detailed part of the follicle, but you need to understand the bulb and bulge, okay? Those are the areas that you got to protect when you're doing a transplant. Understand the hair cycle. Why understand it? Because you're going to see telogen effluvium. What is antigen effluvium? Basically, what that is when you have cancer, those chemotherapy agents are cutting off the growth. That antigen effluvium, because what I say, 85% of the grafts or the follicles are in antigen. If I kill the ability for those hairs to grow, what happens? You lose all your hair, right? So that's so you have to understand the cycle. You have to understand the region of the scalp. We're going to explore that in great detail coming up. Understand the Norwood pattern. And if you have questions, please ask me as we go to lab. If you don't understand a concept, let's go over it. That's why you're paying the money to be here. That's why you're going to be with me this time. There's no shame. Don't think this is too stupid a question. Ask me, please. I would love for you to be after 2 days go, wow, I got a good solid footing on this. Understand hair growth. Understand that process of hair loss, where you understand miniaturization or vellus changes. That is the key to this whole point of understand AGA, understand what donor dominance is, and understand the SDA. And we're going to understand the SDA or safe donor area through real people, not through how many millimeters or how many centimeters. It's just not relevant. If you go in that textbook, you can go to my book and memorize it. Congratulations, but it's not going to help you. All right. So this is a book that came out last year. I make no money on this course. I make no money on my courses. I make no money on the books. All my profits go to stop human trafficking. Love does. So your whatever honorarium I get from this, if I get anything, if I don't, no problem. But whatever I get will be donated for a good cause. So this book came out last year. As I mentioned to you, this is not a beginner book. It is an advanced book. It's great for you to have on your shelf as an encyclopedic knowledge, but it won't help you. This book that's coming out in July of this year, I'm very passionate about. It's been a labor of love over the last year. This is a companion to the course. The reason why this course has gotten so much better because the amount of knowledge that's pulled from this book. And the reason this book is so good is how much work I prepared for this course. So I hope you get this book. It should be out in July. If not, there'll be proofs in July. It won't be out later than this fall. That I'm very, very confident. So that's the first lecture. All right, medical therapy, how I do it in 2023. So here's the thing, this is not academic, but guess what? You guys, you may want to memorize what the internal root sheath is and all that, and the medulla and the cortex, but I'd rather you really academically understand the studies. Do you know that I quote these studies to the patients all the time? Not only does it make me sound smart, but they need to know these things, because they need to know what are the side effect risks, what are these things, and if you're just vague about it, patients are scared. They won't do it because there's so much online confusion, things that freak people out. So you need to know this. Now there's a disclosure, I'm going to talk briefly about a product I make called FolliFlow. Now, I hate, as you know, I give all the profits away for this course. It's not that I'm trying to make money off you, but it's such, to me, I spent 2 years developing this product, and it's in such a huge part of, especially helping women with shedding, that I'm going to mention it, okay, because I think it's a successful product in its context. This is the crux of the entire course right here. If you don't understand this, you are doing a disservice. Do you know I spend sometimes an entire day suppressing and I turn every patient away? And it's hard. When you're starting on practice, you want to operate on every patient because that's money. Money in the bank that's feeding your family. But the thing that gives me passion is social justice, which is not hurting people, okay? Why am I teaching this course? So that you don't go hurt people, okay? I don't want you to go into this with the wrong idea and hurt people, which is this concept is that we are facing a real problem with hair loss in men. Women not as badly, but with men, yes, which is we're constantly losing supply. Why? Because this crown gets bigger and it's getting smaller, and we take from it. We take and put transplants up to the top, so we're constantly losing that supply, and we're constantly increasing demand. No male all of a sudden gets more hair unless he castrates himself, right? That's historically true. Eunuchs had no hair loss, so that's one option, okay? But I don't think it's a very viable one. But the understanding is that we're constantly losing supply and constantly increasing demand. So what is the goal of the surgeon? Is to make sure that in the future you have enough supply to fix future demand. That's a huge, huge, huge responsibility on your shoulders, because if you screw it up, it's going to be a serious problem. Okay, I had a consult with a plastic surgeon, like a phone consult, and he had no options left to fix his horrible problem at 43 years of age. He said, Dr. Lamb, I wish someone had told me that this back when I was 30. And this industry right now is very corrupt, I say. Right now, there's people doing it for $1. The reason you're sitting here and spending these 2 days with me is so that you don't do this for $1. The dollars will come. What you need to do is do the right thing by your patients. And this slide, I want it to be emblazoned in your brain, because your biggest response, when I walk in a room for a consultation, the first thing I do after greeting a patient, I look at the donor, because that supply and that demand informs my entire consultation. If I don't know what they have anatomically and their age, then I can't treat them. And then I go and do the consultation. Guess what? I don't ask for family history. Oh my God, you're kidding me. You must be a bad doctor. I don't, because it doesn't matter. I'll tell you why it doesn't matter. It's against the grain, okay? But if you think about one thing, if you look at people out there, you can have identical twins, okay? They have different sexual orientation, they have different hair loss. Wait a second, identical twins, I thought it was genetic. There's epigenetic factors. Fraternal twins, totally different. One with full head of hair, my dad is losing. I don't ask. They want to tell me fine, but I don't even record it, because what matters is what's happening to that patient. All right, but that's against the grain. Okay, that's against every textbook you're going to read except for mine. So let's talk about this. Here's a chart again. Just please know this. And understand that it's not hair shedding for male pattern baldness. It is a miniaturization process, okay? So these are my 2 weapons, all right? If you need to understand the ins and outs of these, all right? Read the chapter in the new book. Memorize every study that's in there. This is academic, and I'm not an academician in terms of memorizing useless information. You must know this. I'm going to only briefly touch upon all these points, because it will take me 3 hours to go through all this. All right, so let's talk about finasteride and dutasteride. Good question. So finasteride blocks 5-alpha reductase type 2. There are 2 types, type 1 and type 2. Dutasteride blocks both of those. So with finasteride, you're blocking about 69% of circulating DHT. With dutasteride, you're blocking 99%, okay? And they actually did an interesting study recently in Korea. It was a retrospective chart review that they looked at about 600-some men on both sides. Each arm was about 49%. They found that dutasteride didn't have a higher side effect profile, shockingly, over finasteride. So I say this to men because the other thing is true. There's been a study with a 5 milligram dose of finasteride, and they found that there was a 5x higher likelihood, actually a 45% sexual side effect rate with counseling a patient that they could have sexual side effects, and only a 15% when they were not counseled. So it's actually 3x, do the math there, but it's something you need to know. Now, so that's a high sexual side effect profile. In phase 3 trials with Merck, they showed about a 0.9% sexual side effect rate with a 1 milligram dose, and when they to cite it against all types of sexual side effects, from erectile dysfunction, libido to breast tenderness to the decreased ejaculate to like 5 or 6 parameters, in order to get a p-value statistically significant, they had to actually put all of those together. So it's a very low incidence sexual side effects, but it can happen. And yes, you've heard online through that 2012 article from Journal of Sexual Medicine that have shown long-term side effects with what we call post-finasteride syndrome. Yes, I've seen it. It's 2 to 3 men like this. I do have people sign off on a consent that says they could have that. You have that consent. You have it in your thumb drive. You can use it actually from Bob Bernstein. So thank you to Dr. Bernstein for having that. It's also in my textbooks. There'll be a clickable link on the book too, and it's also in my previous books. But yeah, it can happen. I counsel my patients on that. But I will tell you that the incidence of anything long-term is very, very small. In fact, 57% of men they've shown after 1 month of taking finasteride, if they have a side effect, that it will go away. So men that 6 years into it that have a side effect usually have it because they read something online and then they stop doing it, which is sad to me because it's one of the most principal weapons to stop hair loss. And I use it in women as well in the right context. Again, it's teratogenic. As you don't know, if you don't know that, please understand this. I cannot cover everything about finasteride in a single slide. You're going to have to read about it, and I'm just going to go through some key points. It is processed through the liver. You don't have to adjust it for renal insufficiency. So if they've got they're alcoholic, they got high liver function test, something, you may want to be careful with finasteride. Dutasteride does last longer in the system. It's dosed usually at 0.5 milligrams instead of 1. They've actually done a study, by the way, with finasteride and found that 1 and 5 milligrams doesn't help more one or the other. Now they haven't done 3 or 2. We'll talk about that in a moment. With the dutasteride, it is a longer half-life. And the question, though, is how to dose it. And this is a hard one. I oftentimes just dose it, if it's like mild, I may dose it once a week. You can dose it QOD every other day, or you can dose it once a day. And there's no consensus. I dose it sometimes different ways, to be honest with you. So there's no consistency with the dosing regimen compared to finasteride, which is once a day. The other thing to know is the PCPT trials. It stands for prostate cancer prevention trials. These were conducted in 2008. What these studies showed were basically looking at does it affect prostate cancer? And so the initial study showed that it didn't affect it, and then they found that it was actually reduced the chance of prostate cancer, and then they found that it actually may select out for higher grade prostate cancer. Now, that was clarified, and understanding what happens with Propecia or finasteride is that it shrinks down the prostate, and so there was a higher sampling of these tumors, even though the total incidence was lower. So I always counsel patients that it should not increase your chance of prostate cancer. They actually think it reduces the chance of prostate cancer, so just so you understand that. But you should review the PCPT trial data and really understand that well. To me, it's important to understand it. Especially, it does reduce your PSA by about 47%, so men that are over 50-some, it's great to get a baseline PSA before you start doing it, just so they have a good understanding of where that is. Yes, Tommy?
Has it been studied in women? Do we know?
Yes. So the one study that I know about in terms of it was done in postmenopausal women because it's teratogenic. It can cause a hypospadia in a male fetus. And for men, it should not be an issue if the woman is getting pregnant, but for the woman, it is an issue if they're taking it. But in postmenopausal women, the dose at 1 milligram probably is not enough. They probably need 2.5 to 5 is what the study had shown to make an impact on them. I'm going to mention in a moment a refinement of that knowledge through a test that I'm doing that I love called the trickle test, and I'm going to explore that more in a slide coming up. But so I really can tweak it better based on genetic profiling. But that's the answer. It's usually 2.55. Which one do you do? I've done both. I see. That's what you're asking. Yeah. So that's a good question. I don't think it's really been studied, to be honest with you. And dutasteride is an off-label. They've only done phase 3 trials with it in Korea. Just to let you know that in case someone asks. So it's legal if you know what off-label is. I'm not going to go into that. If that is not clear, we can ask it offline. So yeah, go ahead. Patients who are doing testosterone. Great question. I forgot to mention that. Yeah, one of my big questions I ask is, are you on testosterone? Because testosterone is a killer. It's that bad in terms of hair. And we don't know statistically if you're under 700 or if you're over 900. What causes it? We don't know. How do you know? So when I say to my patients, look, if you go to the dentist, they're going to tell you don't eat candy. I'm going to tell you don't take testosterone. It's only because I don't want you to have hair loss. If you're not genetically sensitive to hair loss, then take testosterone. But if you are and you're seeing progression, especially if you can temporally time it and say, you know what, my hair loss really accelerated the last 5 years. And how long have you been on testosterone? 5 years. Guess what happened? Testosterone. So that's why men in their 40s, oftentimes with a little bit of drop of testosterone, their hair loss slows down. And that's why I feel it's safer. But on testosterone, they drive that testosterone level to the 20s, and then they have more hair loss. So that's a great question. It should be part of every consultation to ask that question. Does that answer your question? Okay. This is a slide that I use to talk to patients about it. Because men, they use medical therapy for a while ago. It stopped working. You probably heard this, right? And it didn't stop working. What happened is you're just going to continue to lose hair. It's like a speed train that you want to slow down. But look at the study. What's interesting is that even though you get a good boost and it starts to go down, that's a top curve. The bottom curve, this is a 5-year, believe it or not. I don't know who the heck took placebo for 5 years, but they did. There's only 32 left in the arm by Merck. But they found that, yes, male pattern baldness continued to drive it down. But those that, even though they did lose some hair over 5 years, look at the delta between those two arms. That delta increases. In other words, you actually preserved more hair from this, right? Than you actually, you lost some. So I always tell them, because people, the practical side is when you say, well, when can I stop this? You can hear this question 100 times. When can I stop this? I say, when you stop caring about your hair loss or when I have better technology. Instead of saying lifetime, because it's scary. So if you say that, look, hey, hair cloning, we don't know when that's going to be available. Okay, we've been working since the 80s. But when we have something where I can replicate that hair follicle, you can stop this medical therapy. Or when I've got better technology. I'm right now working on injectable dutasteride. I'm actually part of a webinar next month that I say, oh, cool, this is what I'm working on. Every 6 months to do a little injection would be pretty cool if it works, right? So far, my colleagues have said it has worked. So there are new technologies all the time that are out there, okay? So I love this slide because it helps people understand the power of long-term therapy. So minoxidil, we don't know how this works. Mechanism of action, we don't know. It lengthens anagen. It's been shown to maybe reduce telogen. It works on, it's a potassium channel agonist. So we don't know, but it works, okay? And it's synergistic. The key with this is that it works really well with finasteride. Oh, I did mention the finasteride slide. Topical works great too. It's usually 0.25% up on the slide, but I've been using topical for years. It's a great alternative for men that don't want to be on an oral. The only exception is I'm always cautious if their wife or significant other is pregnant because I just don't want the wife or significant other to handle the topical, for teratogenic issues. So the other thing too is that the side effects are basically with topical. The number one is allergy. Okay, you're going to see a topical allergy. The one that is propylene glycol free, which is the foam, now it's generic as well, could minimize that risk of allergy. The second biggest side effect is hair growth in women, and the reason for that hair growth is not clear because people think it's dripping down their face. No, it's actually absorbed. So just so you know that. And here's what I tell women. Okay, it's true. The 5% that get secondary hair growth, their hair on their head explodes. They're very sensitive, so they get a pro and a con. If you explain that to them, they go, oh, okay, well maybe I won't stop. Some will go, no, I hate this. I don't want to do electrolysis or shave. And some will say, look, I'm postmenopausal. I shave every day. So or shave not every day, but I shave often for this. So that's the way that I counsel people about this. But it really works incredibly well. And as you may have seen that, I think it was New York Times or Wall Street Journal, that's an article in August of last year that made everyone talk about oral. Oral is great. I've been using it for about 2 years now. It's a great alternative. One of my colleagues, bonus out of Thailand, just did a paper on a non-inferiority of the oral. I think oral is actually stronger. And so the next slide, I'll just introduce it now. I do a test called trickle test. No financial relation with anything I mentioned unless I disclose it. And it's a buccal swab that tells me exactly the parameters that I need. And it'll tell me you need 0.3 dutasteride QOD with this level of minoxidil. You need a 3.0 oral dose, or you need this exact topical concoction with. It'll they look for glucocorticoid receptor. Do you even need a steroid on top of the scalp? So it's a great test. It's something that you can actually monetize as well, which is nice. But it also helps you use that test to give exact dosing. But if not exact dosing, I usually just start empirically at 2.5 milligrams for women and 5 milligrams for men, QD. You want to be a little careful if someone's got a cardiac history. I don't think it really can exacerbate the cardiac history, but it's a question whether it can cause some issues. For example, tachycardia, some flushing. It can cause, this is the oral dose usually. It still can cause some allergy. It can cause even red scalp with it, but very low likelihood. And it can cause some edema in the legs. And it can cause some dizziness or headaches. It's pretty low incidence. They did a study in Japan, 18,000 men. Incidence was about 2 in 1,000, but I have seen it, so it's not that rare. But again, to minimize that nocebo, I try to counsel patients on these data that's on the low end so they don't get a nocebo. They can't, but usually nocebo has a lot to do with the sexual side effects. Obviously, if you get facial flushing, I doubt it's a nocebo. I think you just have facial flushing. So if they have that, I usually dose them lower on the oral or go to topical or vice versa. And that's a great thing, is that flexibility. I'm going to talk to you in the next slide about how do you practically dose, how do you give this to the patient? But we're going to talk about that in a second. So there's 30 to 50% of people, they don't have sulfotransferase, which is an enzyme needed to convert it to its active metabolite in the scalp. So that's why this test helps me to know that information, or I try to encourage patients now to be on oral, because to me it's an easier regimen to be on oral dose than a topical. But that's there. You can also hear this all the time because the package insert, that's what word PI, the abbreviation PI means, is that it's only good for the crown. You'll hear this because that was done on the FDA trials for minoxidil. They have to only put that on package insert. They can't say it's good for the front, but subsequent studies have shown incredible efficacy on the front and the back. So it's across the whole scalp. And I usually just dose at QD. Anything BID, game over. It's no one's going to do it anyways. And what I usually tell my patients, because the studies were made for the crown, if they have a full scalp, just double the dose that's on the over the counter and apply over your whole head and do it once a day. Okay? And so now let's talk about how I do this. So I call myself a hair personal trainer, because here's the thing. Like if you eat fried chicken for 3 days in a row, you're going to go back and try to eat some salads and eat organic food and juice and maybe go back. You haven't done the gym for 3 weeks, you're going to say, you know what, I got to go to the gym because it's going to help me. You drank too much over the weekend in Mexico, you're going to say, you know what, I'm going to be on the wagon for January, whatever it is, right? So it's the same way with hair loss. Help patients. I say these words. I try to help patients understand whatever you can do to save your hair, do it. If you're only doing it 4 days a week, that's 4 days better than anyone else. The only problem is if you stop for a month or two, all those years that you gained are going to be gone. That sucks, right? But don't think that. But understand that if you went for a week without it, please restart. If you only do it 4 days a week, please continue. And that's the key with this. And so now, what I try to do is I combine orals and topicals. Now the fact that it's not just traditionally oral finasteride and topical minoxidil, but I can do oral or topical and make it easier for the patient. As you know, anything BID is not going to happen. And as you know, topical is harder. So if I can massage out in a consult, if they're going to do topical oral, that's better. With the trickle test, if they do it, in about 3 to 4 weeks, I get a diagnosis of exactly what they need. And I try to, during my consultation, find out what they're willing to do first, because I can't remember after that. So if they said, okay, I'm not interested in oral, no, you can talk to me forever, I won't do it, I only want topical. Okay, great. So we're going to do topical, and when the trickle test comes back, I have that topical ready formulated, and then I get it going for them. Okay, so that's what I do. So for men, my first line is chemical. In other words, finasteride minoxidil combination at some level, because male pattern baldness is so brutally bad. Okay, for women, this is going to be against the grain. I oftentimes don't start with that. I start with the natural. You say, well, what do you do? Well, I'm going to talk about it on the next slide, and then I will talk about it in more detail on the female lecture. So first line for women, there's my product, COI. Sorry guys, and it's right now not available. It may be in production next week, or I may just pull my own hair out. It's taking me forever to get back on. So Caravive is basically, it's a plant-based growth factor. It's like PRP, except with no needles, so it's an expensive machine that infuses into the scalp. I find it to be more effective than PRP and less painful. And for women, for men and women, it works really well. I do it once a month for 3 months and then every 6 months. And I usually use these two as my first line for women. If they're shedding, oftentimes this is enough. I don't necessarily need to do finasteride minoxidil. So that's against the grain. If you want to hear a really detailed podcast on this, I did one on female hair loss evaluations that you can find on my Instagram, my website. I spend like 20 minutes going through what I'm telling you in about 30 seconds. But I usually use the natural for women because they don't need it. Now you say, well, do you ever do this for men? I do. If I got a 55-year-old and they're just losing a little hair and they don't want to be on finasteride minoxidil every day, so the ways that I do that is different from a guy that's 25 that I don't think I want to do surgery on. For the 25-year-old, I'm doing finasteride minoxidil, whatever avenue they're willing to take, and watch them really carefully, maybe add another one. I may even stack 2 therapies at once, which I can't even read which one is working because I'm so desperate to make sure they're stable. Most times I want to segregate those so I don't give them too much at one time because I can't tell what's working. But for a young guy where I can't do surgery and they're rapidly thinning, I sometimes throw both this Caravive or whatever it may be and throw everything at them. When I'm doing a 55-year-old, well, I don't want to take finasteride. Okay, you know what? Let's do a trickle test, see what you're sensitive. Oh, you're resistant to finasteride. You need to be a high dose of that. Okay, I'll just do minoxidil. You need 2 milligrams of minoxidil. That's all you need, done. So, okay, no, I don't want to do that. I'm too lazy to do minoxidil every day. Okay, well, listen, you're slow hair loss. Why don't we just do a Caravive once every 6 months and get you on that? Again, I have no financial affiliation to speak around the video with this company. But so these are the ways I treat it. Or a 65-year-old, I'm losing the hair very slowly. No medical therapy. Let's just do surgery, see where we go, follow you back in 5, 10 years. If you're losing more, we either add medical therapy, we add something small. So this is how I tailor it. The easiest way to understand it, the younger you are, the more aggressive and hyper-aggressive on medical therapy, and very conservative, if not completely withdrawing surgery options altogether. Now I'm talking about men, okay? 26-year-old female that wants a hairline lowering, that's a different story. But man, I'm very aggressive medically, very conservative surgically. I'm not even offering it. Middle 40s, I'm surgery when appropriate. If it's not appropriate, they don't get it. Plus moderate medical therapy. The older you are, the less medical therapy, the more surgery. Think of it that way, because I feel safer. All right, does that make sense? Low-level laser therapy is effective, but not as effective. I think it's more effective for women, and you have to have hair loss. So if you've got a lot of hair up there, it's harder for it to penetrate. And then oral vitamins, they work. That trickle test will actually give you exactly which vitamin deficiency you have as well. And so there's a lot of, yes, go ahead, Eddie.
What's the mechanism?
So no, that's the thought, but the way it works, I have this fancy chart on my, it shows you, it's through, it's an internal cyclic AMP activation of a base bulb, dermal papilla activation through cyclic AMP and ATP, and it's an incredibly complicated cascade. And you know when they discovered this? 1968, Hungarian scientists. So it's an old technology, but the technology's gotten a lot better in terms of improvements. To me, I don't sell a lot of these because I don't sell things I don't believe in. I just don't think it's as strong a mechanism compared to the other technologies I have. So it's my second line, just so you know that. Okay, I'm not into just make a dollar off you. I really want everything to work so that when I sell you something, I believe in it. Okay, and that's what I'm giving you. I'm telling you what I say to my patients. You know, I know everyone wants a dollar, but what's more important is doing the right thing for the patient. You know, that's really, really important. I hope I drive that home to you guys. So, and I'm saying things on video recorded. I'm fine with it. I'm totally fine to be transparent and understand these things. So, I said this earlier. Medical is the key when you're having miniaturization when it's balded surgery. Okay, again, you're gonna hear a lot of redundant things when I'm talking. Unstable, please don't operate on that. You're gonna put in 3 hairs and lose 3 hairs and put in 3 hairs and lose 3 hairs. It's not good. Medicine is where it's stable. Maybe surgery, maybe medicine. You've heard my algorithm. And then the other thing I use medicine for is that if you've got a lot of miniaturized zone and you need a transplant there, especially for women, you're gonna have a lot of hair shedding. And that telogen shock loss is not good. You're gonna have someone upset at you. That should come back. Most times it comes back completely. But what I want is I want 6 weeks of minoxidil stabilization. Now, how long should you do it for? If someone, let's say they're a 63-year-old guy comes in and they're miniaturized extensively, but they don't want medicine. Okay, and I think, okay, no medicine. You're doing great. It's great. I'm gonna do it. I give them only 6 weeks of minoxidil, stop them 2 days before. before, restarting 1 week after. Why? Because if they grow 20% of their hair in 6 months, and then I do the transplant thinking those hairs are permanent, and then they stop the minoxidil, they'll lose that 20%, and I won't know what's going on. Does that make sense? So I only do 6 weeks of therapy for that. So this is the summary. Understand miniaturization of DHT. You've got to know these products backwards and forwards, and I really want you to know the studies and you're able to cite them. All right? So there are things that are academic that you don't need to know except for maybe taking a test, and there are things that you really should know because you need to counsel patients with data. Not, hey, you know what, I know. No, you need to be very accurate. So this is stuff that the citations I've given you, why can I cite it like this? Is it because I'm just brilliant about it? No, because I use it every day. I cite this to my patients. And you need to know the literature to cite medical therapy. You don't have to cite everything about studies on surgery, you have to cite medicine, so they know the percentages of risk. And then know the ways of delivery. Remember what I said is I like to combine medicine and, topical and topical, oral and oral to make it easy, nothing more than QD. And remember what I said, hair personal trainer. If I can coach you to just do what you can, okay? Like if personal trainer says, look, I need you to be my 6 days a week. I can't do 6 days, what can you do? I can only do 2. Can we do 3? Okay, I can do 3. Done. Do you see what I'm saying? This is how I look at medical therapy, and that's the way I counsel them. And know the roles of what medicine and surgery does, and understand that natural therapy is not all hogwash. It does work in the right context. So let's talk a little bit about when to decide to do one or the other, strip versus FUE or linear strip excision. So the trends, obviously, everyone's doing FUE, right? Everyone's maybe here just to learn FUE, I don't want to learn strip, but it is something that, unfortunately, this is what's happening. There are fewer and fewer doctors that can do the strip. And I think there's a role for each, and I think I want you to understand by the end of this, what is that role? So this is what FUE surgeons want to give you hype. Scars are horrid, do not do this, all right? My scars oftentimes are very hard to see, even close up. I get a lot of hairstylist barbers send me cases because they can't find the incisions. Or this is what you see too on the other side. Look at this. You can get hypopigmentation because nothing is scarless. You hear this all the time, FUE scarless, that's unethical. You cannot say that. You cannot shave your head after FUE, okay? So there's hypopigmentation at some level. Don't think it's scarless. It's absolutely not scarless. Strip is not scarless either. I show you one thing you barely can see. When you shave it, you see a line. Nothing's. That's why that supply and demand curve I showed you is so critical, because if you think, well, I have an exit strategy to shave my head, you do not have that anymore. I'm very clear with my patients. You cannot exit hair surgery. You can only exit it with more surgery. You can't exit it with less or to be out of it. So this is a disaster I saw in my office come through. This is a guy that had multiple bad strips. Then he had over-harvesting with FUE that depleted it. Now what can he do? He wasn't even counseling on medical therapy. I mean, this is the problem with the industry today. Everyone's in it that are inexperienced. They don't know what they're doing terrible work on patients, and it's making hair surgery a bad name, and it's making me depressed. I come home, I got my heart broken on a daily basis. People walking through the things I hear what people are counseled on makes me sick and nauseous. Okay, I hope it makes you nauseous because that's what I want you to be driven toward is better work. So what do LSE surgeons want you to believe? That FU grafts don't survive. They're terrible. They're useless, but they're not. They're great, and they survive well today. In fact, studies have shown that they're the same. The growth rates are the same. So what is the revolution? The reason I had my first book come out in 2016, I rewrote it in 2022, is because of 2017-18. The revolution occurred with what's called hybrid technology. And so what are they? You're going to have two of the vendors. You're going to be able to try the state-of-the-art hybrid ones. We don't have them. Again, no affiliation with them. But the idea is a trumpet punch. We'll hear more about it during the FUE talk. But these are a best blend of sharp and dull. I'm not going to talk too much about it here. We're going to reserve it for the FUE discussion, but it's really great. So the graph quality is very similar now. So we're going to talk about this. Remember what I said. What is the first thing I do when I walk into consultation after I say hi to you? I look at the donor, right? Because the SDA is there. Well, here's the deal. FUE, by very virtue of the procedure, harvest an expanded concept of SDA. You cannot take a narrow strip. You can't. You're going to have a mopping appearance. So that's why I poo-poo these windows. You hear these, well, it's a female. I'm not going to shave it off. I'm just going to shave a little window off your back. That way I can do my FUE. The problem with that is now you have a loss of hair in one zone. In fact, if I take an eyebrow, I harvest very wide to minimize in case they do want to shave it close. I don't want to see that hypopigmentation. So I think that the problem, though, with these wide harvests is, look, what is our prediction? Remember I told you your ethical and judgment is so critical. Is Bruce Willis in his 30s, hey, I want that little that frontal temporal recession, FTR, corrected, right? That's easy. We can correct that. Get you back up to a beautiful Norwood 2 pattern. We won't lower it. I'm not going to lower it like weird angle. Could you predict it becomes a 7 where he's even miniaturizing his donor? Is even a strip safe for him? Probably not even a strip would have been safe for him. Certainly couldn't shave his head like this. But can you imagine these weird transplants in the front of his scalp? Could you predicted this? No. And so even my prediction is a prediction, right? We're not prophets. We don't have a perfect foretelling. And that's the problem with FUE is we don't see the problems that are going to be occurring in 10 years, in 20 years from now. We think we hit it. We did a great surgery. They look great. But in 10 years, because they're on medical therapy, their genetics are incredibly bad. We get a situation like this, and we have no options to exit. All right? And you caused it, or I caused it. All right? So the other thing to understand is total donor capacity. We think, oh, you hear these cases online. Oh my God, I have these people coming in, 6,000 grafts. They don't even have 1,000. How'd you get quoted 5,000? Well, one of my staff used to work for a big company. They cut their grafts into one hair so they can be able to. What the hell are you doing? That's unethical. Okay? Because you can have more hair grafts. I stopped charging per graft a couple years ago. That's against the grain. Because people come like, how many grafts do I have? Did you ask me 3 hair grafts I had versus 1 hair grafts versus 2 hair grafts? How about if you have great color contrast ratio? All these things. Did you ask me that? No, you just want a number because men are obsessed with numbers, right? I said, look, I'm not going to tell you numbers. You know what I did? I safely harvested so that I don't hurt your donor, predicting what's happening in 20 years, and what I did for the front. That's how I charge. You pay me for artistry, safety. That's it. You don't pay me for a graft number. Get that out of your head. All right? Get the graft counts out of your head right now. What are total donor capacity? So here's the issue with total donor capacity is that strips, I can get a little higher. And this is a range. I could get more than this or fewer than this. Probably not often more than this, but I could. But the problem with FUE, in my opinion, here's against the grain, okay? Someone's going to shoot me probably watching this video. There are not that many, I struggle by the second round FUE, and I insanely struggle by round 3. There are not that many grafts that are available if you don't want to overharvest, okay? And this is the problem today with FUEs. People, if it I just put some tattoo back here, some SMP. No, you can't do that. I have to do that sometimes because I see what walks through my office and they're destroyed. Yeah, you want to destroy a few patients and then throw some ink on it. Great, I offer SMP. It's not ethical, it's not appropriate. You must try to save for the future, and FUE depletes the donor faster. I hate to say that it does. All right, that's against the grain, it's reality. I see these inexperienced people. This is why I should be physician driven. That's why I harvest myself for FUE or strip. This is why technicians shouldn't be doing this, in my opinion. It's not only a legal issue, it's an ethical issue of people just coming in and going, well, they don't care. Do you care? Does anyone in your staff care more than you do? I don't think so, right? You care, and I'm teaching you to care. But there's a great book I read by Danny Meyer called Setting the Table. He's a restaurateur in New York. He said, I can teach someone to set a table. I can't teach them to care about setting tables. I can't teach you to care. But the reason you're sitting 2 days here, because I already know you care. I know you're here because you're going to do the right thing for the patient. So together, you get more grafts. But here's the problem. You hear this, you go, oh, salvation. I'm going to do both procedures. I read about that. I saw Dr. Grisostomo's lecture. He's a great guy. He's a great friend of mine. And he does great work. This depletes the donor very fast. You need to think of what's in the bank. And I'm not talking about the patient's bank at Chase. I'm talking about the donor bank. That's a non-renewable, finite, dwindling source. Okay? Don't combine these. No, I do combine them, but I do those in burnout cases, and I'm very select, and that's a whole different discussion, which is not for beginners. So yes, there are many sources out there. I don't personally believe body hair works. I've heard now enough lectures on it, and I've done a couple smattering. I just don't. The new thinking for body, if there's a question people are going to raise, is that I think that the grafts don't have enough density. Their anagen phase is poor, although there can be some what's called recipient dominance, which means they grow a bit faster. But they've actually looked at some long-term studies that oftentimes those die out in about 8 to 10 years. They don't know why. So I would focus, even if you're advanced, to work on beard eventually. And scalp. That's a question that's naturally come up, so I'm going to address it right now. I want this to be seared into your brain. This is the state of the problem. This is where we are today. This is the disaster. Over-harvesting. I'm going to repeat this. This is the disaster. Over-harvesting. I'm going to repeat this. This is the disaster. Over-harvesting. This is what when I'm harvesting with FUE, I'm thinking every harvest I make, am I going to over-harvest this? All right? I'm 20 years of practice now. I've been doing FUE only for a few years because it's a newer technology. But I'll be honest with you, as I think, am I going to over-harvest? When you get this, you have no exit. Okay? Don't think S&P is your nice backup. Oh, I can just screw this up and put something on it. You can't do it because what's happening down the line? They have no exit. They have no exit. This is the take-home slide. Don't do this to a patient. Okay? So to me, there's a role for both. There's an incredible role for both. So here's a quick slide to show you this. It's very confusing. But let me think. Here's the thing. The older you are, that strip heals better. Okay? If you're dealing with a 30-year-old, it doesn't heal as well as a 50-year-old. And the second thing is, if they have look at my bad shingle, it sticks out like this. They can't hide my scar. But then that bad shingle also predisposes you to over-harvesting. So there are a lot of pros and cons of this. And so I'll be honest with you, with women, I'll strip all day long. I don't do FUE, I'm sorry. And half my business is for females. So how could that be so high percentage? Because I cater to women. I do things that people don't do out there. And so it also high contrast. Black hair, white scalp, higher risk of seeing that scar. Take a young patient, that's a high risk. You take an older patient, white hair, white scalp, 55 years old. Are you kidding me? Strip all day long for that person. Okay? So who are the ideal cases? Women. Why are women ideal cases? Well, when they don't have to shave anything. I don't believe in windows. You say, well, I've heard this fancy non-shave technique, Dr. Lamb. That's what I want to do. Yeah, you want the patient lying there 2 days trying to harvest off them, and guess what you still do? You thin out the density back here. Do women want to do that? No. The strip, there's no thinning of density. And you're taking off the perfect occiput right where it counts. All right? Now, if they have big keloid history, okay, probably not. But then FUE can still cause it. So there are not a lot of good exits on that. But I will tell you, women are ideal for strip. That's just hands down. Extensive baldness. I talked about supply and demand. Think about this for a moment. My God, this is a strip. But not in a 20-year-old because that's going to start evolving. But if I got a 50-year-old guy that looks like this, if they're going to wear their hair longer, I'm going to do a strip all day long on this. And I mean, I still may not touch the crown because the crown is the risk. Why is the crown the risk? Because pi r squared. We'll talk about this more in the crown talk. But when that radius doubles, do the math on that. 2 squared is what? 4. It's 4 times the surface area. That crown is a bitch. That crown is the area where I have to take a lot of judgment on whom to operate on. It's not just, I saw Sam teach me how to do a great whirl. He told me I nailed it. It's not the design. It's the judgment. All right? And I'm going to walk you through how, like, female hairline drawing is the easiest thing. You probably won't even mess it up. It's so easy. But to make it look right is a bitch. Okay? Male hairline design is very hard to get it right. But the sight's much easier. I'll walk you through what is scary, what is not, because it's so easy to get one piece of that equation there and go, I got it. I'm going to tell you what you do get and what you don't get. That's why the lab is so important. So to me, it's a spectrum. All right? So the most confusing, to be honest with you, is a guy in the middle that I go, you know what? You can do both. And I'm going to weigh both issues for you. Like, for example, if they've got a long wall of hair, I'll show you this in my FUE talk, where it goes all the way down the nape of the neck and they have no retrograde loss, meaning no hair loss coming up. I think FUE could be better. I can more effectively take that donor down so that I can use it because I can't get down low with the strip. So so that person, I'm thinking, I have this in my book. I have like 30 consults in that book that I shot real time, 40-minute consults where I say, this donor is FUE, this donor is strip. Oh, blow your mind, this book. Yeah, make my mind. I'm just telling you this. So clinical cases, here's a guy that I did that I corrected with a strip with FUE to correct that linear scar. Here's a guy that has a bad shingle that just needs a few grafts. This is FUE all day long. Okay. Here's a young guy. FUE is great. African-American women, all day long strip. African-American males, FUE all day, because they wear their hair in different ways, and this is the best area. FUE for eyebrow and beard, sure, but then you have to make sure the color and contrast, everything match up and do well. Someone has extensive baldness, strip all day long. It's the best way to preserve that donor capacity and be able to move hair from a great SDA, and that's what makes sense to me. FUE correction using FUE makes sense. It's just bad FUE. Here is FUE corrections use of 2 bad strip procedures because he's burned out in the back, and I've been able to pull FUE to do that. This is a guy that had horrible surgery elsewhere that I used a combination of small bitemporal strips and beard FUE because they destroyed his donor. This is a slot deformity from a scalp reduction, which we'll talk about in a separate talk toward the end tomorrow, and bad 4mm plugs in the front of the scalp. This is a great bitemporal strip, beard FUE, to get that result where it wants to be. Women, all day long strip, okay? Female hairline lowering, especially with the level of temple design, you can't do that with a surgical advancement. You can't get the temples done. So this is a strip, this is a strip. And as you know, this is saying, when all you have a hammer, the world is a nail to you, right? When all you know is FUE, it's all you can give them all day long. When all you know is strips, all you can give them all day long. Well, some people are better one way or the other. It's better to counsel patients to get the best things right. This course in the book and everything is about teaching both. If you don't do both, please refer the ones out. If you think this person really should do FUE and you don't do it, get it out. If this person really needs a strip, send it out. Don't do the wrong thing for the patient and make $1. So the advantage of FUE, obviously, is that there's less noticeable scarring if you wear your hair short, especially if the shingle is poor. Psychologically, it's sexier. I'll be honest with you. Everyone knows I don't have to tell you FUE, I have to tell you strip, right? It is a fast recovery for athletes because I don't want high impact blows. We'll talk about that in the LC talk for athletes for 3 months. If high impact blows are not good, I have additional donor that I couldn't do, and it complements strip, as you saw in some of those examples, and I can cherry pick the best grafts. So a great example, you heard my FUE talk just 2 weeks ago. I did a case where I did all 1s and 2 hairs because he just is 30 years old, very limited frontal loss that needed a frame, just stabilizing medical therapy, watched him for a while, and I was able to cherry pick those 1s and 2s. That means I don't deplete his donor, and I get the ones that won't look weird as he ages, and I blend it back, and I use almost all 1s and 2s on him. And another guy, I'm using more 3s and 4s. Our natural tendency when we do FUE is to take the best grafts, and we were naturally going to deplete it. We'll talk about that in the future talk. And there's less pain with an FUE, but I'm going to show you some cool methods, if you don't know this, I invented this, of how to take a strip scar pain down from higher to almost 0. Okay, this should be very low discomfort afterwards. So advantage of the strip, no shave. You got a rock star with long hair, come on, you can do FUE with the guy. Good luck, have fun. Better preservation of thickness of donor hair, easier social recovery because the sutures are hidden from the day one they walk out. Increased donor capacity in the right patient. It can be combined with FUE, and it remains better within the same donor area. So when you see a sea of people out there, and if you only offer FUE, that's all you can do. So the summary here is understand the pros and cons of both procedures. Understand total donor capacity. Keep that in the back of your mind whenever you look at a patient in a consultation, and understand who could be better for strip, who could be better FUE. Understand it's not it's not black and white. Sometimes it is, but there's a huge gray zone in the middle. So FUE can't solve everything. And I think the future of the strip, which is dying right now, is up to you to understand the role of it. Again, send it to the surgeon if you can't do it. If you think this is a better procedure for them. Okay, so operative setup and time flow. This came about because people don't see the big picture. In St. Louis, I got a criticism to say, okay, I see all these little details of hairline design, but I don't even know how you structure the day. So this is a big picture understanding. So operative setup. I used to do this in a smaller room, and you can do a smaller room if you're doing FUE only. With a strip procedure, I need the room, so it's almost double the size that I have now. It allows me not the elbow room to work. And these are just rough guides. You know, this is all in the book as well, and you're getting a copy of the video. So you need room to work. I need a big table, back table. I used to use Midmark, you know, fancy ones. You can use even built-in cabinetry. It should be fine. It doesn't really matter. I work in a joint commission accredited facility, so I've got a lot of things. I've got suctioning with a triple linear device. You'll see you can use a portable suction, but it's great to have it wall mounted if you're especially building your own center. I have a hot landline to go out to 911 or any other issues. I've got monitoring because I do intravenous sedation with Versafental. We'll talk about that. You don't, to do that, you really need to have a center that's accredited. So I'm going to give you some alternative ways, so don't worry in the anesthesia talk. This is a great chair. Again, no affiliations. I don't have to say that every time I mention the brand, but I'll mention the COI when it's relevant. It's not that expensive. It has all the things that you need for FUE and strip. So it has a headrest that's not in your way. It can be converted to a headrest. You can put the patient down prone. Everything's controlled by foot or by hand. I never use a hand. You need to have something controlled by foot, and you need to change the armrest out so the patient can be prone. So this is a really good one. Padding and coverage. Just make sure you have enough so the patients are comfortable. Patient comfort is so critical during a procedure. And I like overhead lights. FUE is the only exception where I have a xenon light to harvest, but everything else I use overhead. And you want this. You see that weird track bar up there? It's actually a mistake because it wasn't low enough. So what I would do is measure from fullest length down. Okay, maybe with a little bit of latitude, with the patient fully supine. Is that light reaching long enough to hit it? Because you don't want to measure it with the patient sitting down, because if they're prone, supine, making recipient sights, your chair is lower. You want those lights to be long enough to reach down all the way. That was the mistake I made in this, so that's important. And these are great lights I use. People want to know what brands I use, and that's what I use. Rotating stools. Basically, the key with this, I don't care if you use a saddle or not. I don't like them. You want to have a foot adjust for height, especially with FUE, but even with recipient sights, you don't want to just adjust the patient's bed. Sometimes they're out of it, and you just want to move yourself up a little bit. You just tap on that little ring you see on the one most closest to you, and it can move the chair up and down. And that's a nice little bonus. From the instrument side of things, different razors that you can use. I basically use a number 2 guard when I'm doing a strip procedure. You'll hear that again when I do that lecture. Why is that? It allows the hair shaft to be about 5 to 6 millimeters, and you can see the exit hair curl. Because if you put the grafts in the wrong direction of the hair curl, it won't come out well. You say, well, wait a second, how do you do FUE? FUE, I use a 0 guard, but I use a disposable for that because sometimes in the middle of it there's not shaved low enough. I don't want to have blood over it, so I just use a disposable for FUE. The other one I use something that I can sterilize the top of it. And then if you look at an FUE, and I'm talking about this in my FUE talk again, is that the epidermal cap will tell you which direction. Okay, and you'll see it better in that talk. This is all in the book. You're not going to remember any of this anyway, so for me to tell you everything on this table is just going to drive you crazy. But suffice it to understand some key elements. I've got a spray bottle. I've got some of the donor tumescence back there. I've got my recipient side instruments. I've got all the anesthesia that I'm going to be using. So what I do is I have a Mayo stand and I've got a back table. The Mayo stand is everything I need to use right then, and the back table is everything that's not going to clutter me as I'm doing it. For example, if I'm doing a ring block and a nerve block with lidocaine, I don't want all my marking there. I don't want to get confused. If I'm going to put in donor tumescence, I don't want my recipient tumescence. I don't want it on the back table. And my staff know during time procedure when to move them onto the Mayo stand. That keeps it clear. So back table for things I'm not using yet, the Mayo stand for things I'm about to use. So this is just showing you FUE. It just has very similar, except obviously nothing to do with a strip procedure. And then the Mayo stand for the start of my procedure for the strip, and Mayo stand for the start of the FUE for that. So the Mayo stand, that's another Mayo stand. So PRP, I use Angel system. I'm not married to any system, to be honest with you. I've done every system out there, and I think they all sort of work. I don't really do a lot of PRP anymore as a standalone, as you heard why before. Time flow, so the day before, my staff comes in, they mop the floors, they wipe down everything, make sure it's ready to go, and then the room is clean, no one can go in there and mess with it. I use underpads on all the tables, are all lined, you saw that in the previous slide. I put this barrier film on all the, on everything ready to go. I have all my split sheets on the tables, and they're all covered for the day. Everything is pulled for me, the room is closed, not entered, and it takes about 20 minutes or so to do this, or longer if you don't have if you're not experienced. So I usually do it the afternoon before the procedure for the next morning. So this is a quick overview of how I do it. So with this, there's prep time, we'll go into more detail with that. And then so the easiest thing for a strip is I harvest first, and then I make my sites, and then the grafts are placed. But the FUE is the exact opposite. Why is this logistically? So I'm going to tell you how I do it. It's not how you should do it. When you're doing a strip, it's going to take a lot of dissection time. All right. So I want as much time for my staff to be working on it. So I want that strip out and starting to dissect. That's the first thing I get out there. I guesstimate my strip because no one's going to complain you gave too many grafts. No one's going to complain I didn't get enough. So I look and go, this is my SDA. This is what I can pull safely. I think I can get this much. I'm going to 2 ways to do it. The way that maybe you start is use a densitometer. We'll talk about that in a subsequent talk. And you look and you go, I got 70 fluid per square centimeter. I need this number of grafts over this. I don't do that. I guestimate it. I give my staff. They calculate it. I'll show you both methods of doing this on the right lecture. So don't worry. I'm just giving you an overview. So that's why I do the strip first. With FUE, it's risk of what? Over harvesting. And why should I go and spend another hour and a half harvesting when I don't want to do that? So what I do is I first design it and I go, I need 1,500 grafts. I need 2,000 grafts. And then I go back and I plan what I harvest based on that number. I'll teach you how to do that in the FUE talk. Okay? I'll give you all of the details. So don't worry. This is an overview of why I do what I do, and it may not work for you. Okay? So I prep get the PRP out. Why get the PRP out first? Because the idea is that when there's inflammation already being caused, the PRP won't be all the growth factors. You want to get that out of your body first and foremost. I spend the time when the patient's still awake, design the hairline, go back and forth, make sure they're happy, make sure I'm happy, review all the case. Then I hit them with the anesthesia. Then of course I harvest and close for the strip. Whereas I'm doing a few test grafts with the FUE, making sure that they're the right length. So that way when I make my sites, I don't go, oh wait, none of the grafts fit. And then whereas on the strip, after I've closed, I make a few test sites, and then they work, and then I make my design. Okay? And then the grafts are placed. So here's a breakdown in more detail of all this here. So basically the timestamps here, I don't do all the PRP, put the IV, they do everything. I'll come in and draw the hairline. And that's our first lab today of how to do a hairline. It's going to be a lot harder than you think, all right? It looks darn easy. I'm going to make it seem so easy in my lecture, and then it's always going to be impossible. But like my sister, I'm an artist, and my sister tried to do some oil painting. She goes, I can't do it. I'm going to go back to acrylic. I said, no! The first time you harvest FUE, you're going to want to rip your hair out, okay? The first time you do a strip, you want to kill yourself. Don't stop, all right? So understand the hairline, I'll give you the semantics and mechanics, and then I'm going to teach you really how to do it when we're in lab. That's when you're going to learn it, not in these lectures. Anyway, so then the donor's prepared sedation is given. I'll give a whole anesthesia talk, so don't worry about that. This is an overview lecture. Then I do the donor harvesting enclosure. You can see all these times, and one thing I want to warn you is these times are someone doing this for 20 years. You and your staff, what I'm going to teach you with a strip, for example, harvest a small strip first. If that takes them all day, you're done for the day, okay? Don't take a 30-centimeter strip out, and your staff is bleeding, your eyes are bleeding, and you're there till midnight, and you got a strip dying. Take 5 centimeters out, all right? Let them start cutting on it. What if you did both FUE and strip? Okay, whatever, but just start small. Don't promise I'm going to do 3,000 grafts, so I don't promise grafts. I'm going to do 3,000 FUE, I'm going to do it. Stop doing that. Just do small. Start small, okay? And then I do the sites, and then the grafts are placed. On the FUE side of things, It's similar. This is just breaking down. So the only difference is I do the sites first after I test, make sure that the grafts fit, and then I make my sites, and then I plan the donor harvesting. Again, there'll be a whole lecture on that. In fact, I even teach you in lab how to mark out the donor. No one has done this. It's in my book, it's in my lectures, it's in my lab. It will be unique. I've edited a 64-chapter book, and I realized I don't even teach you how to mark a patient. Dear God, that's an error after a 4-year project. So this new book will teach you how to do it, and I'll teach you in lab, and we'll film that for the audience that's watching this on video. So the summary is have a bigger room than you think. Just like my mentor Ed Williams taught me, have more storage than you think. If you're building a med spa building, just think, hey, can I afford a little bit more? Build. You're going to outgrow it. The demand is there. Just build bigger. Like I wish I'd built a 320 square foot room to begin with. But I had to build it. I had to double my office because I just outpaced it. But that's okay. It's good. Good situation. Have balanced overhead lights that reach far enough. Have a chair designed for the FUE. Think about that. Stools with foot adjust I mentioned, and really understand the time flows again. It's going to be basically hairline design for both with PRP beginning of course anesthesia. Then I'm going to do harvest for the strip, recipient site graft placement. Opposite for FUE, it's recipient site followed by harvest followed by graft placement. Again, that's how I do it. Again, for this lecture, it looks easier than it is. You will have a hard time. And I will be honest with you, when I taught this in St. Louis, I was shocked. Someone nailed the hairline. Like, wow, everything perfect, like flawless. I wanted to see if it was a fluke. I wiped off the hairline and had them redraw the hairline again on the same patient. Totally screwed up. So that was luck. So I learned one thing. It's not easy, okay? It takes years of judgment to see. It took me 5 years to see when a result was unnatural. So how the heck can you, because you learn, you see. I was on a cruise in 2021 with my wife and my parents. I saw a guy that was worth a lot of money. He had a hair system on. It was not well kept. It was slanted sideways. I saw multiple scars in the back. His temples didn't match. He had a transplant. His temples didn't look right. And I asked my wife, could she see it? She says, no. I asked my parents, could you see any of it? I just said, no. You don't have, if you guys, I'll be honest with you, have no idea to see this. And what you're treating, so when patients ask me, don't tell me why I look natural, I'll say my goal is not if your friends think you look natural, it's if I think you look natural, okay? So understand that that's the goal, is you'll develop the eye. You won't have it after today. You have to be in practice, in my opinion, at least 5 years to see what I see, maybe 10. But you will, don't just stick with it. You'll develop that. You know, whatever industry, whatever line of field of medicine you're in, you know what I'm saying, right? What happened your first 5 years in practice? Now you're like, God, how did I miss that, right? Am I wrong? That's the same thing with hair. But just don't give up. It's a lifelong pleasure. You're going to go through some difficult times, all right? All right. So hairline. Hairline, there are two hairlines. Well, there are many hairlines, but we'll talk about anterior hairline. I'm just going to call it hairline, all right? And temporal hairline. Where's the dividing point? Lateral canthus. So how do I decide that? It's a 3-dimensional plane. I've got to make it 2-dimensional. I put my, you'll see this in the slide in the lab. I just roll it up, and that's lateral canthus. Close one eye, look at it. That's the limit of your hairline. Why does the hair system sometimes look bad? Because the hairline was too wide. Okay, because that's a toupee that's sitting up wide. Or you designed it wrong. Understand that division of lateral canthus is sacrosanct, all right? That's why a comb over looks wrong, because you're taking temporal-borne hair and moving it midline. It doesn't look right. So understand the lateral canthus transition between the two. Don't worry about all those other details in the slide. Just know that. Rule of thirds, do I use it? Occasionally. It's good to know. Da Vinci rule of thirds, you know, I sometimes take a pen and go like this and just to check my work. It's not how I measure it. It's good to know it. It's not how I do it. How do I do it? So how do I start? First thing you got to do is the CAP, central anterior point. This point is how the whole hairline hangs. It's the number one point you've got to define where you want to start, okay? How do you decide that? Well, a great way to start is a single point. Remember what I said, the head like a box, there's a vertical and horizontal plane. So that 45-degree intersection is the lowest acceptable point. Even if your friend has a hairline that sits on the forehead, you go, look, Sam, I saw my friend has a hairline down here. Why are you saying it's unnatural? Well, some people have hairs that grow on the forehead. But you should never design that, okay? Because you're balding. You shouldn't design that. Women, yeah, okay, you can go a little, whatever. But for men, no. This is the lowest acceptable point. From this point, you can go higher. You can't go lower, all right? Why would you go higher? Limited supply. Why should you not go higher? Because the number one reason, besides safety, of designing a hairline is to give an aesthetic result. You have a hairline way back here, it doesn't look attractive. But if that's all they got in terms of donor, yeah, you should do that. Because what happens when you pull this wave low? You have to pull the temple way over here. You may not have donor do that. It'll look weird. You have this hairline sitting here, no temple, because I told you, lowest acceptable, let's do this. These have got to match. We'll talk about that. Don't worry. We have slides and everything I'm telling you. But I'm introducing concepts that we'll present it later. So that's a starting point. In lab, that's the first point we're going to design, okay? And you'll see, when I design a hairline, you'll see I struggle with it. And I do that. In the morning, I spend 15 minutes thinking, rethinking. Great examples a guy did on Wednesday before coming here. I drew his hairline, and it looked off in the mirror. I said, why is, and I can't be lower. It doesn't look right. I don't even want to commit to drawing this lower, because it's not going to look right. Why is this off? And I was screaming in my head. And I kept on looking, his right temple is more receded. It skewed it off. So I rebuilt his right temple, and all of a sudden the hairline went straight. That's a subtlety that takes you a long time to see. So I'm 20 years in practice. I couldn't figure out why my hairline was wrong. Usually I can just tell because I actually am off. I just need to redo it because the mirror tells me a gauge. But I was off, and I couldn't figure out why. It took me about 5 minutes of struggling to figure out why my brain not telling me what's right. The second point you're going to do is the lateral termini, which is the lateral canthus, okay? Where do you set those? We're going to make this more refined knowledge. So check for symmetry. You want to the best thing to do, in my opinion, is draw the 3 points. And before you draw the line in, the natural temptation is get that line on the head first. No. For me, yes. But for you, no. I want you to get the 3 points in. And then I want you to mentally draw that line in and look to the top. Look for symmetry. You can use a ruler if you need to. Look on the side. I'm going to teach you what that is in the next slide. The angle. I want to teach you all the angles. And when you're pretty 80% happy with it, you can even take the mirror and then think of it, conceptualize, then draw the line in. Because you're going to be wiping off, right? It's going to look bad. It's going to take you 10 times longer. So get the 3 points, get pretty happy with the points, and then draw the line in, okay? The lateral side, this side view is critical. I've taught this for 14 years, and I will tell you, half of you or all of you will make this mistake because you don't check the side view. Check the side view. Why? Because most times it's like this. It's flat. Conservatively, you can go higher, especially if you're starting out. Do not down tilt it. Down tilting it is a prepubescent, not even Norwood 1. It's pre-Norwood 1. It doesn't exist on the Norwood scales. Norwood 0, okay? It's a female hairline. You do not want to down tilt it, okay? That lateral view, I'm going to scorch the important points in your brain. Look from the profile view. If you don't check the profile, you missed it, all right? Take those two, before you draw the line in, have those 2 points. If this is the nose, if your points look like this, why draw the line in? Does that make sense? Then you have to draw the line in. You already know the points have got to be like this or higher, okay? And then look, some hairline designs, this is just esoteric a little bit. It's either rounded for like an Asian, okay? African Americans a little straighter, and then there's more suppression in other types. And look at the scalp. That's part of the fun thing. If they've got a very long, narrow scalp, you may want to make it a little bit wider to make the face not look so narrow, but not so wide that it doesn't match the face. You know, if they've got a very wide face, maybe you make it a little bit narrow, but not so narrow that it doesn't match the face. And this is the art of design. Like I had a lady that said, hey, I want a hairline that's right here. I go, that's going to make you look wide. You have already a wide lower face. You lower the hairline down here, it's going to look weird. Does that make sense? You have this narrow little forehead because she wants it, and she's got a big jawline. I said, no, I want to narrow your face. So to match this, we'll use a rule of thirds, we'll look at this and see how it's going to work. So that's the artistry. So the key with this is that the temple and the temple and the frontal hairline unzip. All right, what that means is, as this goes back, the temple goes back. Now, I'll be honest with you, when we redesign in Norwood 2 here, sometimes we just don't have the graphs to get this exactly right, and I can tell someone's had a transplant because it's not quite matched, but only I can tell. And so I told you, hey, you should do it where you can tell. Yeah, but there are some rules of cheating, okay, where you look and I go, you know what, I just can't get a temple. No one's going to tell but me, but I got to get the frame good enough that he looks better. So I just won't build a temple up as high. But there's also where that front just is sitting way out here, and they've got no temple here, and it looks crazy, okay? So that's, how do you decide that? This textbook is the first time I'm presenting this in lecture, so this slide doesn't exist before. These beautiful images are from Mason, so I'm going to teach you this. This is going to be confusing, so we'll see in the lab. How do you decide upper temple? So the key is don't design a low temple. It won't look right in your hands, all right? It will not look right. But the upper temple, you sometimes have to do it. If you want a decent hairline, where it stops, you got to design a little upper temple. Otherwise, it's not going to look right. But the upper temple is a little more forgiving in terms of recipient side design. So how do you decide this? So here's how you decide it. First time I'm presenting this information. It's pretty cool to me. So here's how you decide it. Remember I told you to decide this point. We're going to decide the lateral side points here. So sometimes it sits in front of that temporal recession, right? And then you go, oh, if it sits here, let's say it sits here, I want the hairline to end here. I've got to build up a temple, right? Because I can't draw the hairline to go farther than the lateral canthus. I've got to build some upper temple. How do you decide when to build an upper temple versus just positioning it farther back? So if I've got a hairline that I think really works, that I think is aesthetically pleasing, then what I do is I draw, you see that line on the right, that it's from the back of the sideburn. That's basically a definition of sort of a 2 to a 3, and I want a 2, right? So interior that line is a 2, in front behind that line is a 3. I aesthetically want a 2. So I'm going to draw that line from the front of the, so the back of the sideburn, which is about 2 centimeters in front of the anterior external auditory canal, and we'll draw that line up, and that's my ideal point, all right? And that's going to tell me if I should design that upper temple. We'll show it in lab. It's very difficult to explain this intuitively or understand this even logically, but so what I want is to see, is this match this? Because if I draw this and I put it way back here, it's going to look like a hair system because it's going to be too far forward, and that's called the lid effect, which means this thing sits much farther than where the temple sits, okay? It's better to understand this in person. We're going to do it in the lab. Step-by-step design, how do we do it? So execution, I first draw what I think aesthetically will look good for him at the shingle point. And then I take that, how do I define the lateral canthus? I'm going to run it up. And that's very easy. So it takes a three-dimensional plane, and I roll it up like this. Okay, that helps me understand where that lateral position is. And I try to match to see if it works. And then you can take, just hold it in the midline and just either measure the distance. Just look, are these two, I see this, I've taught this for so many years, I see that these 2 points initially look good, and you tilt their head down, it looks like this. Guess what? I just made that mistake a month ago. Oh, wow, wait a second. It's off by a centimeter. So I cross-check my work. So fix it. And check, put a paper ruler. We have rulers for you. We'll just measure, is it the same length? One side could be 3 centimeters more because you're just starting and you don't know that it is. And then what do I say? Check the side angle, all right? So the side angle, is it tilted down? This one is tilted, it's pretty straight, maybe up a little bit, but you don't want it tilting down, okay? And then this is something I don't really use anymore, but I brought 2 of them so that you guys can play with this. The laser is another way to conceptualize a line and make sure, sort of like you think about building a house, if you want to use levelers, it gives you a good idea of how to draw that line. It's not perfect, and your line will be too straight or too round, but it'll give you a great way to conceptualize the hairline. So I have one of these. They're like $100 from India. They're supposed to be a vendor here. They couldn't make it, but if you want that information, I'm sure we can get you that, how to purchase one of these. And then here's the trick. Check early with the mirror. Don't draw a hairline and wait 20 minutes and realize you're totally lopsided. Why would you be lopsided? Why can't you see it? Even I can't. I miss it all the time because I call it marrying a 2D and a 3D world. So what that means is that the slope of the scalp changes the way you read the line. What the mirror does is it flattens the entire image. It allows you to see the line as a line and no longer on a curved plane. Because if you look at all of our scalps, including mine, there's more protuberance on one side or the other, and it changes the angle. I liken it to putting a stick through water. You see it refract differently. The way that the hairline looks when you look at it looks different from a mirror. So the mirror is a quick cross-check. Use the mirror early, not late. And the second thing is what you're going to find sometimes, because they don't match up exactly after you've drawn the hairline, you've drawn the mirror, neither one is exactly straight because of that principle of the scalp looking slightly off. So you're going to have to make each one 98% straight, okay? Because if you make the mirror 90% straight and the frontal view 100% straight, the patient will be upset when they look in the mirror. But you need to tell them that it's going to be not 100% straight because none of our hairlines are straight. But you don't want looking like this. You won't know that until you check the mirror. So check the mirror early, not late. And then we'll have all this. This is exactly how I do it. I use an eyebrow pencil and I erase and change it with the alcohol Q-tip. Q-tip is the best way to finesse the line. By the way, when I look in the mirror, the first thing I tell the patient is don't bother to look because I'm checking first. And also, when you hold it like this, they can't see if it's straight because they're looking at it like this. When you're ready to show it to them, you give them the mirror. They can hold it straight. I will guarantee you hold it. You're not holding it straight for them. Don't hold the mirror. You hold the mirror for yourself, and I announce, don't bother to look. It's not straight yet. I'm still looking. And then when you're ready at the end for them to cross-check, hand them the mirror. Let them hold it. That's another little pearl. Okay. So when I'm done, I check the hairline from all angles, make sure it's straight, it's consistent. You can see the angles are pretty consistent there. And then I draw in what's called the micro hairline, which will be in a subsequent talk. I just like to draw that with I use a permanent marker. You can use Gentian Violet, and I just draw in the micro irregularities in preparation for my recipient sites. It helps guide me as I do the recipient sites. And then the posterior hairline. Oh, sorry. This is a close up here. The posterior hairline is just where the back side of where my transplant will go. Ethnic difference, that's the vertex transition zone. Ethnic differences, Asians are rounder, as you know. I have a rounder head. And African Americans oftentimes are straighter, but I don't always design a straighter hairline. Because if they have so much recession, it won't match. So I'll tell them, look, I know you want a straight hairline. I can't give you one. Okay, it won't look right for you, it won't age well for you. But I know what they want. They want a straight hairline. But you can't always give it. You want to make sure it matches. And then for, other types, this is Hispanic, Middle Eastern. They're all, variations of white. So you've got sort of Asian African, and then you've got variations of white, Indo-Pakistani, and Middle Eastern and Hispanic are all sort of mixed. Of course, Hispanic is a term that's very vague because you've got the mestizo term, you got the slave trade through Cuba, which is more our Dominican Republic. There's some black, darker skin types. There's there's the indigenous Indians are more Oriental. I hate to use that term, but Asian. Those features. It's a mix. So you look and see what matches. As a pearl, if I forget with FUE, when I ask if I'm doing an FUE on African American because a curl is so strong, is I ask them what % are you black? Because if they're 50% or less, the harvest is relatively easy. If they're above that, it's African American in terms of the difficult African descent. In terms of FUE. So summary of the steps. This is a good overview. I think it's helpful to start with this central anterior point. Use a shingle point, not the rule of thirds, but you can cross-check with the rule of thirds. You're welcome to take that thing and just go, is it about right? It's a good point. Just use both. Define the lateral 3 points. Use a lateral canthus. Go find it. Get those 3 points. Figure out, do I need to draw a temple or not? You can use that point. Imagine it. Just put it on the back side of the sideburn. Go up and say, does that look good? Not look good? Do I need it? Not need it? Does it match? Is it too far forward? Get those 3 points. Cross-check it every direction before you draw the hairline in. Notice all my key points. I said 5 times. And I'll say it again in lab and say it again tomorrow. So you'll hear it again. Check for symmetry. All angles. Frontal, top down, sides. Frontal, top down, sides. Look at it. When I'm done with my hairline, I walk around the patient and I look all over. I tilt the head up and down. I'm not happy with a 1-minute hairline. It takes me 15 minutes and 20 years of experience to still draw that hairline. Okay, I'm not No. You'll see. You'll see me draw a hairline. I'll struggle. I'll say, no, I'm not quite, no. And I'll tell you why struggles are, because it's helpful for you to see it. Then complete the temporal hairline. Use a laser if you need to. Think about the shape as you design it. Adjust it, recheck, check, and show the patient at the end. So the bottom line is, get those 3 points in, and then go from there. And check for the tilt on side views, check for symmetry. All right? All right. We made up for time in the air. So, yeah, go for it.
Do you find that looking at older pictures from
No,
patients?
never helpful. Never helpful. Great question. They give it to me, I say, okay, I'll look at it. The only thing that with an exception is if they want to do a little bit of like a widow's peak, they didn't like my hairline shape, could be helpful. I always tell my patients, look, I'm defining for you the most aesthetically pleasing and safest hairline I can. Whenever I've noticed in 20 years I negotiate patients, I get a bad result because they don't know what they want. They don't know what's safe. They could be 5 years a hair surgeon, they still don't know. And I know that if I put it forward, I'm going to have a problem in 5 years. If I put it back, they won't have an aesthetic result. So the only negotiation I have with the patient is like with women, yeah, okay, women, if they want a little different shape, let's talk about it. Eyebrows. Yeah, they draw the eyebrows in, you'll hear that. They actually draw the eyebrows in. But for male hairlines, I usually don't have as much negotiation rule because I know the problem in 10 years. With women, I'm not as worried about the problem in 10 years. With men, I am acutely thinking the problem in 10 years or in 20 years. Does that make sense? It's a great question. The key with the hairline, what I always do, to be honest with you, is I always want to look at the donor. So I'll just briefly look, don't worry about shooting. I just look at the donor. He's got pretty good donor in the mid-scalp. He's got miniaturization top and bottom coming down. We'll talk more about it in a separate lab. But it gives me an idea of how aggressive can I design. So this is predicated on this. So when we look at here, what Norwood is this? So any guesstimate on this? 3. So he has enough thinning here that I would call it a 4. But it could, I usually say 3, 4. So, but you're not far off because he's still got a good frame in the front. So this wouldn't be wrong to say a 3. It wouldn't be wrong to say a 4. And sometimes that level of miniaturization gives you a little bit of hard read on it. I'm going to tilt your head up. So the key with this is when you're designing a hairline, I see people trying to draw it from all angles. No, I even saw that they were drawing hairlines like this. No, here's the deal. Get like this. Tilt up. I want you. Bam. All right, straight on. You can't draw a hairline this way. So your first thing is get the position. You're high enough, you're low enough, or tilt the head so I'm straight on. First rule, okay? Second, when I'm drawing on it, where's my CAP, center anterior point? The summary slides are up there. So first thing, I'm going to think, that's pretty good. So where's the shingle point? That's about right. You know, could you go lower? Yeah, so the shingle could be theoretically as low as this, okay? That's probably a little too low. It's somewhere probably the lowest. This is probably on the forehead. So this is probably 45 degrees. Maybe that could be acceptable. But here's the problem. When I think of this, I already know if I want to build this, I've got to build a temple point out to there. Look at that. That's crazy, crazy, crazy. There's no way. I already know that that is going to build up a hairline. Way too many grafts, especially look at his donor hair. There's no way I could do that. It would look crazy on him. I would eat up all the grafts. He would age poorly as I did this. So this would be the lowest acceptable point. Could I do this? I could. This is not unacceptable to draw that as an anterior point. However, would that give him a good frame? Well, what it's going to define whether I do this or this, I won't do this, and definitely not that, is going to be, for me, how far I have to draw the temple forward. How far do I have to draw it? When I start to draw it, it'll tell me how much I need to bring this forward. Because if I bring this forward, it's an advanced topic, and it eats up donor. So those are the two things. For you, those two have a lot of meaning.
If you had that, would you keep this the same place?
We're going to find out. That's a great question. So let's look at that point that we defined in Norwood too. So let's go ahead and define that point. How do we define it? So if you look from the side view, we define this, the posterior portion or 2 centimeters from the AC, going vertical plane up, right? Sits about here. If we put it here, he's closer to Norwood 2. All right, so let's go ahead and just do that point, just to draw it here. Now, I'm not even know if I'm in the lateral campus, I'm probably not, but I'm just trying to draw a vertical plane up. Okay, so I'll do it from this side. Don't worry about moving. I'm just going to draw it up. It's got to be in front of the horizontal plane, so it's going to be sort of up here. Okay, now let's define that. All right, so let's take a look at the frontal view. Where should I actually draw that point? So again, straight on. We're going to draw it like here. So it's somewhere around here. Okay, and we'll draw this one here. Somewhere here. So where's that line? So see, I'm pretty close to that line. So this line is an intersection of those two. That's where we define it. So now the question is, do all these match? Where would I have to build this if I do this? Well, here, I have to build a lot of temple here. Do you see this? Because honestly, to put it here, it's not just an upper temple. I almost have to build that whole temple up. Does that make sense? It's a lot of temple to build up, especially when you're starting out. Because look, this is the temple. That's that line. That's the best line I can get in Norwood 2, is to bring it here. But is that going to be a good, well, it doesn't take a lot of grafts. For me, I would probably do it because I can easily do that. For you, that's, to me, maybe too much temple. Does that make sense? Now, where do these 3 points line up? So let's not draw it in yet. We're still, remember, these two I'm going to say bye-bye to. So we got two, these are the 3 points that we could propose, here, here, and here. Well, if we look at it from a side view, what's the problem with that? That's right. It tilts like a female hairline. So that's already a problem, right? So we can just cross-check the other side. That actually looks pretty straight. So that's actually more acceptable. But somehow the two are not exactly aligned. So why is that the case? Let's look here and cross-check it now. Pretty similar. So there's different levels of recession too. So what we're going to do is we're going to look at this and go, what can we do to make this? I would say, now when we get the 3 points, this is part of the artistry of just thinking about this. When my gestalt is somewhere between the two, I would say probably around there. Now let's just draw this in. So I'm going to draw this in, and I don't want this down tilted. So for you, what I would do is readjust those points. So I'm going to draw this in, like this. And to me, this is a great hairline because it gives him a better frame than he has right now because this is weaker. It gives him a good frame, but it's so conservative that I don't have to do a lot of temple on him. And so maybe we look at this and say, you know what? Let's just do that. Let's just cheat a little bit and get into this upper. That way it's a little more balanced, and let's do this side. Now he's more receded here. He needs a little more temple. I think I'm doing a little more temple here. So I'm just drawing this in. So to me, I've cut the difference, and I think it looks pretty good, but it may not be symmetric. So if you look, this one curves that one, this one curves backwards. It's not quite symmetric, all right? But I've got a general position that makes me sort of happy. So we're going to do this, and before I even get to that, because I already can see this is not right. You can see this curves like this, and this goes straight. All right, so if you already see it's off, before you get to the mirror, I'm just going to go and fix this. So which one do I like more? To be honest with you, I like to recede it more. I like this rounder, so I'm going to go and make this one a little rounder going this way, and try to adjust it up. And of course, I'm just going to cross-check that it looks pretty symmetric from the down view, and then the slope, we'll check that again too. But I'm going to recurve this up to match the other side. So look at the shape and angle, and your brain already makes an adjustment for it. So I think that's pretty good. So I'm going to go take the mirror now. Let's grab a mirror for me. So this is as fast as my hairline before. I got to see if this looks off. So if I'm looking at this, he's too high here. This is still too flat. This point sits higher than this point, and the curve is off. So what I do, from this I look, and I see, I'm going to let you all see this first. When you look at it from the frontal view, you can see that it actually looks sort of symmetric, but this gives me immediate read that I'm off. All right? So when I'm off, yeah, you guys want to come through? When I'm off, all right, I have to decide which one I like better. And I'm going to say, because I'm being conservative and careful, I like the one that slopes higher. So my problem with this is if I make this look like this, I'm going to drag that temple point too far forward. Does that make sense? So I'm now limited because that's telling me, hey, I don't want to build a large temple point. Now, for me, I probably would. For you, I'm thinking like what I would do for you. I would say let's make it more conservative of the two sides, the one that slopes back. Well, I already made an adjustment because I can already see that I messed up, because what you're going to see is going to be very hard when you start drawing hairlines. You're going to see the natural asymmetry of the hair loss, and you're going to follow it. All of you will do this, okay? But you have to pretend he's shaved bald because you're naturally going to follow his contour, and that's going to, so it throws me off. 20 years of practice, I'm thrown off by it. So this is an example where I think I would rather fit this model than this model. Okay, I need to go up a little bit here. I need to reslope that one side. I make little marks, sort of like a tailor would make little tick marks. So when I come back over here, I can think about what I don't like about it. So I don't use this anymore, but I think it's great to buy one of these as they're not expensive, and it just gives you, and for females you could even do that if you wanted to look for symmetry. But you can look at this. You can see that the symmetry may be a little off, but here, look. I can cheat. So it doesn't give me that much information. My eye is better than the laser, but the laser is still helpful for you guys starting out. So it's an inexpensive thing to purchase.
You don't mind about the tip,
No, that's a female design. You don't want that on a male. So we have a Q-tip with alcohol. So I know that this needs to slope back more, so I'm going to bring this forward. I'm going to bring this back. Does that make sense? So that will give me the slope I'm wanting, and this looks too blunted. So I'm going to make those adjustments and see how that looks. Do you see how I just sloped that back? So I saw it was in the mirror, and I've moved this down and moved that up. So pretty close. Pretty close. The angles look pretty close. And so I haven't eaten up a lot of temple. Very conservative design. This will give them a good frame and won't exhaust my hair. So I'm going to come back. If you look at this, I've got to bring this back because take a look, see if you can walk through it and see that I've got to bring the left back. This temple is so far back on the right that I've got to build, in order for that to look better, I've got to build a huge temple on the right. And that's going to be too big for you guys.
So
you see that?
bring the left back more?
To match the recession. Right, exactly. Does that make sense? Because that's my limiting factor here, is that right recession is so far back that it's skewing it. And so I've got to bring the left back a little bit. Otherwise, I could bring the right forward, but it's going to take too many grafts to bring the right temple forward. So this is that subtlety, and this is an advanced thing, but hairlines are advanced. You can't just learn the 3 points and try to go from there. So I'm going to come back and look at this. If I build it, bring this forward, I have to build a huge temple, okay? And the problem is with this temple, now I could do it, he could benefit from it, but you guys building this temple, you're not going to make it look natural. And you're going to run out of donor hair because look, he's already retrograde thinning here. If you build a huge wall of hair here, will it match this? It won't match. And it's very tough. And there's so many factors in hairline that I'm trying to teach you. It's not just by drawing a line. It's about donor supply, age, degree of loss, medical, all those things, and asymmetry. This is a great example of a little bit of asymmetry where I'm looking at this, and here's what's interesting. When I look at this, they're about the same recession. I mean, to move this back may or may not be the trick. So I'm going to bring this back a little bit and see how that looks. I'm going to make sure we're on loud canthus, always checking, and we are. So I want to bring this back this way, not out this way or in this way. So I'm going to bring this a little bit farther back and see if that changes in my temple, and just see how that changes my read on the situation. And it may not be good. We'll see. So it's still pretty close, okay? But I've just brought this back. I'm going to see if that changes my read. So overall, it's much better. I don't like the shape right here. It's not quite. It looks weird, kinked up. I've got to change that. So take a look. To me, it's much better, more symmetric, but the shape is a little off right there. It's a little kinked. But you see how by doing that, it doesn't look as flagrantly lopsided? It's because I adjusted for asymmetric temporal recession, all right? You got to get right on it to see it. Yeah, right. That's exactly it, right. So you see the shape is a little off, but the symmetry doesn't look as bad because I've adjusted for his temporal recession, and I've been on the more conservative side. So when you guys are having an asymmetric hairline, you're debating which side looks better. For a moment, also think which side is safer. Okay, which side do I have to build a massive temple to make that adjustment? Well, that's the wrong side for you guys. For me, it may or may not be the wrong side. Does that make sense? So the shape is still slightly off, but the symmetry is better. It's never going to be perfect. And I always go back and forth, mirror back and forth. I'm going much slower than I usually do. My brain is constantly cross-checking it. So now what I'm going to do is look at what shape bothers me, and it's this little weird bend, and I'm going to go and mark it so that my brain knows where to make the adjustment. It's somewhere here. So that way, when I look at them straight on, I know what's the problem. Sometimes the problem can be adjusted with my eraser. So it just looks like it kinks out a little bit. So I'm just going to do that and bring it in a little bit so it doesn't look so curved out there. Let me look at him straight on. It actually looks a little too high. When I look at him straight on, he actually looks more receded this way than this side. So let me see why that is. Let me just reshape this first. That may change my brain on this. So even for me, I get confused, and that's the art of doing this. So I'm going to look here. And I just think for a moment and look at it. That already changed it. It looks better just by re-angling. Let me see if I fix it from the mirror view. So I've always got to hold his head because he's still slightly off because this needs more temple, because his temple just needs a little more reconstruction, but it's pretty close. I'm looking from the frontal view again. It's pretty close, okay, it's pretty close. So let's check him down. And then what I do is at this point when I'm 98% happy, I show the patient and I hold him, let him look at it. So this is generally, and then I point out to them, I say, look, the recession here is a little bit farther back than this one, and it's driving my eye to see slight asymmetry, but I've compensated for it, so it's not going to be perfectly symmetric. It's slightly off. I can obviously erase the other lines. And then let them see this. And so of course this angle is also slightly different from this angle. I may have to bring this back a little bit. So you can see that here, this curve is slightly different from this curve. It's a little bit more concave, so I may fix that. And I'll come back and check it one more time. You see how they're slightly different? So you want these to be similar. That bend is still not quite the same as this one, and that's something I would make some minor adjustments on, and then I'll cross-check it. Then after I've done that, I come back, and it's still not quite. You see this one here is like this, and this one is close, but it's a little bit curved. So what I do is I come back and just look at it and recurve it. And the problem is the more I curve this downstroke to match, the more I've got to take temple. Again, for me, I don't mind going down a little lower. I really need you to think anything below this line is too advanced because these angles get flatter and flatter, and you'll hear that in a lecture this afternoon. So anything below this line is going to be too difficult for you as a beginner to reconstruct well. So that's when you start to push it back. So then I come back, and then at the end, you can just say right there, I walk around the patients. I literally come over here, just look, and I walk around, and I just keep on looking to see if the angles are about the same. Am I happy with the design? I think, and I walk, I look, tilt them down, I cross-check again with the mirror. And so this is not really a 2, it's still sort of a 3-ish because of, it's interesting because he doesn't have a lot of recession here. The reason is his temporal recession and his retrograde hair loss. Retrograde means that this is thinning. So if I go build this big temple, it's not going to be good. And just for the sake of completion of the discussion, as you see, the degree of miniaturization going on here really puts him in 4. Category 3 is either isolated with an isolated 4 log going forward, but he's really, I would say 3-4 to the 4. And if you see he's got retrograde here, he's got this is not where the crown ends, it ends there. And this would be a great example where FUE, I don't have a lot of grafts. And I'm worried if I harvest here in 5 years, this is going to show up. So a strip is the only way I would go with him, but it's still risky because if he couldn't shave his head very short because there's issues, look at this, where can I put a strip there? I really can't, so this is a difficult surgical case, but look, that's why I'm doing conservative transplant. Would I do transplant him? How old are you?
48.
So he's a good age. You know, we don't have to go into medical therapy, all that, but I would harvest a shorter, wider strip and go about here and try to get as far away from here. But I'm getting messed up by both directions. I'm getting a little retrograde and this. So this is a great example where I would do a strip on him. I would do a limited strip. I would not go past here. Okay. Now, why am I talking about donor? Because to be honest with you, the hairline design is predicated on this. If I have insane donor, he's got no crown issues. He is, I mean, he's really good age, but he's 60 years old and he's got insane donor that I can take. I would build a bigger temple point, not for you guys, but for him, I could be more aggressive. And him, no, I'm already predicting problems if I go do that. I can't even go that wide on this. I can't take those grafts. FUE is too tight. Strip is too tight. I've got a narrow playing field that I can take from. So that's how I plan the design. That's why, as I start to work with you on the hairline design, I just want you to get the basic design down, but I want you to understand sophistication as well. Does that help?
Yes.
Any questions about this?
What about beard?
What?
Beard.
So beard is good and bad. Look at how thick this is compared to look at the donor here. Now, look here. Look at the caliber. Put your eyes on that. Does it even look similar? It doesn't. These are, even though he's got coarser hair, right? You got coarser hair. They're much finer. And beards are all individual one-hair grafts. So if I take one-hair grafts that are coarse, that don't match in color and texture, and stick it up here, do you think it's gonna look good? It'll look like pubic hair. All right. Then you take an inexperienced person placing into it. It looks ridiculous. Beard is my salvage. So I want you to start thinking beard as a salvage. Don't think of it as a go-to. All right. It's like I'm stuck. I got nothing left. Let's do beard. How often do I do beard? Once a month. Or I do a beard to beard. I'm doing one of those in a couple weeks where I'm taking this to this. Makes sense. Beard to beard is great, but it's limited. But when you're looking at scalp, you got to make sure it matches. So what if it doesn't match? Well, if I use a fill here, I need it. Yeah, I'll fill it with that. Even if it doesn't quite match, if it's a little bit off, I'll tell them that, and I'll use it to blend in areas I just have nothing left on. But this is a salvage. This is not a and the other thing about salvage, that word is important. It's a rescue. It's not like, you know what, I've got the superhero sitting down here I can steal from. No, think of this like I don't ever want in my own patient to have to use this, because that means you messed up in your decision making. And guess what? I have had to use this in my own patients. But don't use this as a crutch. Use this as a super backup. Okay, make sense? All right. So for you guys, you have over an hour. What I'm going to do is I want you. We have 6 models. I'm going to erase this line. I want you guys to start doing this. And I'll be around to work with you. And then if you don't mind, I'm going to use you as a Socratic method and say, what's wrong with this? Nothing's wrong with it. I made 50 errors designing mine and still not 100% happy. There would have been some refinements here in terms of the lateral shape. I would have spent 5-10 minutes more fixing that, but you need the time to start drawing. Does that make sense? All right, so let's have you sit, and I'll start. Let's get everyone to have a model. So look at this summary. I'll be talking while you're getting the models to sit down. So remember, get that central anterior point. And if you've got a question before you start drawing, say, Sam, come over here. Let's look at the central anterior point together. What do you think about it? All right, you don't have to draw the whole hairline and show it to me, because part of the designing and the thinking is so critical. Let's look at this. Yeah. So is that on the vertical plane or the shingle point?
Vertical?
It's more on the vertical. So it's slightly aggressive, okay, on the design. So you see it's really on the vertical, right? Because if I do this, right, that's the easiest way for me to do it if you're trying to visualize it.
That's what I was trying to do. So.
Okay, look at that. You see it's a little higher, right? Just a little. It's not, you're millimeters away from it. Okay, so this is the point?
This came up here.
So why don't you answer yourself a question? Is it along the lateral canthal line? So straight on. Is that point along the lateral canthal line? Where's the lateral canthal? Show me. Look at this drawing. You use this. Where's your lateral canthal line? Are you on it, or are you lateral to it, or medial to it?
I'm lateral.
Insanely lateral, right? Very far lateral. So you answer your own question. You cross-check it, because there's 2 things you need to do for the most aggressive quote-unquote point. Go up that lateral point and then marry it to this. Those 2 lines must intersect. So you got one of them right, you got the other one wrong, so it's not at all right, correct? So you get those 2 points together, show it to me. Why don't you work on that, show it to me when you're done. Okay, you slope a little up, okay, which is good, or flat, you don't want it down. Now it's Frankfurt horizontal plane, so he's about Frankfurt, so you're a little up, and that's okay. You just don't want it this. And then you cross-check this way, and you look at it, and he's more or less flat, but maybe you could argue up. So are the 2 tilts the same? Let's look at it down. Looks pretty good, but let me look at this canthal position. You're pretty good, canthal position. Now with this, so the only thing, so overall you're pretty good at this. For me, my only critique, okay, so you've done a good job, and you've done this where I can build a little upper temple and be okay with it. The only critique I have is look at his face. He's got a narrow face, right? And your design is triangular. And so it makes him look longer. Can you see that? So now you've got some technical things done well. So I think you graduated from that, but don't get cocky with that, because when we switch out to another hairline, you get totally wrong, that's fine. But if I critique it, now I would make this a little bit rounder. Now would he look good with a totally round head? Not necessarily, but it looks too pointy. It's making his whole face look linear. Yes. So the suppression point usually, as a general rule, is mid-pupil, around here. So you could say, well, I need that rounder. So what I would do is maybe draw this a little bit wider. This is a little bit of a riskier donor, and but he's not so bald here that he couldn't do FUE, because so you could argue both. I could argue both ways with this. I probably would lean toward FUE for him, because what I would do is I would cherry pick the grafts that were less prone toward miniaturization, but there's risk. Whenever you see miniaturization of the donor, that's risk. Those grafts may not survive, and you may get exposure. And because his crown is, even though it's early, I would definitely get on medical therapy, but I would be cautious. And he doesn't need a lot of grafts. So when I have less risk of over-harvesting, when I've got possible some miniaturization that I've got to dance around, I may lean toward FUE for him. Does that make sense?
That's great.
Students, just take a break for 1 second. There's one major issue with his hairline. Can someone call it out? 1, 2 straight around is the question. That's not it. Anyone else? That's it. So that's the biggest issue with this, is it goes way beyond the lateral canthal line. So let me show you this. So that's important. This is the Socratic method I was talking about. So if you look, this is very natural, because what happens is we look at, as beginners, even for me, we look at his existing hairline, we think, well, we got to move it forward because he's sitting in my chair, and so we just move it forward. But the problem with this is, if you look at the lateral canthus, where does it end? It ends right here. So if you actually drew this hairline, if he wants this hairline, and Regan wants this hairline, okay, again, I'm just doing it very quickly, then the temple that he would need to build is that, okay?
And that's why I was struggling with, because
I know. And this is, of course, unacceptable. Okay, it's even for me. This is a very aggressive hairline. But that's where the hairline. You see how far the hairline is off. But it's not easy. The hairlines are not easy, because your brain conceptualizes it. But that's the number one issue. So I'm going to work with you as you start designing your hairlines. Go back to your station. But this is a great example. We said, what was even worth it for him? Well, he's thinning a little bit here. He'd probably be great on medical therapy if he's not on it, and that would help this. And before I even begin to consider a transplant for him. But if you wanted one, and how old are you?
32.
So he's young, and I would probably be very hesitant to do a surgery for him to put him in context. But let's say we're at this point here, I wouldn't lower him. This is a great example where if he were on medical therapy for 2 years, pretty stable, and he says, look, come on, I don't like how I'm seeing a little bit through here. I would do a transplant. I probably would do FUE. I would take a look at him to make that decision. Younger person, the scar would heal just slightly, not as good, and I would build a hairline somewhat like this. Is that even worth it? Absolutely, because it gives him a stronger frame in this area. And then what I would do is, where's that canthal position here? So it's somewhere over here. So remember, our goal is in Norwood 2. So how do we get this? You go to the side view, look at where side burn sits. The side burn, 2 centimeter EAC, somewhere here. So I actually just came up with a new way of teaching this, because this is new for me. I've not taught a lab with this. So I go, let's say that's the line. Okay, I put my finger there. I turn back around and I look and I see, that's the canthus. Actually, let me teach it. Hey guys, sorry to interrupt again. You know, this whole new concept with the 2 centimeters anterior, the EAC, is a new thing for the book, and I've never taught it in lab, and so I'm learning how to teach it. And I was teaching Dominique there earlier about this, and what I would do is, let's say that's your most aggressive anterior point. So I go to the side of the patient. I say, here's his back of his sideburn. I'm going to think it has to be somewhere on this line, right? So what I'm going to do is say it's somewhere on this line. I put my finger there. I'll bring him to the front, look up like this, look at where that falls on his canthus, and what I just drew fell lateral. So I'm going to move it here to touch. Does that make sense? So that means his line should be somewhere here, right? So that's how I would judge that hairline is if you don't know, should I build a temple, what should I do, is find out where the most aggressive point is from the lateral, put your finger there, turn it back to the front, see the alignment, and make those 2 points have to work. Does that make sense? Any questions, let me know. But that's a new way of teaching this. So anyways, for him, this is a very quick line. You can see I've actually skewed it off because it's too high here, but I would just show you this here. What I would do is build it like this for him. And now this is the line I would design. So he's got, well, I'm not going to build it all the way there. Does that make sense?
Yeah, it kind of just fades into where he has right there.
Yeah, and look, he's got a very strong frame. I've lowered his central anterior point. When you look at a side view, it tilts either flat or up, maybe slightly up, so it's a little more conservative design. It gives him a good frame. It doesn't go outside of there. And I'm only talking about a small distance from where you designed it, but that is a world of difference. When I look at this line, it's really not too bad. I would aesthetically do this one because when I look, he's got a wider face. Yeah. This is a very narrow design. Yeah. And when you look at this curving, it doesn't necessarily violate that. Now let's just try to visualize for a moment. If it doesn't violate the rules, which if I look at where the canthal position is, it's about right. You could bend this down a little bit and build that. So you're not using a lot of temple. He has very little recession. Yeah. Whereas the biggest issue is the central forelock. So from an aesthetic perspective, if you give him this narrow thing, it looks like a wider lower face arching into a smaller one. And this doesn't take a lot of grafts. Yeah. This is easy. I would draw the lower one. Now this one, it is a little too linear on this side. You see the difference? This curves up a little bit, and that goes almost straight. Yeah. So I would argue just curving it here would be better. Okay. But that's a great design thing, right? And in a way, his hairline is easier, but it's also harder. Yeah. But this is in general good. So I would draw this line. Now let's just look at this. Let's erase the other lines, and just because sometimes we have too many lines, we don't know what we're talking about. Right. So let's just look at one line, and then just see, does this work? So this one, somewhere between these two lines. Does that make sense? Because that line was a little too low and straight, and this line was a little too curved. So just a quick draw. Not really doing too much, but just doing a quick draw there. And so can you see how that gives him a good frame? And can you see that how where his face looks better from the width perspective, right? This is where his hairline should end. Can you see that? Should end right about there. Yeah. So he needs to build this with some upper temple, which is easy to do. So let's look at the hairline angle again. Now all of a sudden, what looked like it was tilting up because I aborted that last few millimeters, now looks about right. And I haven't used a lot. He's got great, little bit of retrograde, but this is being argumentative. He's got great temple, not worried about building. How old are you? So he's younger, but he's less like his donor. And so this is a case where I probably would lean toward FUE because it gives him more long-term options. And he's, when I see that crown starting to dip down, it starts to scare me. But he's got very early miniaturization. This is a great example where, and he's got limited grafts. I could pull from, look at, does he have retrograde here? The answer is he doesn't. He's got good grafts all the way down here. Now, being he's not 32, where I'm worried if I take it down here, he's going to retrograde and show my scars. I wouldn't go down here just to be safer. But with a strip, which is counterintuitive because I talk about strip safety, but this is a great example where I'm going to show that example with FUE. I could harvest a little lower, he has no retrograde back here, he has a little retrograde here, so I'm not going to go in there, but I could do FUE and stay farther away. He's got a limited graft count. I can pull more 1s and 2s and a few. If he has 3s, I could go lower. So a strip would be equally safe, but this would be a little safer because I get a little few more options. It's slightly on the younger side. I could pull grafts a little lower. He's got limited loss. I could able to transplant that front zone. The only area I probably would be cautious of transplanting is his crown because that could open up and cause problems, and it would take more grafts. With FUE, it takes more donor bank. So this would be a great, I would now lean toward FUE for him because I can pull lower donor bank. I can stay farther away. I can actually stay farther away in certain respects in the strip, but not entirely because with FUE, you can't just take it like that. You got to go at least up to there. Does that make sense? But I would harvest fewer grafts here because with a little miniaturization, I'm worried that that's going to come down. Stop your doing for a moment, just for a moment. I want you to just look at this line and tell me what are some of the things that you could do better. Sorry, this is what do you think is slightly off? Downsloping, one major thing, because you see this is downsloping. I don't even have to go to the side view. You can see from the side view it's downsloping. Okay, now that's a natural thing. It's not much downsloping, but it is downsloping a little bit on the edge. So this one should be a little bit farther back as that. What's the second problem? Let me take a look. Slightly, because the lateral canthal point is right here. Grab me that pencil there.
Yeah, I had marked it in.
But it's not bad. Okay, the width. I'm just doing a very quick line here. So, all right, now that I draw the point in, what else is going on? To me, there's another issue going on with it. No, actually, this one is actually pretty good. I don't think this is a bad one. So to me, it's a little asymmetric. The shapes on both sides are different. Can you see that? So just the shape of the frontal temporal recession, they're a little different on both sides, and that's the hard one. You saw that I struggled with that with the other gentleman, and the reason I was doing that was actually his level of recession. So let's look at it straight on. I'm going to look at it right here. Let's look at this. Do you see this? If this is more or less the central anterior point, what else do you see? Why do you think you're asymmetric?
Because his recession is different.
Well, forget the recession. Just look at where you drew the point. Where the point would be. If this is the lateral canthal point here, okay, and this is the lateral canthal point here. Look at it straight on.
Correct.
Tilt it down. Do you see something?
Yes. So
let's put it here. So the biggest issue is they're off axis. Do you see that? Correct. So when I look here, that's a great cross check when you're doing this. Is now with that asymmetry, look at this one. It comes back like this. This one comes forward and round. Do you see it?
Right.
You see it? So yeah. So you begin to develop the eye to see things, and that's really part of the art of this. So what would I do? So I could lower this. I could raise this. Well, with this one, as I heard from Charles, that this is curved down, and that's correct. So I need to fix this. Before I even fix it and lower this, which could be done, I need to raise this before I can think of this. So what I would do is reshape this. So if I know this is at the lateral canthal point right here, right? So what I'm going to do is I'm going to reshape this like this. Now the problem with this, to be honest with you, is where this canthal position sits, I have to build up that much temple. Can you see that? To make it not look wrong. Right, but where your hairline is, you cheated, but you can't. You see what I'm saying? So, and that's the tricky part of this. So what I would do with this is either you can move his hairline back a little bit. So there are a couple options to fix this problem. Go back a little bit and redraw it. So I know the first thing I saw was this hairline's too high. To be honest with you, this is too low. So I'm not going to adjust this lower because I need to adjust this higher. That's that concept. Should one go lower, one should go higher? You have to ask yourself before you even think about shape is which one will cause fewer problems. And then after, and usually of course is the one that's too low. But sometimes it's not the right answer. Sometimes it really is too far up and it just doesn't give a frame to the face. In his situation, this is too low and you try to cheat by bringing it down, and it's fine. But what I've got to do is, what if we go a little higher? And we know that this is the canthal point going back like this, right? So we know that this is that lateral line. So that means I'm going to have to bend it at this point. And you can draw that line. Don't be ashamed to take that line and just draw it up there and draw it up here. And that way you have a framework. Just erase it in 2 seconds. So I know that that's my lateral cavity. That means the temple's got to come down. Now that's what happens when I do this. Oh my God. Oh my God. I move it that far. I no longer have to build this temple. Do you see? So that's the trick here, is that just that few millimeters has completely shifted what I need to design. Now, and that is reading it from here. And that's why this was off, because the recession here threw you off. And when you drew it here, you just had to curve it down. And that's exactly right. What Charles said is that it's slightly off because you just fixed it by down curving it. You can't do that. Does that make sense? Yep. So is CAP, let's look at it together here, okay? Remember what I said it should be a shingle point, right? This is on the very top of the vertical plane. Can you see that? Yeah, you can see it now, right? Because when I walk by, it's the first thing I saw. And what's the first point you need to find a CAP? If your CAP is off, everything else is off. It screws you up. And that's why when you look at his design, it looks like, it's sticking out. Like it looks like a promontory coming out, right? So watch what happens when I just do this small adjust. So let's take a look at where the lowest acceptable CAP is. And that's going to be the shingle point. Again, if you can't think of that, do this. Write down your steps so your brain sees on the paper, on the back paper when the patient doesn't see this, and say, I need to find CAP. What is a CAP? Shingle point. What is a shingle point? It's a 45-degree intersection between vertical and horizontal line. Does this violate that rule? And the answer is it does. So it should be somewhere a little bit more conservative. And you say, well, God, he's barely wrong. But barely wrong is wrong, all right? So this is the lowest acceptable point. Now, if we define that right here, let's look at his other things. What's the next major issue? Let's take a look here. So this is his canthal position is good. He's done a good job here, Annie, of getting the line right. Do you see? That's so critical. You see that actually in 2 examples where that canthal point was off by even a centimeter or 2 centimeters, and that throws it off. You can be off 3 millimeters and it won't look right. And so really bang that out, make sure. So these are good, the general position. Now the question is, when I look at this, do you see something else going on? Top-down view. Did you check your top-down view? Did you check every angle? What is the biggest issue with top-down view? Yeah, that's it, right? So that's it. You need to check all your angles, because if you look down and studied it for a second, you would already know it's off. And you should be able to get that off before the line is drawn, right? So look at your CAP, look at those 3 points, because you hang your whole structure of your hairline on those 3 points. If those 3 points are off, nothing else matters. Until you nail this with symmetry and everything, you can do this and go, is it off this way or that axis? You can even do this and put a line this way and go, is it off? Whatever you need to do, okay? But this position is good. It's just, you're off, right? And then once it is off, now you look at it, can you see your asymmetry? You can see the asymmetry. Now you see it, because once that's off, it throws everything off. Now which one should we do? Should we lower it, raise it? Should we lower this or sorry, should we raise this or lower this? You know the right answer? Right, be conservative, you hear that answer. So I'm just gonna draw this quickly here. And to me, so what I'm doing is, you see how this looks drawn forward? By just raising it up, I can widen it. And so again, he's also got a wider lower face, and I don't want it to be too promontory-like, right? It won't look right for him. He needs a little more width anyways, and he's got such limited loss that he doesn't need to be conservative with the design that way. I want to get this rounder for his facial shape. So I'm just going to round it out and start at higher CAP. It's only millimeters of difference. And then I'm going to take a look again. I do this all the time. I do this all the time. It's not just I'm teaching the beginner to do this. And then I'm going to look at this point and see if this works. And for me, I would take an alcohol pad. This looks too straight. Can you see that? It looks like rounded and like this, right? So I would take my alcohol thing and just erase this part and bring it down a little bit and round it. And it still looks a little off. Can you see this? It looks like this and then it looks like that. So I need to round this. So I first get it pretty good with my frontal view, and then I come back and so I would erase this upper portion. My temptation is to go up this way just because my brain is seeing things. Now look at this. This curves up like this. So I need to round this part out. Okay. And then this part, I like this look. This looks good. I still don't like this look. So I would erase this part to make it look better. But and then I haven't even checked for symmetry, because the mirror will give me immediate feedback. I'll look at that. Overall, pretty good. He's a little too high on the side, but not bad. I would need to build this one farther forward. Sorry, I'm doing the wrong line. But I would probably need to build it a little farther forward here. Close to where that should be. My criticism is, don't draw point way too interior. So if it sits here, you ask yourself, how much is that? So the principles here of anesthesia are different for FUE and LSE, and I'm going to sort of go through that. Here's a quick summary slide. You're going to hear it about 5 times, so don't worry about memorizing this busy slide. But the basic understanding is that for the anterior portion of the head, it's very similar for strip and for FUE, because it's the same thing I'm doing in the front. There's no difference. Well, the difference is in the back. So the front is going to be a nerve block and followed by a ring block. Why each one? The nerve block gives me durability, where they don't have to be re-anesthetized at noon, and it reduces a little discomfort for the ring block, but not perfectly. The ring block provides efficacy. I'll repeat this, okay? The strip, the ring block provides really effectiveness. The tumescence, which we'll talk about more in a separate lecture, is providing a lot of benefits in terms of neurovascular protection, less bleeding, mechanical creep. We're going to go through all that. But for FUE, the backside, it's not high concentrated anesthesia, it's tumescence. If you do dilute marking in the backside, your anesthesia lasts all day. And Klein has shown that the lower the anesthetic concentration, the longer it lasts. Crazy, right? Makes no sense, but it does. And that's a great thing. You dilute marking, you think it's not going to last. It does. So that's the trick, okay? And for facial areas, it's the same FUE type of anesthesia with dilute marking. It works really well. And we're going to go through that again and again, so don't worry about it. Just as a quick intro. So I do a combination of oral sedation as well as a combination with intravenous. Again, I have a surgical center. If you have one, this is my cocktail. I have it in the new book coming out. I'm not going to go through all of it in detail. The summary basically is for strips, because they're not in a prone position, I can give them formal intravenous sedation using versus fentanyl, and they're all monitored, of course, that morning. And for FUE, I can't quite go as deep because I'm worried about airway issues. So I'm really using a demerol phenergan combination, and they're down with their head in a prone position. I will give that repeatedly over a few hours as need be if they're fidgety as I'm doing the harvesting, but they're not quite as deep as with a strip procedure. As an alternative, I have never used these, but I go to a lot of meetings and I hear a lot of stuff. This is in your notes. It's also in the textbook that's coming out, and some of my colleagues have done well with these. They report results that are as comparable to what I get with intravenous, so it gives your patients comfort, because if your patient is not comfortable, they will remember it. They'll come back another time and go, God, that was miserable. I guess I got to come back. But if they go, man, this was so easy, I'm going to go see Dr. Lamb, whatever. So you want to make your experience really favorable. So if you can't give intravenous, you want to give something that has a little bit more potency than just Valium, if you can. So as you know, there's 4 levels of anesthesia. Level 1 is basically an oral pill. Level 2 is this conscious sedation using first fentanyl. I think that when you get to level 3 and 4 is when I bring on an anesthesia provider. So I've got an anesthesiologist. Like when I do a level 3 or 4, which is propofol 3, general anesthesia 4, I have an anesthesiologist. Anything up to a 2, I use nurse sedation. Other things, I don't use this except for if I'm doing some facial procedures, but this is a thing you can think about, which is nitrous gas to help things be a little bit better. To do PRP, for example, this can help. There's actually another company, I don't know what it's called, that has a 70% one on the market versus this is 50%, so maybe a little more effective. You want to be careful with people that are women that are pregnant. It can cause miscarriages, things like that. But nitrous gas is a nice adjunct if the patient is not under enough sedation. Vibration devices, the gate theory of pain, the idea is you probably know this, is maybe pretty basic, but you just want to put some vibration proximal. Bone vibration is great, but on the jaw. Anything proximal or on bone can further do it. Sometimes patients not under heavy sedation, you can actually have them hold it. It gives them mental control if they're doing something to help. So the more vibration on 2 or 3 devices can be helpful with that. These are on Amazon for like $5, doesn't matter what you use. And then it's not a sterile procedure, it's a clean procedure, so you don't need to wear sterile gloves or sterile gowns, all this kind of stuff. It's clean. I have a patient basically wash with chlorhexidine the night before, morning of, and they're clean with some hypochlorous spray. If you don't know what that is, Microcen, Surgipro Heal, they're great little sprays. Hypochlorous acid really cleans things very effectively and it's non-toxic. But I just wear non-sterile gloves and I don't even gown up for this. So I begin with the regional nerve block. Why do I begin with it? Because the regional nerve block provides durability and reduces the discomfort of the ring block. It doesn't 100% if you don't give it 5 to 10 minutes, but it does help. You can get a little ptosis if it bleeds in the elevator. Don't panic if you see that. I see that unfortunately about 23% of my patients, they look a little bit ptotic for a few hours. It's fine. So there are 3 nerve blocks I want to teach you. Supraorbital, I think most of you know how to do it. And the trick is that it's not supratrochlear. The supratrochlear only ends at the mid-forehead, so you don't need to aim your needle superficially medial to the orbital foramen, supraorbital foramen. You just need to get the supraorbital bundle. That's going to hit your middle hairline back up to the upper occiput. For the lateral hairlines, auriculotemporal, and the temporal point is zygomatical-temporal. So we'll show each of these as we go through this. So you see this diagram here, supraorbital block is basically going all the way back to the back occiput, but it's missing the lateral hairline. So you're only going to get the midline. But where you fail durability-wise by the midday or so, it's the center, where you're going to have some failure in the centers here. So this is why to me the supraorbital is the most important block you place because it really helps minimize needing to come back anew and re-inject them in that mid area, okay, which hurts. So that's important. How do you do it? Palpate the supraorbital foramen and always withdraw. These are very near intravascular arterial issues that can cause major cardiovascular collapse, other toxicities. Always withdraw. I'm using about half a cc to 1 cc. I use 1 cc, doesn't matter. Half cc, 1 cc, 1 to 100,000 lidocaine. Always withdrawing. 30 gauge needle, just placing it right in there in that area. The auriculotemporal block, maybe something you're less familiar with. Essentially, what I'm doing it is I'm palpating just anterior. It's basically right, there's a little dip you'll feel back here. You can even sometimes feel the STA, superficial temporal arteries anterior to it. And I can show you at lunchtime. It's basically palpating that little bit of a dip, and I'm aiming it sort of supromedially in that area, and then I just inject it sort of up and in a little bit, and that blocks out the lateral hairline. It doesn't hit the lower temple. So for women, I need to do all 3. For men that I'm doing a lower temple, I need to do all 3. For just a hairline where I'm just doing that upper temple, like I showed you in lab, that just needs auriculotemporal plus a supraorbital. Does not need a zygomatical temporal. So zygomatical temporal block, which is shown in red, the zygomatical facial is in the diagram in purple. You don't need to treat that one. Essentially, what you do here, schematic, is you're going to palpate. You're going to look at the zygomatical frontal suture. Basically, that's at the lateral canthus. So you don't want to palpate it. Just look at where the lateral canthus is. That line is just go horizontally behind it, and you're going to palpate right behind the zygomatic arch coming up here, and you're going to go into the zygomatic arch and a skide underneath the bone right toward the eye. So you're going to go just with a 30 gauge half-inch needle, go right toward the face, right toward the canthus. You're going to go under the bone at the canthal horizontal line, and you're going to go straight toward the eye. Always draw back and then inject. Okay. And again, if that's any of these things are confusing to you, I'll just show it to you over lunch if it's confusing. Okay. And that's just showing you is palpating that back side of the bone area. Tumescence, I'm not going to go over it with you. It's all in your handouts. It's in the textbook. And essentially, the bottom line is that tumescence is king. It is so critical. And as I go through each of the individual lectures, I'll explain why tumescence is important, how it's important. But suffice it to say, tumescence is important. The way that I make the recipient tumescence is basically adding some dilute triamcinolone to my already pre-made mix. And the reason for the recipient tumescence, besides neurovascular protection, is this guy Abbasi out of Iran came up with this great idea that putting a little bit of dilute triamcinolone reduces your swelling rate postoperatively. And 10 years ago, I had about 75% chance of distorting swelling. I reduced that less than 5% now with this little bit of triamcinolone. It's a fantastic thing. So a few other tricks with this: 27 gauge needle to start because it's less painful for the patient, and then I use a 25 gauge when I go back and reinforce my blocks with bupivacaine, which again we'll show you. But I also use 3 cc syringes versus 10. It's just so much easier on the fingers and it's less uncomfortable on the patient. So don't do anything more than a 5. It's just, I'm getting old. It's tiring on the hand. Use 3. It's less painful for the patient. And then recipient tumescence, you just basically place that into the front for the 2 reasons I've enumerated: neurovascular protection, which again we'll cover more, and also for the postoperative edema reduction. So let's break down specifically how to do each of these things. So with the FUE, I basically along the occipital bone, along the nuchal ridge, I just put a few dots in there, and I put like a little bit of straight lidocaine 1 cc, just put a 0.2 cc's in each point so they don't feel my larger needle go through. Then I draw up my tumescence with the dilute bupivacaine lidocaine mixture I showed you, and I just raise wheels. So I'm actually just blowing up these wheels with a 3 cc. This is an older slide. I have a 10 cc syringe there, and I'm with a 25 gauge, and I just blow up these areas. And I start along that sort of occipital line because that nuchal line is really where the nerves sit, and so if you can get that blocked, it's generally a little bit more comfortable. So I sort of work from the lateral point where the nerves are in the concentration, and I work along that line medially, and I go below the line all the way to where my harvest, the lowest extent of my harvest is. And then once I've gotten that anesthetized, as you're seeing here, and I've got the line completely filled up, that's when I start going up and lateral. I'll show you a schematic of this in a second. But by doing that, this anesthesia lasts all day. It lasts all day with limited toxicity. And I'm putting in maybe 80 to 150 cc's of this, and it lasts. But I do reinforce it only because it reduces further, improves hemostasis as I'm harvesting. A little tissue turgor, I don't think it's critical for FUE harvesting, but it's nice. So I'm just going up and then finishing laterally. Now, it's going to get the whole backside anesthetized, except I'm not going to get the front as well. So remember, I did the nerve block first, then I'm doing the FUE tumescence for the back, and then I finish the ring block to complete it. So there's only a half ring block for the front. I'm just using basically standard high concentration 100,000 lidocaine with epinephrine. After I've done that, I harvest a few test grafts because there's different lengths in different areas. I want to harvest a few ones, try to measure probably the longest one that I have. That way I can make sure the grafts fit, and then I make my recipient sites. Remember, in FUE, I'm doing the sites first, and with strip I'm doing the opposite order. After I've done the recipient sites with the FUE, and I then do a nerve block reinforced with bupivacaine in the front. Remember, the backside is good to go because it's got bupivacaine already in there. The front doesn't. I put only initial lidocaine. The reason I don't put bupivacaine, it hurts. So I put a lidocaine, and then after I've done the recipient sites, it takes me about an hour or so. I have time, then I come back and reinforce with bupivacaine for the rest of the day. So I put in the 1 cc. Oh, you had a question? No. I put in the 1 cc of bupivacaine, and then I come back and reinforce 8, 10 cc's of 4% to 200,000 ring block in the front. Okay, and this is an outdated photo. I use 3 cc's and I use 25 gauge. So this is just a quick schematic. I put those little dots of 1% to 100,000 just so they don't feel the larger needle. Then I come back and I just blow it up along the occipital nerves more laterally first, and I finish the entire line. And I go down, okay, to get down to the bottom of my harvest, and then I go up like that, and then I go out. So that's how I give the FUE tumescence. Okay, let's talk about strip anesthesia. So it's the same nerve blocks in the front, and I should say nerve blocks, not ring blocks, but it's the same nerve block except I'm doing a ring block now circumferentially. So the way that I do it is I do the nerve block first, I go back to do the backside, and I do the front. The reason I do the backside first is I want a little bit more time for that front to work, and I want this to be a little more time for that to work as I come back and do that. So I do the front and the back and then the front with the ring block, and it's just 1% lidocaine. I'm putting in probably 8 to 10 per front and 8 to 10 in the front and the back. Another alternative, if your patient is a little bit more awake and they're feeling this ring block and it's more uncomfortable, is you can basically put little dots every centimeter or so with a small 32 gauge needle, put little drops of lidocaine, and then pass the needle to connect them. You can use Septicaine, which is articaine generic. It's a little less uncomfortable, provides a little bit more profound anesthesia. It has dose-dependent risk, so you don't want to use a lot of Septicaine. And I don't do this. Okay, to be honest with you. This is an alternative for those that are having too much discomfort with a standard ring block. You can just put little drops and then join those. And you can even put the vibration right at the point between those points, and it can limit the discomfort if the patient is a little bit more awake. And you can do that for the entire circumference as needed. Okay, so little droplets with smaller needle joining those dots, it can help it make it better. And then the ring block in the back, same thing. So it's a ring block all over. The tumescence, again, you're going to hear this much more detail for the strip procedure, but I want to just tell you how critical the donor tumescence is. This one, basically for strip, doesn't have the marcaine, although I may actually start trying that in there, but I use dilute lidocaine, so it provides better anesthesia. It finishes up the little bit of anesthetic that they feel from the ring block, and it has a lot of advantages. I liken it to sort of a ship over coral. If a ship is over high tide, there's no damage to the corals. If it's over low tide, there's damage to the corals. The ship is your blade, the coral is your neurovascular blood supply. So if I can push that ship or blade farther away from the underlying thing, discomfort afterwards is much less. The risk of injury back there is less. You have better healing in the back. It creates mechanical creep by splitting that open a little bit, and then it relaxes. It makes the hair follicles more straight on, so less risk of transection. A lot of benefits to tumescence. I want it tight, blanched, flat. And some people they absorb it very fast, so I'll go back and keep on adding it as we go. I don't just it's not bad. If it's bleeding too much, I go back and add a little bit more. Take your time with the harvest, and we're going to go through that as a separate lecture. And then what I do is I score it. I actually brought the multi-blade. I score it, and that scoring allows me to know exactly the width and exactly where I may add a little more tumescence in. To me, it's much more accurate to have an exact width because it's easier for graph calculation. It's easier to know that my wound is exactly the right width, not too wide, too long, because a mark is not accurate. This, I have exactly the width. So I'm just scoring the dermis. We'll do that in lab to show you this. And then I come back and add a little more additional tumescence. So then I just do the donor harvesting at this point. Again, that's going to be a whole separate lecture on how to do donor harvesting. I'm just giving you the time sequence with the anesthetic built in, so you hear that. Once I've done the harvesting and closure, I'll reinforce it with the bupivacaine block, with the nerve block, followed by the ring block, okay? And then I test the grafts to make sure they fit, and then I will make my sites. Okay, so remember the sequence again for a strip is that my sites come afterwards, and I'll talk to you about why again and how it's calculated. For beard harvest, I really like, again, the tumescence. I think the tumescence is the way to keep this anesthetized during the whole day and for the harvest. And so I put a little bleb of lidocaine, just like you heard before, and then I'm just raising blebs all the way across the midline, and I do the same thing on the other side. I like using this pressure bag. Essentially what that is I use a large 20 gauge spinal needle. Here's a little video, and after I've anesthetized the top, it's under high pressure, this dilute marcaine, and it just floods the whole area. And I like it because it's so fast and atraumatic. But I use my patients under some sedation, so if this is more uncomfortable, you may need to do little injections, but I like how... So you get like the pressure bag, you're squeezing the pressure bag is brought all the way up to a high pressure, and then it stays that way. It may go down after a few minutes, but it usually stays that way for the entire duration of the fill. And I just go back and do it from the other side. For a dental background, you'll know how to do this, but anyone not in the dental background, this will be new information. Essentially what I do is a dislobular block, so to get them, if you're doing recipient sites in the beard area, about a centimeter medial to the lateral commissure or commissure, I can get this profoundly anesthetized. And unfortunately, if you're from a medical surgical background, you don't know about this, you're going to be doing infraorbital blocks, and they hurt, and they don't work as well in the midline. So if you're trying to do these blocks and you're missing the midlines because you're not doing a dislobular block, you're doing these infraorbitals. So it's very simple. My rule is 3-4-5. Essentially what you're doing is you are basically, I put a little bit of carbocaine, 3% carbocaine plain, and that gives me a non-burning feeling, and it doesn't last long. I just put a raise on the non-attached gingiva. I can show you this in lunch. I just put a bleb in each of these quadrants. So 3, it means basically the canine, it's a third tooth over, and then below, it's between the 4th and 5th from the midline. I go between those on the unattached side just to get a bleb in there. Then I put in either Septicaine or marcaine, depending how long I want it to last, like 1 cc, and you want to hit it on the periosteum. I'm actually aiming toward the attached gingiva. If you do that, and you just raise half a cc or cc, that area is wiped out numb. Very numb, this area, for hours, okay? So it's a way to get this area anesthetized. If you're doing lip enhancement, if you're doing fillers, this will just wipe out that area and make it totally numb. If you're doing a med spa, this is incredible in terms of the anesthetic potential. I don't use marcaine, not going to be happy. What I use for them is I just put the carbocaine block in, about half a carpule each one if I'm just doing a lip enhancement. But for hair, I want it to last. I'll put one carpule, do the whole 4 quadrants, unattached gingiva, then I'll come back and reinforce it with marcaine. And this is showing you, I use all dental equipment. So this is showing you I just go unattached gingiva here, and then I aim down with either Septicaine or marcaine, and then you just really massage it and rub that area. For the, if I'm doing beard harvest, beard transplants into the face, I also do the same thing as the donor here. I just raise a very dilute marcaine, and it just makes that whole area numb. You're not going to get all these nerves anesthetized with concentrated anesthetic. There's too many nerves coming up. Temporal nerves, there's got different branches of cervical. You're not going to hit it. You want to dilute tumescence. If you're doing anything from here down or back here with FUE, don't bother with concentration. It's going to not last. Toxicity is high, and it's just not going to be good. You want to use a dilute tumescence with marcaine in the concentration you have in your notes, okay? And for eyebrows, I like to use Septicaine because it doesn't burn as much. I can use a very low amount, and it lasts really well. And because it's such a small amount, there's very low risk of toxicity. So I first hit that supraorbital block. I'll aim it up, and I'll anesthetize across it all the way. You see that the lateral portion is the lacrimal gland. You really have a hard time to anesthetize that, so it's a direct infiltration. It's one of the few cases where I'm actually directly infiltrating, and you're going to hear it again in the eyebrow lecture. But that's how I do it here. And then I like to inject the eyebrow from outside the line so it doesn't smear it, just so you see that. So summary here with anesthesia is remember the gate theory of pain. I always do progressive anesthetic blocks so there's less pain for the patient. Sedation, I think work to do what you can because patient discomfort is huge. If you can make that better, it's important. So I use selective nerve, ring, and field blocks in the way that I've described. Essentially, I do a nerve block for the front, those 3 that I talked about for better durability, it lasts all day. And I find that women's interesting. If I don't do the zygomaticrotemporal, sometime by the end of the day, even though they're pretty numb, they will actually have some soreness here. But that zygomaticrotemporal block really knocks out that soreness, even with the marcaine ring block. So I really love that. The ring block is really there for effectiveness, and for the back side, I'm using that for the strip, and the field block is really for back effectiveness for the FUE, durability, and effectiveness and toxicity. Beard, the same thing, and also the tumescence that I use, the field block, I'm using that tumescence in there for the recipient and here for the reasons I've told you about. But again, I'm going to go through that more in detail. So recipient site creation distribution, we see results that look like this that scare us. Now, this is probably a Uri flap plugs. These are obviously big formula plugs. But here's the thing. There's so many errors that occur even on a subtle level. There's a gentleman that we fixed here that you can see that he's got hairs that are traumatically inserted, look like pubic hair. Hairline is too straight, doesn't look right. These grafts have been compressed. Those grafts don't fit the site well, so they squeeze down. They look like a plug, but they're actually just normal sized grafts. They're way too big in the frontal hairline. Hairline is too straight, doesn't match the temple. And these are things that are post-plug era. So you think, well, these are all plugs. They're not. This hairline is too straight, and I'm going to talk about this in this lecture. The grafts sit up like this. They look surprised. The angle's got to be dropped down about 10 degrees to create a natural look and great comb mobility and density. And you can see this is a correction I did here. I'm not going to go through the Nord again, but I just repeat, know the Norwood. If you have a question you want me to summarize it in person with you, I'm here as a resource for 2 days. Okay. Know the subregions, and again, the better way to look at these subregions is this way. And your level right now, the head like a box is so critical. When we do the lab on recipient sites, I will actually start by showing you how hair grows on a scalp. I'm going to hopefully have a volunteer, one of the gentlemen that was here, and I'm going to walk you through it. So if you don't understand how it naturally grows, you're going to be in a forest trying to actually recreate it. So this head like a box, when you think about horizontal vertical planes, it's a very easy, simplified thing. And when you think of those shingle points, it helps you know what that lowest anterior point is. Because where is it? It's a shingle point. That's the lowest acceptable. It's not the best point. It's just the lowest acceptable. Okay. Otherwise, you're on the forehead. Look at those angles and understand angles and direction. So the definition of an angle is the relative elevation off the scalp. Okay, a direction is where it's pointing. Like this is a direction off midline. This direction points over here. This is a low angle. That's a high angle. Does that make sense? So angles are vis-a-vis the scalp in terms of the elevation off of it, and the direction is where it's pointing on the head. And so you need to understand angles and directions. I'll be using that terminology to describe recipient sites. And the biggest thing is when you're designing recipient sites, there are no about transitions. If you design a hairline like this and then a temple over here, it doesn't grow that way in nature. Go look at some scalps where look at together. You're going to see everything cascades like this. And if you're creating abrupt angles, you're not representing nature, and you're making either exposed hairlines where you can see the part. You're going to create things that don't comb well, that don't look right, and that gentle transition is the key. How do you make that? We're going to talk about that. So the angles, remember, a relative elevation off the scalp. And you can see here, they go from low in yellow up to medium high in the back to very high in the crown. And we'll hear that more in the crown lecture, down farther going down. And so you don't want these fronts going like this. They don't look right. They don't comb well. You can see through it. And you don't want your crown very low because it won't be right. So you want them to look good. So this is what I call surprised hair. You don't want hairs that stick up like this, okay? And I'm going to walk and work with you on the recipient sites to see if you're making that. The problem is I've noticed in my students when they give me their heads, they show it to me, they go, how do you think about these sites? Well, I didn't know how you angled it. I can't only see a hole. For me to know your angle is correct and not surprised, I have to watch you make the sites, okay? And for you to know you're doing it, because you don't remember, have your friend video it or put it on a tripod and film it. Because you're so focused on density, interlocking, angle, direction, you may forget one of them, right? Because you have to remember 7 things in terms of also counting. You got to make sure that you fit 1,000 grafts into a certain area. So all of those problems, you're going to miss one. And you can see all of your problems except your angles. So you're going to have to film that with your iPhone or whatever you're using. Tilt is a esoteric comment. I don't think you need to worry about tilt, but it's just there for completeness sake. Essentially what tilt is, it's the lateral position off, like if you're sliding like this off midline. Why do I use tilt? A lot of times in female hairlines, they already have hairs growing like this. I can't do this, I'll transect it, I've got to follow the tilt. Okay, so that's the only time that tilt comes into play, but otherwise, angle direction. That's all you really need to worry about to make it easy. Directions, I've already told you, they go in different directions. So you're going to hear each of these directions compartmentalized into separate lectures. But I'm going to give you a brief overview so you understand it in terms of direction. So the frontal area, they all go forward. The biggest junior mistake I've seen is they splay like book leaves open. Then you can't get density, it looks weird because where do you need the most density here? And if the angle splay, it's not radial, they all go forward for a male. I'm talking about man. Only lateral centimeter does it turn down, and it turns down if you look on that temporal point, they go back, okay, and then down. If you make a temporal point going down, you can have hairs growing on the face. So they got to go back. So the temples go forward, back, down, and then back. Okay, well look at people's temporal points. Naturally, they're not been transplanted. And then the back side, the crown, you see it's a whorl, right? Everyone's got different whorls. We'll talk about that in the crown. But then where they arch up to the lateral humps, where they arch up to the posterior mid-scalp, where they arch down to the donor area, there are also no abrupt angle changes. Okay, so everything flows. Priorities. The central forelock in the green circle is where the person needs grafts. If you don't have enough in the central forelock, even after a great transplant, they're going to look weak. And if they look weak, they're not going to be happy. So you need that central forelock at high density, using stronger grafts, more density in those areas. So that's important. There are many ways to make recipient sites. You can do parallel sites, perpendicular sites, or micropunch. A parallel site, also known as sagittal, although it's not a good term because I'll show you in the next slide. But parallel is more grammatically correct. I use sagittal all the time. It's not right, but it's more semantically correct. Parallel sites follow the parallel to the hairs. So if the hairs go this way, my sites go this way. Okay, my hairs go this way, they go this way. They're parallel to the hairs, right? Because if you look at this, that's not sagittal anymore, right? It's parasagittal, so it's not a good term. But it's parallel, and then perpendicular, they go perpendicular to the angle of the hairs, all right? There are a lot of advantages for each. I can go into it. It's a little confusing, to be honest with you. I would encourage you to only learn parallel. 20 years in practice, I use almost all parallel. You're going to hear all these fancy things online. Lateral slits, perpendicular is great, better density, has less angle elevation, all of which are true in terms of angle direction, not the density. There actually been side-to-side scalps done with this, and it's false. It does not provide more density if it's done well. So you can leave all the marking out there, and it's all marketing. I wrote a chapter on micropunch many years ago. I was passionate about it, but I had some issues with necrosis and tissue compromise. I would not use micropunch in your central scalp. I use it for donor scars. If I'm punching out a scar back here, I haven't had an issue. The front, especially in the midline where there's risk of blood supply, I would not use micropunch in that area. I would only use slits, and I'm going to talk about different options of that. So here's a great example of showing you why the word parallel is better, because you can see that when they're going to the side, it's even look at the one on the far right. You can see that those are sagittal, but we call them coronal. So just use the word perpendicular and parallel if you they're more appropriate. Okay, if that's confusing to you, again, I'd be happy to talk about it more afterwards. But I'm going to only show you parallel here. I'm not going to show you perpendicular. I'm not going to show you lateral slit. It's just no reason. So the reason, in a nutshell, of what the disadvantage of doing a parallel, because the slit goes this way, the graft could ride a little bit too high and create a surprise look. But if you've got a controlled angle, it's not going to ride much. So that's one thing. But the perpendicular ones can slide this way because the slit is going this way, and these cause the perpendicular is very hard to follow those in terms of the design, especially in the crown, especially in the eyebrow. And there's a whole host of other issues that we'll individually talk about. And also higher transection, easier to transect native hairs and grafted hairs. So parallel to me is the way to go. Okay. Another point I'm going to show you as we work through this is interlocking. Essentially what interlocking means is that you want the sites to go like this. You don't want them like this because this takes up more space and you can see through it. But if I do this, if they're all interlocked, they're a tighter pattern and they don't compete with each other. So I'm going to show you that again in lab. Many types of instruments to use. I personally use solid core needles, which I'll show you. I don't like the chisel blades. It's not because they're bad. A lot of my incredibly esteemed colleagues use it. I find that they made sites a little too large, and I found that they slid because the whole thing is sharp. When I'm going low angle, sometimes I find that my site is slightly too large. And when I was using very fine ones, they bent too easily. Maybe I'm too rough with my hands. I don't know. But I do better with needles. I used to just use hypodermic needles, which I still do for eyebrows and I'll explain to you why in the eyebrow lecture. But I really now use solid core needles. The advantage of solid core needle for me is several-fold. Number one is the fact that without an open hole at the end, I've seen a lot fewer inclusion cysts. Sometimes I get a little inclusion cyst after a 2,000, 3,000 graft case because the epidermis can be entrapped with the open needle. Second thing, they don't dull as much because I can do maybe between 500 to 1,000 sites, sometimes only 200, depending on the, instead of with my hypodermic, I can only put in 50 to 100 sites, so I don't have to do as many. I don't have to change it out as much. And it just gives me a really good ability to make very good solid sites.
How often are you changing the needle out?
Between 200 to 1,000 sites, depending on what I feel. So sometimes, on average, 500 sites. So if I feel like at 200 sites are getting dull, I'll already have a backup, and I'll switch it, and I'll tell my assistant, hey, give me another 2 of these, because I'm calculating I need 5 of these. Generally, it's between 200 to 1,000, depending on the patient. Whereas with the hypodermic, it's 50 to 100. It just dulled really fast. So these are the size equivalents. Again, you have a handout with all this. The easiest way to understand it is I usually, in general, use a 19, 18, 17, where my 19 is accommodating 1 hair sites, 18 is accommodating 2 hair sites, and 17 is accommodating 2 to 3 hair mixed. And I'll show you what that means as we do this. So always want to test the site, graft to site fit, make sure it works. And how you do that, so your assistants are working with you. If it should sit up without much pressure, about a millimeter above the scalp. If it is way above it, it's going to dry out and die. If it's buried under it, it's going to cause a compressed or a pitted look. So you want to make sure that each fits. And you don't want to make 3,000 sites and realize, oh, none of them fit. So you want to test it, make sure everything fits, and then you want to make sure each of your recipient sites are matched exactly to the right length. So if you make 4 of those recipient sites, make sure that they're the same length that you originally tested. Okay, so that's very important before you get into it. Patient positioning is important. When you're working on the frontal hairline, you want them fully supine, because think about this. When they're lying down, you're making low angles, naturally low angles, right? You can see that, right? Sitting up, low angles. When you're doing the crown, I want high angles, and so I'm having them sit upwards. So that way I can get, first of all, there's 2 reasons. One is I can get the higher angles. When they're down, I've got to go like this to try to get higher angles. And second of all, I can't see the back of the crown. So you really make sure you've drawn off that back side of the crown, so you know that's the limit of where my design is, and you can plan into that design. We'll talk to you about how to plan into the design in a minute. I like to put a trough underneath where I just tape it up so the blood, if it trickles down, is making sites. This is all before. So that's a little trough. I just tape up the chuck or the underpad. So distribution, for example, here, this is the 1 hair sites I'm putting in the front, like 1 or 2 rows of that, and then 2 to 3 rows of ones that are specifically designed for 2 hairs. And then I use a mix of 2 and 3 hairs. Why do I do this? So first of all, there's all variability in 2 and 3. So someone may come out with 75% 2 hairs, some may come out with 75% 3 hairs, rarely the case. But you want the site small enough to accommodate the graft, because the hairline's got to be tight. So if you're making large sizes, like with a 17 gauge or 18 gauge for 1 hairs, you can't get them tight enough. You need the hairline super tight. So you need small enough sizes that you can get tight enough, and that will also fit the grafts. Okay. With FUE, oftentimes I'm just using 2 sizes because the FUE grafts are a little slimmer, but I will trim down my 1 hairs anyways, or I may split a 2 into a 1 if I don't have enough 1s. So I'll make the 1 still smaller than my 2s, but oftentimes with FUE I'll just do 2 sizes. Not always, depending on what I see. On strips, I usually do 3 sizes, and I mix. So I'll call my staff. I'll say, look, he really needs a central forelock done. Go ahead and segregate me out 300 to 500 threes, so we can place those in the central forelock. The rest you can mix. Or I'll say, you know what, he really needs it all over the place, or she really needs it all over the place. Go and start mixing from the very beginning. So that way, that last purple area you see is based on what I design. If the person is thinning in the crown, I don't address it. I don't want a big graft sitting on the back, so I'll go back and do what's called the posterior hairline and put a few 2 hairs and scatter it, and sometimes some 1 hairs as well, depending on how exposed that area is. For women, oftentimes their hairline's preserved, so I may not even need 1 hair grafts, or I may just need a little bit. I may not even need a lot of 2 hair grafts. They just need density. So I may, of course, it's different from a frontal temporal rebuild. I'm talking about density issues. I may just use almost all mixed FUT, 2 and 3 hair grafts from the beginning. Or I may say, this is really important. Go ahead and save me 2. How many 3s are you getting? This is from a strip or a harvest. If I'm harvesting, I may target more 3s or 2s. But for women, again, I'm not doing a FUE. But this is how my brain thinks. These are paint to cover a canvas, right? So basically, there's a macro and a micro hairline. To refresh your memory, the macro is what we just did, which is the line. The micro is the little bit of the snail trail, which you're going to execute on the recipient side. So this is the micro. This is taking a straight line and not making it look straight and making it look irregular. Okay. And this is just showing the artistry. I draw the design of what this looks like. So male hairlines, as you see as a sample, they all go straight forward. There's no splay except for that loud centimeter. This is the biggest mistake I see, and it's very hard. I'll tell you, the biggest mistake you're going to make as a beginner, and I still make it 20 years in practice, is my left and right sides are slightly different because it's on a curved space. So when you make recipient sites, don't practice on a flat plane. It's too easy. You need how much harder was that hairline on a curved space, right? It's very hard, right? You have to think curved. And so when you make recipient sites, if you're right-handed, your left side will not look like your right. And that's the exercise I'm going to drill down when we work in the lab, is work on your left and right sides. The left FTR, you can see that it goes forward and then starts to arch down. Okay, that's that little bit of transition across there. The crown, everything whirls in different ways. There's just no abrupt transitions. And female hairlines are complicated. Don't start doing these. They whirl in different cowlicks and they blend down and they go across. The female hairline drawing, I don't even have a lab on it because it's so easy, but I'm happy to do it. It's just draw a curve that looks good. Drawing the female hairline, you can almost not mess it up. But doing recipient sites, you will almost definitely mess it up. So the male hairline is the exact opposite. Very hard to get the hairline drawn right. Very hard, you saw that. But the recipient sites are much easier. Okay, and it's still hard, but it's much easier. So what you got to do is the limiting factor. But you're in the practice of hair loss, you got to do some men, right? So the men is where I encourage you to start, even though the hairline is difficult. So also look at, if they've got existing hairs, you can't just put the hairs however you want. You got to follow those. You're going to chop through all of them. So this is sort of a whirl pattern in the front that I matched. If you make the pattern way too complex, your staff can't place into it. So remember that too. Sometimes you just got to chop through some hairs. Temple points, I showed you, they're very, very low angled, and they're much harder to get the right. Do not do temple points. I heard a little bit about eyebrows and things like this. Eyebrows are the single hardest thing to do. They're near impossible to get right. And even if you can get it right, which you won't, your staff won't place right, and they won't look right. And they're the most exposed area. So it's the hardest thing to do right. Temple points are right behind it. They're slightly easier. When I mean slightly easier, they're slightly less than near impossible. The central scalp is where I would start. Crown is then a little bit harder, but again, where the crown difficulty is not the design. It is executing future problems and looking at future problems. Then female hairline is slightly harder. Temple points and eyebrows, highly encouraged. You should be many years of mastery before you even begin to touch an eyebrow or temple point. Seriously, you're going to mess it up. I almost guarantee it. So that's depressing, but it's the truth. And a lot of people come take my St. Louis course saying, or this course saying, my first goal is eyebrows because it's so small. It is so hard. Okay, don't do it. So sideburns, post, facelift removals. So how do you do this? Let's do it step by step. You got the drawn hairline in. These terrible drawings are mine, so the real one in the book will look a lot cooler. So Mason hasn't finished these. So I work on those irregularities. I constantly fuss. It's a great word that my mentor Vance told me. He's a family doctor by background from Calgary, and he really worked on. He says, look, Sam, fuss over it. Think about it. He's taught at the course. He's at the St. Louis course, and think about it. Don't just make that line. Think about is it too asymmetric? Is it too linear? Look at that row that you're making, and so there are going to be things that don't look right. You got to keep working through it. Then you start working after you finesse those 1 hair sites. You want to start building the 2 hair sites going back, and those 2 hair sites. Now I don't really do a lot of coronal sites anymore. This is an older illustration by St. Louis. This will be gone. I'll have Mason's much prettier work than mine. But this is showing you the execution. I draw that snail trail in. I make my 1 hair sights, and then I come back and make my 2 hair sights across there, and then I make my 2 to 3 hair sights behind that. And we're gonna do that in lab after lunch, and so you'll see that.
So you just don't engage in your needle, right?
That's right. That's exactly right. So 2019, 18, 1918, 17, depending on your staff experience, depending on what works for you. Hairline's like a coastline. From far away, California looks pretty straight. Close up, it looks really jaggedy. Super close up, it looks ridiculously jaggedy. that's why your hairline should look. They should look relatively straight, but not entirely from a distance. The closer you get to it, it should look more zigzaggy. And then I always draw like a placing guide to tell my staff this is what I did, so that when they're placing, they have a reference to how I design things so that they know how to do it. And during recipient site design, I won't be silent here because I won't have to worry about the number counts, but there is no discussion. They don't talk to me. I'm focused. I'm razor sharp because as a design, I got to keep my number counts in. And I don't use counters to count because if I count every 100, I'm going to be off. Every single site I make, I'm thinking, should it be somewhere else? Am I putting too many? And I'm going to talk to you about that in a more logical fashion in upcoming slides to understand what that means in real terms. But I'm constantly thinking, I don't want to run out graphs. And I'll be honest with you, if you ask me, Sam, what's the hardest thing you do 20 years in practice? Getting my number counts right. It's still hard now. It's still not easy. I'm still thinking, if I put too much here, did I put enough there? Does that person need more here or there? And the mistake I've seen for the starting people is they're going too fast. They're going like this. This is what I see. This is not how you harvest. This is not how you make sites. This is my speed. You watch me. Okay, you should be, that's too fast for you. All right, way too fast. So understand that. And you know, if I have native hairs around me I'm making, this is how fast I go. So you have to really slow down. Biggest mistake. And there's a lot of other reasons. I know how to go full depth. I've seen the students when they're making sites. We'll talk about this in the upcoming slides. They go so fast, they're only penetrating like 2 millimeters in. And if you do that, you think a graph is going to fit in there? The staff is going to try to mangle and stick it in there. It's going to be destruction. You got to go full thickness. Okay. So things that I see: asymmetry. I already mentioned that. Your left and right hands on a curved space are not. Yes, Andy.
What's the challenge? What's the downside of it being too deep? I mean,
A lot of things. There are a lot of things. Yeah, there are a lot of things. So one is the graph will fall in, so that the graph will either die or it will be buried. You'll have a pit. The second thing is you'll have necrosis. If you don't have, if you have super long depth in there, you'll hurt the blood supply. You'll have poor growth, patchy growth, or frank necrosis. So there are a lot of issues with the graph the site length and not using enough recipient tumescence. And that's why when I do recipient site tumescence, I usually put about 50 milliliters in. But if it's bleedy or if it's like scarred down or from prior surgeries, I may put up to 100. And so I sequentially apply the whole thing with tumescence, and then I come back and I even use donors. You don't need that much triamcinolone. So if I've got some extra donor and I'm doing an area that's a little bleedy or I'm worried about like tethering to that area, I just go and put more tumescence in. You want a lot of tumescence to cushion you from that neurovascular blood supply. Or if the graft sites are a little longer, or if they're diabetic, or if they're a previous smoker, or the tissues look sun damaged, I'm going to spend more time tumescing, and especially if those grafts are longer, because you can have poor growth from dense packing it or placing it too deep. Does that answer your question? Yep. Yes.
So, what's your interlocking pattern when you're using parallel sites and
right.
interlocking?
Yep.
So are you like following like a certain line each time?
What do you mean?
Like, kind of
I understand what you're saying. You're saying I'm just going down like this, like this.
Yeah,
So I'm doing what I call a broad field. So what I want to do is I don't want to do left and then right and then middle. I sort of work it down. There's a lot of reasons to do that. The biggest thing, you're going to see this. I'm going to show you this in a very detailed in a coming slide of number counting. Because if you do the right, and you make, let's say you have 1,500 graphs, okay? I want to do 1,000 on this side. Uh-oh, now what am I doing on the other side? I got 500. Now you're screwed. If I work through priority zones, I work for priority 1, 2, 3, because sometimes you think, well, I'm going to start the back. That way the bleeding will go down, right? I'm going to start the back side, and I'm just going to make it pretty good. And then halfway through, you realize, I'm about 2/3 through my number count that I have that I think I need. And that's sometimes I'm going to strip because I have if you eat, you can harvest more. But then you wind up taking 3,000 grafts, you don't have that back there. So the problem with that, I always go priority 1. So my priority is hairline central forelock in most cases, and then I go back from that. Okay? So always go priority 1, 2, 3, 4 down in terms of priority. So asymmetry, side to side, hairline being too straight, abrupt transitions, these are all things I see in running out of numbers. I struggle with that 20 years in practice. That's why I go slowly. That's why I don't talk. That's why I'm focused, okay? So do parallel sites, please. I do that. Don't think you've heard something sexy online about perpendicular sites. Please don't do it. Do only male frontal scalps, please. Don't start getting into crowns. Don't start getting female hairlines, eyebrows, temple points, please. Avoid temples and eyebrows like the plague. Practice. Before I did my first case, I spent a year practicing, okay, on inanimate objects. What are those inanimate? I'm going to show you. I'm going to give you all the tools. I'm going to give you feedback. I'm going to say, look, this is your number one mistake. I'm going to go through Socratic. You know what's cool about this? And he'll test this is that when you do this, I say, look, Andy, you made these 2 mistakes, and guess what happens? He corrects it. And then he doesn't make it again. And then he makes another small mistake, and I correct, and I show you guys, and you will self-correct fast. Okay? This is not rocket science. This is not like what I think one of the highest stars is rhinoplasty. This is easier to get you there faster, but you need to put the effort and the concentration to do it. Okay? So recipient site density. These are just showing some examples. Do not get up into the 40 to 50 sites per square centimeter. You want to be in the 20 to 35 range, and more concentrated in the front, a little less in the back. If you put a bucket of density in the front and none in the back, it'll look weird. If you put it evenly throughout, it's not going to work well. Guess what? I just invented in the last 2 months a systematic way of doing it to make it easier, because I always like to teach it instead of vague ways to do it more concrete. I'll show you that in a minute. So this is the recipient density. Always think in terms of this. Your 1 is central forelock, 2 is frontal temporal recession, 3 and 4 is the back. We say, well, wait a second, what if they have a huge good frontal tuft and they lost here? Well, that is not the priority then. The priority is here, right? So this is just a general. They're losing hair, so understand that. Or female, they could have the front here and they just lost their temples. Well, that is your priority. I'm just trying to tell you generally. Look for your priorities. To answer your question, hit those priorities first. If you miss that and you run out of your numbers, you're screwed. Okay? Start with always the priorities. That's how I do it now 20 years in practice. Cascade effect is a thing that's very dangerous to teach you, because if you listen to this, you're going to overdo it and it's going to be wrong. So I'd rather just give you the understanding so you can mature into it. A cascade effect simply means that if I put a graph here, and you can hear more of my crown talk, it can be combed this way, so therefore it covers the part, it travels longer. If I put it here and they comb it this way, it only covers this much distance, you see, so it doesn't have as much value as the left. If you put it in the forelock and you comb it back, it has more value to the front and the back. But the biggest mistake I've seen with teaching cascade is you overdense pack one and you don't put enough in the other, and it looks weird. So I'd rather you more or less uniformly apply it, with one exception, which is the next couple slides, but I like you to know about it, okay? It's going to be in the crown lecture even more detailed, maybe too detailed, but it's a good thing to mature into. You know, a lot of these talks I'm going to tell you what's advanced, what's intermediate, what you should do. So geometry. If you think about the scalp in terms of triangles, circles, and squares, you can think about how to create allocation density. We're going to do some of those exercises in lab. Is that you want 2,000 grafts to fit in a certain prescribed area. Well, what is a triangle? It's half the size of a square, right? Because it's half base times height, and pi r squared is a circle. So you can actually say, this is how many square centimeters this is, and determine how many grafts to fit in there. That's a great exercise. I really encourage you to try getting that down. But I'm going to tell you how I do it in practice, because this is going to show you this. So let's look at this. Here's a guy that I want to build, what you see in the front being a sort of a triangle, and the back side being sort of a rectangle, right? And if you look at it, it's sort of half and half. It's not always the case, but let's just say it's sort of half and half. And let's say I want to do 200 ones, 200 twos, and 1,500 two threes. My 401 twos do not add a lot of length. So I just count those as my hairline. They're not going to be into the numbers that I'm going to execute on to cover surface area. So my 1,500 is what I need to cover that distance. So logically, how would I do it? for me, the front is priority, okay? The back is not as priority, but the back side, if I don't give enough grafts there, it's not gonna look right. So the way that I do it is in that triangle, which this is not quite a triangle, but in general, that triangle is about half the size of the back. In this case, it's not quite. So I would look at having more density in that triangle with the same number of grafts. Does that make sense? So that I have more density because it's a smaller area with the same number of grafts, therefore it's higher concentrated. Yes? And this is just a gestalt. And then as I go through that triangle, I want that 750 divided equal to be 375, 375, because that upper triangle is smaller than the back triangle, which is smaller than the rectangle. And if I'm halfway through, halfway, or quarter way, and it's a smaller triangle, that central forelock is slightly more concentrated. Does that make sense? Now, am I exactly 375? No. Because the thing I don't want to do is cheat in the front and get a crappy result in the front where I could cheat a little back. So let's say I'm up to 450 on the front. I'm still okay. But if I start getting to 600, I know, no way, the numbers won't work. I'm going to be so front heavy, it will look weird. So you're going to start practicing to get those numbers right, so where you can fit those numbers. So I'm going to repeat this because it's complicated. I will split an area if it's a triangle, and the triangle should be half the size of a square in general, and I want the same number of the triangle in the square, because that triangle is aesthetically more powerful. And in that triangle split in half, this way, that upper triangle is half the size of the other triangle, not quite, and I want half those numbers there because it's more focused. That's how actually, and to be honest with you, that's how I design a male hairline. I think these numbers, this is how I design. So, and so this is just an example, is tighter to more spread out, okay? So there's so many things here, but you can see that if I just move it up a very short distance in the hairline, just 1 or 2 centimeters, it takes a lot more grafts, a lot more grafts. It's more than you thought, so stay conservative. You heard that in the hairline, because that conservative hairline not only will age better, especially when you're working on this, but also you're not going to run out of grafts in the front. Okay, yeah, Eddie.
On this particular
Yes.
design,
Mhm.
like the back,
Yeah.
we're not going to go to that crown.
Yes, right.
That first one, it was a straight line.
Yeah.
I mean, when you're really designing it, don't you design it so it looks roundish in the crown? That
Yeah,
anterior aspect of the crown
it's a great,
space?
that is absolutely correct. So this design is actually not from what my design, but you're right, it's too linear. It would look better a little bit up and suppressed in the midline. Very good, that's an advanced comment, but you're absolutely correct on that. And it's in the textbook that I mentioned that. So, and these are just showing you the beauty and the fun part of designing. These are my electronic medical records of it. You know. So melon is a great way to work with this, but nowadays, to me, this is a nicer way of doing it because it's a little bit softer, and we're going to use this exact model. We're going to give you some magnifying visors. I like to use 2.5x magnifying visors for this. It's actually better than fancy expensive loupes, and we're going to give you those to use. And they're like $30 or so. Yeah, like that, exactly. This is what I use to make recipient sites, because I can see, I can move out of the way, I have panoramic vision, and you don't want too high a magnification because you're going to overdense pack, and you're going to run out of grafts, you can't see the forest of the trees, you're going to create necrosis issues, your staff won't be able to place in these sites that are microscopic, and so you want to stay not too highly magnified, okay? And you want to be able to see the whole thing. So even at 54 years of age, I still see well with these 2.5s, 2.75s. Don't go, oh, I heard, he's using 8.5x loops for FUE harvesting, I'm going to go like 8x to make great recipient sites. No, you're going to overdense pack. So don't go beyond 2.5 and use a visor. It's $30, okay? So, and so you're going to practice this design. This is just a preview for after lunch. We're going to make hairlines. And you see these lines going down? This is actually a genius faculty in my St. Louis course. And you know what really helps students on a curved space is for them to draw lines. Oh my God. I don't do this in real life because I don't need it. But for you guys, it's really helpful because I've noticed on a curved space, as your hand goes over, you're going to start doing this. I promise you, if not one of you, all of you, will start making sites going in the wrong direction. And those lines serve as a guide as you're magnified to stay straight, stay straight. You see how my sites are staying straight, okay? The spacing too far, the ones on the bottom of the screen, you see they're too far apart. And then you make them too close. Well, what is too close? What is too far apart? Let's look at some examples. We'll work together. I'll show you why I think it's too close, what's too far apart. And this is a magnified screen. I mean, how do I show you that? You'll get a gestalt of it. We'll start to show you. The more you do, the better you understand it. And that's why the lab is so critical, that the lectures only reach a certain point. Asymmetric, it's so natural. You're going to screw this up. I still screw it up. I still 20 years in have to go back and go, oh, my left is a little off. I have to go back and fill those gaps. Like, what do I do with this case? Well, I have to go back and fill those gaps, okay? Those gaps on the left, can you see it? They don't match, all right? They need to match. And making sites that don't interlock, this is terrible, okay? Don't do it. And this is the one I see all the time with my students, is they think they made a site and they give me the design and they say, how is it? And they only made a little dab mark in it because they're trying to go fast. This is not a speed contest. This is a quality contest, okay? I want you to slow down, silent, slow down. Now, I don't have to be that silent with this because I don't need the number counts for you guys. That's another level of testing that I want you to get to. I just want you guys to master design. Not so much can I fit 500 into the space. You can if we have the time to do that today, but you can practice that at home. What I need you to do is make sure I see quality, symmetric, natural, balanced sites. Okay? That's the exercise of the lab coming up. Know the north pattern, know the subregions of how things grow. We're going to really understand a little bit better in lab when I show you how a scalp grows. Think of that head like a box, divide the head into vertical and horizontal planes. Center forelock, center forelock, center forelock. You have a weak center forelock, you have no result. Okay? Follow angles and directions. Angles, remember elevation vis-a-vis the scalp. Direction means which going this way, that way. Make parallel sites, forget about micropunch, forget about perpendicular. Make sure those sites are interlocked. Make sure you test graph the site fit before you execute on 2,000 sites, and practice the bejesus out of this at home. I did as well going into it. Okay? So be an artist. That's critical. These are some of my artworks I've done this last month with my kids. This is my artwork I'm holding, but also my artwork that I designed. This one I just finished about a week ago. So this is artistry and it's design, and it's something fun, and I hope you are challenged by that. Okay, guys, so this is a recipient site designed on a styrofoam head with these these foam pads. It's a little easier probably if we cut it around so there's not as much buckling in here. These are T-pins to hold in position. This is really nice to simulate scalp. Even though we have full head cadavers, to be honest with you, this is so much easier to design. It's also going to replicate something where you can go home and do this. You can't go buy a cadaver head and use it. So don't worry, you've got full cadaver heads, but we use those tools for your education, not just because we purchase those heads. So for me, this is the best way to simulate what I want you to do at home. The other thing, if you can't find these things, which you get on Amazon, just use a honeydew melon, works really well. The problem with honeydew melon is that it's really hard. This is software to simulate scalp a little bit better. So what I'm going to try to teach you today is frontal scalp melt pattern design. We have plenty of time to do this. We have 2 hours if you want. We can do other things like eyebrows, etc. But to be honest with you, this is what I need you to master. You need 2 hours to do this. Don't get enamored that you just nailed it because there's so much work to do. Then you can start working on number counts, see if you fulfill those numbers. There's so many levels I can take you without even going to the next thing, okay? And tomorrow we have a catch-up like 4 hours where you can go into more advanced things if only if you want to. So I go and just draw that hairline in. And so the key with this is don't get focused on hairline. It's a U-shape, okay? And then I'm going to go and just draw a little bit of upper temple there. And let's say this is sort of the design that I'm doing here, okay? So that's what I'm working on. Let's say it's like this, all right? So the thing I already told you is that we're working on a curved space. And this actually is not even that curved. It probably should be a little wider than this because I really want you to simulate the curvilinear space because that's what makes it hard. It's when it's flat, like that's relatively flat, there's only a little curve, it's a little easier. So to be honest with you, if you can get wider pins on this and go even wider with a design like this, it's going to be harder, which means it's going to be more instructive. The other thing I mentioned during the lecture is drawing these horizontal lines is very, very helpful because with these horizontal lines, it helps guide you, especially if you're right-handed right-sided, trying to make the left-sided ones. You may want to wear gloves if you have them, just because it's going to get on your hands, but it doesn't really matter. So, 2.5 a little magnification is helpful to use. This is a solid core needle. What you want to do is you find the graft length. So let's say that you line it to the graft and then you adjust it. Okay. And some of these what I use is there's a little plastic collar I can put on there to adjust it in case it doesn't quite fit for the right length. But this is literally what I use these solid core needles. The bevel doesn't matter if you have the bevel left or right, but you don't want the bevel this way because doing it up and down this way makes it a perpendicular sight. If that makes sense, right? Because if you look, if I make the bevel up and down, the sight makes a slit going this way. If I make the bevel to the side, it makes it go that way. A lot of people get very focused on the bevel. It's either left or right, but not up and down if you're trying to make parallel sights. Okay, does that make sense? The other trick with this is, so I see this all the time, and so since I've taught St. Louis for so many years, I see all these crazy stuff. Like I see people starting to do sight designs like this. Well, I mean, are you hugging the patient? I don't know what you're doing with this. Okay, so it looks weird, right? So common sense is common sense, but you may just, I see all these weird stuff people doing like this. I don't think anyone's allowed to do this. You want to simulate the patient in a supine position lying away from you, right? So that's what you're going to do. With FUE, the patient is going to be like this, and you're going to simulate that. So I want you to simulate how it is in the OR. And of course, the crown you'll be seeing up like this, but we're not doing that right now. So this little bucket holds in a position. Usually, my patient is pretty much flat. So you want to keep it, sort of like this is flat. You see, it's pretty stable. And then with the hairline. So as I showed you, the other thing you can do is go ahead and make, if you want, make sort of this, irregular snail trail line, so you can see that. And then if you've drawn this and you don't like it, like I've gone farther on this side than that side, well, maybe what I'll do is I just go and make a couple sides over here to make it match this one, or this one I don't like anyway, so I can go for it. But generally speaking, you can do that if you want. And my first line is going to be the one hair sights. And so you don't have to use a smaller needle just for this exercise. You, of course, could use, we've got a few sizes, but I don't care too much about the size. I care that you make an irregular frontal hairline and that you interlock and you make symmetric, evenly spaced ones that have the same angle direction and that go deep enough. Those are already hard enough for you, trust me, than all the other variables that you can layer on this with sizes and all that. That can come with time, and really that's easy. So basically what I do is I start with the frontal hairline. And so look at what I'm doing. I'm going to show you a few things. Having taught this course a while, I know all the mistakes. What you want to do is rest your hand, okay? It's just like if you're painting or if you're doing surgery, you always have your finger rested. I rest my hand here. Now I want to show you the difference between left and right before I begin. As I make these sights, as I come over here, watch what I do. Look what I do my hand. Do you see how I move my hand? Don't watch my hand here, watch my hand here. And when I come over here, look at my hand, okay? The mistake, this happens all the time, is when you come over here, you're going to do this, okay? Because you're reaching over, and your hand is going to make sights that angle differently than over here. You need to practice moving this hand, look at this part of my hand, how I work to keep straight, all right? And keep the same straightness as I go all the way across. So this resting keeps you stable, but it also, you have to practice moving your hand across here so you know this before you start making the sights. Because I guarantee you're going to make sights here and these sides here, and they're not going to look straight on. If you do that, remember it's uncombable, and also the densities are going to look weird and different from both sides, and you're going to have a splayed open. Because the center, you think about this, it's curved like this, so those sights are opening this way. You're moving away from what? The core zone, which is center forelock. You need them to go toward the center forelock or straight forward, not away from it. All right, so when I make my sights, I usually like to start in the middle. You can start on the side, doesn't matter. I just do this. So I'll make the sights here. You see how low the angle is? Look at this when I exit. If you look at this, that's 30 degrees or whatever it is. That's what I want, okay? If I'm making sights like this, that's 90 degrees, and that's going to look surprised, okay? If you look at people's hair transplant results, they don't look right. Their hair stick like this. They need to be like this, so low that it looks natural. So I'm going to go ahead and make these sights. So I'm going to make these sights. So what I do is I do micro regularities. I go down, back up a little bit, back up here, back here, back here, just making these. So I'm going to first.
Spacing a millimeter or two?
Yeah, it's about 1 to 2 millimeter, maybe a little wide. It's 1.5 millimeters apart. It's hard to give you exact one here. Sometimes I don't follow exactly the pattern. I'm going full depth. You see this with each pass? I'm going all the way. Now look at my here. You see now I'm using my pinky. I'm rotating out here. I don't even know what I'm doing, but so what I'm trying to do, look at how this is. I'm moving away so that I don't tilt away because there's a natural tendency to want to do this, okay? When do I make that pivot? I'll show you when I make that pivot. I'm still not pivoting. You see that? I'm still going pretty straight. Now, here's a lateral centimeter. Here we go. Pivoting. See this pivot? No abrupt angle changes. Oh, I forgot to show you one. I was going to do a scalp. I need to do that. Okay, now these are, and we go down here, goes a low angle. So this is the hairline. I'm going to just finish it for the sake of completeness. But what I want you to do is, besides looking at this, I also want you to see, and this is the speed that I go, okay? I'm probably going a little faster than you guys would be going, and that's fine, but you're going to see, like watching paint dry, if I take this longer. But this is really the speed that I'm really actually designing it. Now, look, you see how now my hand is just rotating so that I stay straight. It's all based on the hand and some wrist movement that I can maintain a straight profile. And see, like I would like to put another one back there to make it more of a triangle. And then, so basically I'm just going in and doing this. And this is how I'm really designing it. And as I get into the lateral centimeter, here we go, I'm starting to turn until I hit this. And you're welcome, I can leave this one up here to show you guys this. Anyway, so here's the hairline, okay? Now, what I do, I use an 18 gauge or 19 gauge, this next larger size, to fill in 2 hairs. What I usually do, this is my own deal, and you don't have to follow it. I like to fill in all those little gaps for my 2 hairs. So I'll come in and fill in here, I'll fill in there. I want at least 2 to 4 rows here. But what I usually do is I fill in these gaps like this, and I usually make a pretty straight, straight zone so that the area that I'm going into are all 2s, and then there are fewer 2 hairs right at this, at sort of the recess or the crotch area of this thing. So you can see that I'm sort of filling in these guys. These are all 2 hair grafts that I would be doing. The dedicated 2s. They're slightly smaller than the 2s that are used for general central density. And you see how I'm interlocking it. And then these hairs I like all 2s for. And you don't have to create maybe as much density, but you can see. Okay, so these are all my 2 hair sights that I'm making. And actually, before I turn you over to do it, we need to look at a scalp together. I actually have a really good scalp because I don't have that much recession, and I'm also short-haired, which allows you to see everything. But I'm going to see if I can find someone else. I can't show it on me as well. So these are all my 2 hair sights.
And those F1s and F2s are using the same size?
No, I usually use a slightly smaller, step up one. And so these are, so you can see here that what I've done is that I've made these sights. And also when you go to the temples, it's really good to have traction because these things slide. And so I like to put tension on this because if the sight slides, your depth won't be right. So these are all my 1, 2. So then after I've done that, now I'm going to fill density. So the way that I fill density, so these are my 2s that look like this. And you're welcome to take a photo later on of this. And then my 2 3s, remember, I need this as my priority. And I need this as my second priority. This is my third priority called extended central forelock. And then these are my last priority. And if I divide it, I do this in my office. I sort of divide it by half. So my brain says this is halfway. So if I have 2,000 grafts, if I'm planning in the harvest, I want 1,000 here and 1,000 here. And you see this is slightly bigger geography. And if I remember I showed you I divide that in half. I sometimes don't draw that line. I encourage you to draw that line so that you want, if this is 1,000, I want 500 here, 500 here. You see this is a smaller size, but that's the core zone. So if I go 500, 500, 1,000, that's how I plan my distribution for optimal density and balance. All right. And that's actually how I design. But it's not always. Everyone is different in terms of this is just in general for baldness. So then what I always want to do is I just make sure you interlock all these sites, and this is, remember, a slightly larger, I'm not using one here for the sake of speed, but I would just go up on size. And here's the trick. I'm going to show you a few tricks here. No, not. No, that's a great question. Great question. The answer is no. You can almost not make it too low. You can make it too high. And it makes things very complicated for my staff to understand when you make sites of all different angles, or angles. So I keep them all pretty similar. I mean, you don't really need to adjust it. You can go a little higher on the back side of this, but basically keep them all low. It's better. The crown, keep them all high, except for the bottom portion where you want it flipping up. But in general, these, I'd rather you go too low. So I'm going to show you some quote-unquote errors, and these errors are actually ones I still make even today. I'm going to just sort of make the spacing. So this spacing is a little too wide for the central forelock. I want it a little bit denser, so I'm going to try to make it a little looser and show you what I'm talking about. And so what I do is after I've made these interlocking sites, so I'll look here and go, okay, where can I make interlocking? Just here's an example. There are 3 sites here. Do I put it right here? Well, I could, and that would still be interlocking, right? But it's so wide. So what I'm going to do is I'm going to interlock between these two like that. You see that? And then I'm going to interlock between these two and put it there. You see what I'm saying? Now I look at this, and there's a big hole there. This area of high priority, I don't like that big a hole. So I'll come back here and fill that like this. You see that? Where here, this is interlocked, right? It's not incorrect, but there's too big a gap in this area. So I'm going to come back here and put it, make a site. And then this one to me is too big a gap. This is a core zone. Now that width is great back here. But in this area, like I don't like that gap. So what I'm going to do is fix these gaps and make it tighter. So I want this central forelock no compromise tightness again, because that's where I may put 3 hair grafts. That's where I'm going to put some better density. And so now you don't want to keep doing that and make it so tight that you run out of grafts. And that's the art. You can always keep it somewhat loose. Finish your pattern and come back and go, oh, I've got, if you have 2,000 sites to make, it's always better to finish at 1,800 than 2,200. Then you have 200, you go back and go fill in all those gaps. So I always like to be 10 or 20% lower than what I thought. I'm not always, but in an ideal world, I'm actually happy about that. And to be honest with you, like the guy I did on Wednesday, when I was doing this, remember I said 1,000, right? I was doing this, and I was actually at 500 for all of this. I'm like, oh, great, because the compromise zone wasn't compromised. I went ahead and did what it should have been, which is a triangle should be half of this, right? So technically it should be 500, 1,000, or 1,000, 2,000, and usually it's 1,000, 1,000. But I wasn't going to go, oh, I'm going to go super dense. So I'm thinking, this is great. If I'm half of this, I know that I can do double that, and that's a great situation where I can go, or I can go a little bit farther back on it. So that's an ideal situation, but it's not reality. The vast majority, when I'm trying to cheat, I'm going 1,000, 1,000, and it's a smaller size in the front. Does that make sense, guys? Or if you have a design like this, where you have only a small triangle, and then you've got this huge thing like this, then maybe what I'm going to do is mentally divide it into thirds. Does that make sense? So if I have, 2,000 grafts, you could say it's 2,100, it's let's say 650 each of these things, and then each of the 650 I can maybe say 325, because 650 it's still, it's close, 630, whatever you want, 650, so that's, but it's undershooting it a little bit because that's 1950, so that's always undershooting is better than running out. You don't want to run out of grafts. So this is a concept here, and I want you, in a moment after I look at a scalp, I want you to practice this. I'll critique it, I'll take it and walk around and have you do the same Socratic method of criticizing it, again, in a very good way, and use these, please. Take a look at this. You can see it from the video. From the angles, they're too high up. They go up like this. So you can see that, guys, right here. Okay. So the trick here, let's take a look at how they go. They all go forward. You say, well, does that happen all the time? No. If I look at two non-balding scalps, they go backwards. Okay, or they go sideways. Or there's a world. The gentleman I just did on Monday. This I did an FUE on Monday. I did a strip on Wednesday, and the FUE gentleman, 38 years old, his world this way from the central point, and it came out like this, and this came this way. And he, if I had just willy-nilly did whatever I want, he won't match his other hairs. Over here, it went 90 degrees coming out before I even hit the temple. Should I have designed it the way I did? And it's right, because that's his natural hairs. If you have so much mineralization, it's nothing. Like if you say, well, his angle's here or 90 degrees. No,
you would still go
absolutely, because that I won't cut it transect it because I'm parallel to it. And if I made all these 90 degrees, it's going to look god awful. It will look fake. Right. And again, you may not notice it's fake. I will. Okay. So those angles, this needs to go. That's a great question. It needs to go low. But that's to show you this. But his case is classic because they all go forward. If you look, they all go forward. They don't bend. Okay. Now, you're going to see some exceptions to that again. And those exceptions don't mean you should design that. You should design if they have a naked scalp forward, no splaying open. For this, all the reasons I've told you about. As we go into this, look here. I don't know if you can see this. You can see that it just slowly goes over. Right. Look at this. Is it go from here to this? Bump, 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 bump. You see that? Okay, let's look at the crown. Okay, so everyone knows the world going this way, okay? Let's take a look at these angles. Now, the problem is, the angles, these are already off, so to speak. But these, they aim up, and what you want to do is, if you look at it from the side view, can you see it's flattening? What you want to do is recreate fullness. So that's why these angles need to be high. You can hear more in the crown why it needs to be high. The other reason it needs to be high is when you put a whirl, they compete for space underneath the skin, and if you go low, not only do you not get the lift, you can't dense back it. You need to have high angles back here, exact opposite, because you see how they compete for space underneath the skin? Because they're whirling, okay? So let's look at how this arches over. So this is the crown, and as you see, they go this way, right? Now watch this, okay? So what is the lateral hump? This transition right here where the canthus is lateral canthus, that's a lateral crease, right? Mid-scalps go forward and maybe a little bit in, and these go down. Now let's look at the lateral hump. Lateral hump, if you look, these go straight forward and then down. These go straight forward. Now what's happening here? They start cascading, right? They start cascading. Now look at the joining of the crown to the sides. They come up and down, up and down, up and down. So think of it this, the way you understand a lateral hump, which we'll hear a lecture on in a moment. Forward, they start to go down like this, okay? That doesn't have time for anymore, so at least it shows you that's a lateral hump. And you can see they all transition from the crown perfectly. If you see these, they come down like this, and they join. There are no abrupt transitions anywhere on the scalp. If you go back, when I go back and look at your design, if I see you make an angle here and over here, it's very uncombable and it doesn't look right. There must be soft transitions. But in the front, they all go forward. So that's probably the key thing is the crown connects to the rest of the surface in a gentle arc. There are no abrupt transitions. All right, so if we look at this temporal point, let's look at it very carefully. They come down and look at these. They see they go down this way. Now, unfortunately, these last little bit of temporal points, so it's not as obvious, but if you look at the ghost hairs that are left of the temporal point, they aim this way. You see how these aim forward and then they bend back down this way, and these almost go straight down to join. So they go forward, backwards, and these go straight down, and then they join together to go down this way. And these join like this. So this, you see how it's a little too big. It would be better if you cut a little bit curved so it doesn't buckle like this, because it's hard to work with. But I basically want you to maybe cut it a little bit smaller and pin it down in all points on the perimeter. On top of the scalp, you see I'm a little bit off midline. Make the hairline wide enough that you're struggling over a curved space, okay? Oh, yeah, you're just going to cut it off around here and then cut off just so it's not so big. Put the T-pins, enough of them, you can use 6 to 10 of them to put all the perimeter down so it doesn't buckle. Then I want you to take a marking pen of any kind you want, violet is fine, and then draw a U-shaped hairline. Don't go crazy with it. Get these lines done and start, then maybe make a little micro hairline, and then start the recipient sides. You can just use one size. Again, I don't really care too much about anything else. And then I'm going to come around and critique it, so you guys can do that, all right? And then stick it in here. Got it? Female hairline, basically, I'm just going to draw a curve like that, okay? But of course, they're going to be. You can have a little bit of a what's called like a widow's peak over here. You can have what's called lateral mounds, which are a little bit of more protuberances here. But in general, it's the exact opposite shape that you did for a male. when you do a female hairline, generally speaking, there's a cowlick, which basically there's a whorl to it. So essentially, for example, if this is where the hair parts, you may see the hairs go this direction like this, and they go down the temple like this. Remember the note about transitions? And sometimes you'll see the hairs just go backwards, and then they start going forwards. Look very carefully with magnification to see this. I'm not going to design it with magnification. You should be able to see this pretty well. But essentially what I do is I go and do that little bit of micro hairline, okay? And the micro hairline actually goes this way. And I'll have a female lecture, which I'll show how I design it. But let's say that's it. So I'm going to design this hairline. Remember, these go this way. So when I'm making these sites, they need to go like this. They need to whirl like this. So these need to go that direction. But if you can see, there are many. They have like hundreds there. So don't worry about it. If you're dull, just change it out. I'll show you how to change it if you want to change it. But you see that what I'm doing is now I'm following this radial arc. I actually draw those lines in because I need to know how to join it to the native hairs. I look at where the native hairs go, and then I conceptualize it going forward. So I draw these in, and then I make these sites. When I go into the temple, it needs to really start going low. The reason why this is so unforgiving is the temple angles need to go super low. I oftentimes will use bent hypodermics to get low enough because the hub makes it hard for me to go low enough. But essentially what I'm doing is I'm going with this irregular line. The regularity for a female hairline is a little, to me, more linear than a male hairline. It doesn't have to be quite as irregular, but it still has to be pretty irregular. So this is my female hairline, and then I just build my 2 hair sites. Those are 1 hair sites. I usually do 2 or 3 rows of each of these, but just for the sake of this, you can argue these are 1 or 2s, but especially if the hairs are coarser, I definitely need more ones. So this is just showing you building, and remember, conceptualize that line. So that
your needle towards that.
I turn it to the direction that I want to design. So you can see that these are my 2 hair sites, okay? And you see that I'm following, you see this? I'm following this. So I'm trying to create, and I'm not wearing magnification, so I'm not seeing if I'm exactly close enough. I'm really just showing you sort of the design pattern here. So this is how that angle, see there's a big gap there, so I'm going to fix that. There's a gap here, the hairline's too linear. I would put a 1 hair side over there. And then of course sentinels are the irregular ones that sit out by themselves like this. You've got to have a few of these. I design these sentinels. I usually use perpendicular sites because they don't get my staff confused of which one is sentinels, and I only design that after I've really built up at least 2 hairs because I can't read which is a 1 hair site. So I build up these on front. Before I build all this, I go back and add some sentinels, maybe 20 to 50 depending on what it is. And then I just make these sites going this direction. Thank you. And you see that I'm building up less linearly this whole area. So I'm building up these sites. It gives a huge gap over here. I'm seeing, so I'm filling those gaps in. But this is a female hairline. So I'm just building this cowlick and this design to match this. You see this is really poorly designed. There's a lot of gaps here. I have to go back because I'm not wearing my match, but you can see I'm going back and filling these holes that I don't like this, and that's very. So that's a female hairline. I never shave the recipient area. I hate doing that. There's so many problems with that. Besides the fact that patients hate it, it leads to so many problems. For example, it's a wonderful question. I should have brought it up in the recipient. I never shave. And so the reason is it's harder for my staff to place, it's a little bit harder for me to design. But if I don't see those hairs going a certain direction, I don't know where and I don't see the density. If I can't see, I like stack a site on top of an existing site, big problem. I also evaluate how the patient looks with the dry hair. I also wet it down, see how it looks with wet hair. So there are areas I thought, I didn't think they needed it. Oh my God, when I wet it down, it looks so miniaturized. I got to come back and add more sites. You can't see any of that with short hair. So if they've got naturally short hair, that'll mean have to wear it longer. But I need enough that I can see what's going on. Yeah, so do not shave. This is a trick that I learned when I first started from my mentor Vance. Is when you're having all this existing hairs and they're making recipient sites, your natural tendency is just make sites. You're going to chop through their existing hairs, which won't damage the results. Or they're going to have all this hair shedding and fluvium from damaging these hairs, and they're going to come out at a day and go, what did you do? So what you do, it's very cool. What you do is you take the soft, like let's say this is a hair growing here, right? You take you push it out of the way. You just use this one stroke. You push it out of the way and then make the site. Okay, so that's something I want you to practice on when you're seeing someone with hair. You just use the dull end of the thing, move the hair out of the way, and then make the site. Okay, that's a little pearl. That's a huge pearl because that's important. Make sense? Let's do the crown. So just do a little circle back here, and we'll represent the crown. Thank you. So we're going to put it back on the back of the crown. The crown is on the vertical plane. Sometimes it edges up toward the horizontal plane, but generally speaking, it's on the vertical plane. And when you're on horizontal, you're at the posterior mid-scalp. So what I do is I look at this, and I'm not going to go through all the creative decision making of how to do crowns because that's in a lecture that I have. But just generally speaking, let's say we make a whirl like this, okay? And so I draw the whirl in. It's really important that you draw this in, and there's a lot of planning of how you want to do the whirl, whatever. But I just want you to just draw the lines in. That way you know how to follow it. Drawing lines in is so important to do this. So here's a trick with the crown. 1, start from the center. Don't start from the perimeter. Because the problem when you start from the perimeter and go to the center never looks like a center. It looks like a big blur of mess. And when you have a big blur of mess in the middle, think about how hard it is for the staff to place because these are going in 50 different angles, right? Now, if you have a blurred out center, that center, you don't know, is one side this way, is this way? But if you start in the center and move out, that radial pattern is very clear to the staff. And that way, when these angles are going, or directions are going 50 different directions, the staff will know, oh, this goes this way because it's very clear. So always start from the center of the whirl. The question people have given me is, what if you have 2 whirls? So you do. So if they don't have much, it's just all whisper like Vellus hairs, skip the second whirl. However, if they've got 2 that are pretty intact, you got to design them. And the way I would do it is I would build out some, and once you've built the center of the whirls, you can merge them. But if you start with this whirl and hopefully you're going to match and get to that one, it will be very hard. I've made that mistake. You must start from the center of the whirl. That's rule number 1. The second thing is have the patient sitting high up. They need to be upright, okay? Because you're several reasons. I mentioned this already, is that you have to, this is critical. I made this mistake again. I'll tell you all the things I made a mistake on. You need to see that bottom line. You must draw a line. I draw a circle around the whole thing, and I must draw the line, and you're looking for the coordinate. Because if you don't, sometimes what happens is the headrest is sitting here, and you thought you finished it because it looks like that's the end, and like, oh my God, I forgot this much. You didn't plan on it. So have a clear black line that shows you, or whatever line color, on the bottom saying that's my endpoint, so you can visualize that whole distance as you're designing it, okay? If you need to make a quadrants or whatever to keep your number counts good, that's fine. But make sure you visualize that bottom portion. That's important. There's so many negatives with the crown, okay? It's a very, very advanced thing to do, and it's not that advanced in the design. It's advanced in the judgment. Does that make sense? And advanced in the consultation to make people understand. So remember I told you that you need high angles. Low angles, high angles, minus the bottom portion where the angles must go down. You can't make these angles way up high because they need to match down to the donor. So this portion, this upper arc here, about here, this upper 2/3 needs to be high angles. These need to be low angles. They need to be gradually turning low. So how do you get high angles? Remember, that's the other reason they're sitting up. It's easier to create high angles here. If they're down like this, to create high angles, you're like this. And positioning, another thing too you can do for positioning, I even start making sites, like this. Okay, let's say they're here and you're doing this, right? That's hard, right? But watch this. Lie lateral to cubis. Hey, easy. And look, low angles. So low angles and they're easy. What if how about this side? Okay, so what I do is if you need to do this to help, I say turn all the way to the side, move your shoulder in. That way they're not like this and they're comfortable. Put pillows between their knees, get them comfortable position. It doesn't take long to do the lower portion, but do it like this. Okay, does that make sense? So those are all the position controls. Now when I make the side, so I first make that center of that whirl like this. Okay, so I am, now here's the trick. Look, you see there's a hole there? I'm going to go into that hole. I really don't want to leave a hole because this is the area that just looks weak. That center, in the old days, I would put one hair grafts, always worrying they wouldn't look natural. So the trick here is fill the void. So as you see, I'm now going around here, and I just go around. And you see I didn't go all this full thickness, so I went back because this is getting dull. But you can go to sort of see this now here. There's a hole there, right? So I'm going to make a judgment and go, hopefully my staff can figure that one out. But that's the one that they may not figure out. They have to put their tines in or their forceps to see if they got the right angle. And I just really build this laterally out. You see how high my angles are? Again, if you don't understand, it's the reason for the high angles is that when this is coming out, it creates more volume. And that has several benefits. One is from the profile view. When someone is balding here, it looks flat. And when it creates lift, especially women, a lot of times they're not balding here like a man, but they're complaining of lack of volume. And so when you can create that volume going up, you fix that female problem without having to use a lot of grafts because they're all angled out. So lack of volume is one of the big issues in this area. And the other thing too is think of this. When the sites are all in a whirl, right? If you can sort of visualize when all the sites are in a whirl and they're very low angled, they're all competing for subcutaneous space. Does that make sense? Because they're like this. Now let's tilt those up. If you think about the competition of subcutaneous space, you can make it really tight because there's no competition underneath the skin. Does that make sense? Yeah. So that's another reason why you want these angles very, very high, especially for the center of the whirl. Now the other thing is, I didn't really talk about this, but the front, the reason why you want that low angle is, look at this. If you have light coming down, this is called shingle. You see the shadow? The definition of baldness is not just the absence of hair, it's the seeing of the scalp. When you have the hairs at low angles, they create an awning or a shingle like a roof. And if you interlock them, they're better than if they're not interlocked. And so the more shadow you create on the scalp, the less visibility that scalp is. And now you've got really good density. Now what happens is a lot of people, they comb their hair, for example, they comb it back, either covering the crown or comb it this way. You get the benefit of it forward motion, and you get the benefit of it backwards coming over. You get a double density, okay? And that is the other reason why you get visual density. Versus this, it doesn't cover well, and you can see the insertion points. If your insertion is not spot on perfect, it looks fake because you can see the insertion point in this area, and it doesn't comb well, and it doesn't create visual density because now it's just being flayed back this way if it's combed that way, or if it's combed this way, it still doesn't create visual density. Now, exact opposite with the crown. Think about this. What this is doing is if I can make lift and whirl, if I make it up, it's going to go up and back down on itself. Can you visualize that? Yes? Whereas when I'm doing the front, I want it to go forward and back. So the exact opposite reasons, same reasons, but opposite technique to achieve the same reason. I want these high angles and tight, especially in the center, and I will put 2 and 3 hair grafts right in the middle. Because, of course, the very, very inner, I mean, I do 3s. But generally, I want this to be denser than you think because that, remember that cascade effect? This covers all this distance. This one covers only that little distance. And that's why this is so critical. I'm going to show you in my crown lecture all the ways that I can use cascade. And it's going to be incredibly complicated, but it's going to challenge your creativity. And that's going to be the fun part. Right now, I'm giving a tease on it so that you can get that framework to understand it more. And so, I mean, I could just continue to make sites, but it's pretty straightforward. Okay, but those are the key points with crown and female hairline. FUE basics, I'm really proud of this because after a 64 chapter, 1600 page, 2-volume set book, I realized none of the basics was covered appropriately. So the new book that's coming out in July will have all these details. I'm really proud of this lecture because it's going to help you guys understand this. That I wish someone actually taught me when I started this, and no one has ever taught this. And I think you're going to be blown away, I'm hoping. So remember, just as a summary, when all you have a hammer, the world appears a nail to you. So everyone needs FUE, and that's not true because, as I believe, women, as I already told you, extensive baldness is just, they're not good options for FUE. And remember that safe donor area is really encroaching downwards, and so LSE can be a better option for those patients. Remember, it's not all or none. There's a spectrum. Okay, that's a quick summary of some of the key points. So how do I do it? Let's break it down. So the first thing I do is a hairline design, as you heard. I want to get that established when the patient's awake. After that, I want to mark out my donor. So here's how I mark it out. So first thing I do is I look at the perimeter of what I can harvest safely. So I want to be far enough away from that crown that there's no issues unless he has no crown issues and he's older and I've got a wider zone for me to harvest from. But I first mark it out. And this is something that no one teaches you. Why mark out the donor? There's a few reasons. When you're in a close range, you can't read where you are, and you want to be able to see where you cannot go and where you can go. And the second reason, you want to plan the numbers. You want to over harvest from one zone and not get over here and not plan it out. I'm going to teach you in a moment after it's going to be also crunched to understand after I've done the mark out, how do you use these grids that you design to actually use those to calculate number distribution, okay? Because this is not just a marking for the sake of marking. So what I'll do is I'll first draw a midline. I'll draw across the bottom and the top, and then for the borders, I'll say, well, this is about the border on the helix I want, and then I'll measure out, and I'm going to do it. I'm going to do it in lab. I'm going to find someone in the shade over there, and actually I'll walk you through it so you see it in person. I'll measure out from one side. Now just make sure if it's 8 centimeters here or 10 centimeters, I have 8 to 10 on that other side, so that they're symmetric, and I have sort of an even harvest. So then I will just join all those sites, and then I'll divide them into 3 or 4 centimeter grids. Here's the trick. It doesn't matter if it's 3. I don't matter if it's 4. I don't matter if it's 2.5. They're just tools for you to design so that you can stay consistent with the harvest, and I'm going to walk you through what that means as I'm doing the design. I'm doing the planning. So if I can just sort of divide it into areas, that would be great. The way that I usually do is I look at sort of the center, see where it curves up into the ear area. So for example, that center area is usually higher density. Toward the sides, it's usually lower density. So for example, if you look at the side view, that center, in this case, 8 grids versus the lateral 8 grids have different densities. So what I'll do is I'll fix that center 8 grids, and then I'll probably just square off and divide that lateral into 4 points, whether that's 4 centimeters or 3 centimeters. Again, the numbers, you don't have to be exact. I just want them sort of equally divided so that I can make a prediction and plan on the design. So after that, this is an old slide again. I don't have all the grids drawn in. I used to not do this, but now I think it's really helpful. I'll put in that little bit of straight lidocaine, and then I'll just blow it up. You've already heard this. I'm using a very dilute lidocaine marking mixture, and I'm just exploding that up, starting along that occipital ridge there, just to anesthetize that, and then I'm aiming down and going to cover that bottom portion, then aiming up and going laterally. Okay. Once I've done that, I'll finish the ring block anteriorly. Remember, I've done a little bit of nerve block too, and so that once I've done nerve block, deumescence, and then anterior ring block, they're pretty well anesthetized. At that point, I have the patient still sitting up, because I have this patient sitting up to do all of this portion, and then I will just harvest a few test grafts and let my staff measure that length so that I will have the right graft to site fit, and then I'll do a few test sites, make sure everything fits, and then they make all my recipient site instruments, and I have the patient lie supine, because they were sitting up for me to do the marking and all those elements. Then I put the patient in a recumbent supine position so I can do the site creation. Once I've done the site creation, now I've got a number of what I've made in terms of recipient sites, okay? And I take that number, and then I plan on the grid. So here's an example. Let's say I made 2,000 recipient sites. It doesn't really matter. The number can be 1,653, but let's say it's 2,000, even number. I've got 14 boxes that I've drawn out. Dividing 2,000 by 14 gives me 142 per box. But remember that laterally, I'm going to be a little weaker. I probably don't have that number to go to. So what I would say is, if it's 142, maybe I'm shooting for 175 in the core grids, right? Because I'm just guesstimating that if I'm looking at it. So if I do those 8 core grids in the middle, that's 175 times 8. I get a number on that, and I subtract that from 2,000. hope this math makes sense, and I divide that by 6 for the remaining boxes, it gives me 100. Does that math make sense? Do I need to repeat that? I'd be happy to repeat it if it makes sense. Everyone got it? Yeah, so very simple. If I want to shoot for a number of 175 in the 8 central ones, right? Just because I think I need more there. I'm not going to have enough on the sides. I'm going to multiply 175 by those 8 core grids. That'll give me a number. That number subtracted from 2,000, which is a number, will be the delta left on that remaining 6. I divide that remaining number by the 6. Will tell me how many I need I can take from that, and that comes out to be 100 in this case. Does that make sense?
Where'd you come up with the 175 then?
It's just an arbitrary number. I just think, you know what, I need to pull, I gain 142, I need to probably go a little higher density in the middle, and that's how I do it. You know, everything is different, and every grid is, sometimes my grids are smaller, and if I have fewer grids, if there are more grids, I may be doing only 80 per grid, and that allows me to distribute it evenly, so I don't hyper-harvest on one side. And so you'll hear this as I progress, but what I'll do is when the patient is starting the harvest site, I'll announce first grid done. Give me a number count. And they'll say, so let's say I'm shooting for 80. Let's say I'm shooting 175. I'm counting. So I'm counting my harvest and I'm spacing. So it's actually harder for me if I've got a large grid and I've got a low number because I need to space it very far apart, and that takes more work than if I'm just going very concentrated. Does that make sense? Because I've got to work harder to space it. But I want to space it because it's better than over harvesting one zone. So it's easier if I have to harvest a higher number in a smaller grid versus again, it's harder if it's too dense because you're fighting against over harvesting. But generally speaking, I finish a grid and then I'll say grid 1 done, give me the number. And so they'll tell me that first count, they'll say you pulled 190. So I'll say, okay, and as I'm keeping track of this, I'm thinking, okay, well, what I'm going to cheat on is maybe some of the lower grids where the density is a little lower than the upper ones, and I start to progress, I may do fewer on the lower ones, or I may think, well, on my laterals, I can maybe go from 100 down to 75. So sometimes I'll finish that first 8 grids, 10 grids, whatever the core may be, or half the grids, because you don't want to have it too much on one side. But when I finish those core grids, I'll sit and then we calculate. I'll say, okay, I've got, how many did you get me? Okay, I've got 1,500 out of 2,000. I've got 8 grids left. I'll say 500 divided by 8 will give me what I need for the remaining grids. So I'm constantly recalculating. That's how I plan the harvest, okay? And I don't think you'll see this in any book, not even the book I wrote in FUE, because this is something that you guys don't know. You know, how do you plan this? This is so important, right? Am I wrong? It's never been taught. It's so critical. Every step I'm going to tell you is going to be so critical in this. So this has really been a revolution. I use really, and I don't make money off Trivellini or Devois, but they have really one of the best ones out there, not the best out there, because they use this technology. It's basically a hybrid technology. And what hybrid basically means, if you think of a trumpet, it has a sharp edge like a trumpet, right? And it has a blunt face. This combination is the reason why these work so well, because when you have a blunt face, it cradles the graph without hurting it. The sharp edge gives you an ability to cut with less transection, and the graph quality looks amazing. So when you're using the old blunt sharp, or in like the Artel blunt sharp combination, it's just different from these sharp blunt hybrids because they have the combination of both. The other benefit is the older technology was fully rotational. So in other words, it was high velocity rotation. Now it is oscillatory. So in other words, think about this: if you have a high velocity rotation cut through the tissue, you're going to torque the graft. It's going to cause heat damage. It's going to cause torsional injury. When you're doing this at a slow rotation, and you can actually adjust the oscillation going in, you're going to have much less injury to the graft. And that's really where we are today. And that's why these are so. It's a combination of hybrid punches and oscillation that makes such a huge difference. And there's some other little fine points we'll talk about in an upcoming slide. But that's the two things you want to understand: sharp outer edge, inner edge blunt. And there's so many modifications they're not worth addressing in this talk. But that's the core if you don't get that. Okay. So these are to me the leading edge people. You've got both to work with here. And I'm actually excited to try the Devois one because it's a new generation one, which I don't even know. I played a little bit with it yesterday. We'll see. We'll see. But these are both great. I own 2 of each. They sometimes break down. Sometimes they're not good in one case. In fact, they're working on my Trivellini right now to work on it. But it's great to have multiples. I know it's expensive. And you know what? Ultimately, you don't have to buy 2 to start. You want to start doing this, but you don't want to get a situation where you don't have a tool. Your patient comes in and then nothing's working. So you want to have enough backup that you're not having a problem. So what are the differences here? So this slide is maybe a little outdated, but there are some benefits to it. So the WOW, because it's a foot pedal driven one, I can feel it a little better than Trivellini. I can actually modulate it. And it's hard to describe it until you actually do it. I can control it, and I like the feeling of the WOW, especially when I do beard harvest. Hands down, it's the only thing I use for beard. I don't get the sensitivity with the Trivellini that I get with the WOW. But the WOW is a heavier device. It is a little slower. The Trivellini, if I've got a really good clean harvest, it's faster because of the graphs, because it has a lot of gains that the WOW doesn't have. One is that it's very light on the hand. The second benefit, it has what's called smart react, which means that when and you'll see it here, when the instrument touches the skin, it initiates the movement. Whereas my having to initiate it with my foot, it's a nice little bonus with that. And it's faster. It has a suction built in. It's unlike the near graphs. The suction doesn't suction the graph up. It just holds the graph in a position as it comes in. It's a little bit of counter tension as it comes in. It's nice. And also, if there's blood in that area, you can use that suction to get the blood out while you're working if it's a little bloodier field. So, and now the new WOW device, which I haven't tried, the benefit is there's a wireless device. It's a little heavier on the hand. Again, I've not used it except for holding it for about a minute yesterday. And it has 2, so if one breaks down, you've got a wireless and a wired one, so that's nice. And they also incorporated the multiphasic portion that the Trivellini has, which is the fact that you can set the rotation and the oscillation. If you said, well, what, you just told me you don't want to do rotation, why are you telling me about rotation? Because with the Trivellini, what it does, it sets the first few milliseconds on rotation. It allows you to score and cut the dermis pretty well. And then as you start getting closer past toward the rector pili muscle, as you come down, it can switch to oscillation, so you can control it. So that's what so there's a rotation. You can adjust those things just like what the Trivellini does. So there's a gain to that. Here's a big lesson. When you start, it's going to suck, okay? It's going to be tough. You're going to transect. You're going to want to kill yourself. It takes antidepressants. It's not easy the first time, but you'll get it, all right? It really will. It's like everything. The good thing, the learning curve with this is much easier than a sharp or dull punch. But there's a learning curve. It's going to be frustrating. And with your working on cadaveric tissue, it's 100 times worse than live tissue. I hate to tell you this. So if you're frustrated there, you're going to master it, okay? Just like this analogy I used my sister doing oil painting. I had the same struggles. Everything is like the first time you drove a car, the first time you rode a bike, it wasn't easy, okay? It won't be easy, and it will be an uphill climb. But once you hit that moment of lucidity, which just comes together, you go, I got it. You're not fast, but you're getting there. It will happen. It'll click. So don't give up on it. This is the most important slide. Don't panic. Don't pull your hair out. It's going to work, okay?
How are you practicing?
So here's a good thing. I had strip patients. I was able to transition from the strip. I did strip for years. You may not have the luxury of that, and you're going to have to promise small things. So if you are already doing strip, you can transition over to FUE. If you're not, promise small cases. Do scars. Do small little things and get good at it. Whatever it is, start small because it's going to be tough. But you'll get it. Your transection will be high. You're going to hurt some grafts. I hate to say it, but you'll get better at it. It'll happen. Magnification is critical. I used to use 2.5, then I went to 4.5, and there's just this amazing feeling with 8.5. Maybe because I'm 54, can't see a damn thing. But to be honest with you, 8.5 is gorgeous with a xenon light source. And the only one that I know is this Surgitel. I don't think Design for Visions has it because I looked at both. The Surgitel's great, and I have a Surgitel here. You can look at it. I don't make any money off that company either. And I would recommend not to get the Oakley version. I heard some people have those break. They cost a little bit more anyways. Just get the nerdy black frame ones like you see on here. This is great. 8.5x Surgitel, standard frame. Position, you're going to sit above the patient. I find it the easiest to get down on the patient's scalp, and you're going to just turn the head as need be. What I basically do is I start it on the I start in the middle of the harvest, like to the right, because I'm right-handed. I do one grid, that grid, I come over to the right, and I finish the right core grids. Then I go from the left and go over to the left core grids, and sometimes I got to turn the head a little bit. And then I finish the left lateral and then the right lateral. I do the patient's right, patient's left, and then far left, far right. It's just a way that I move to do this. It doesn't really matter how you do this. So how do you harvest? So harvesting requires two things: good visualization and good feeling. And here's the negative: it's 70 to 80% feel. It's actually not what you see. And I wish someone taught me that when I started this. But it is, visualization is critical. If you're misaligned, you won't get the right harvest, but you need to feel it. And I'm going to teach you how to feel it. And I wish someone taught me this. And this is going to be really good to help you understand this. I guarantee no one's taught you this. Well, I can't guarantee it, but I'm pretty certain no one's taught you this. So how do you line it up? So here's the dirty secret. Ignore the hair above the skin surface. I'm going to repeat that. Ignore the hair curl above the skin surface, because the hair is going to curl. So here's an example. If you look at this hair curl, it arcs up on the left. You can see it arcing up. So the natural tendency is to look at the curl and think that's the direction of the skin. It is not the direction of the skin. The direction is where it enters through. So how do you see where the direction is? You look for the blush. And it's a little bit harder to see in African American, but the African American hair is also very different. So unlike that one exception, you can see a blush through the skin. That blush is the hair follicle through the transparent dermis. If you have enough magnification, you'll see the blush. The blush is just the passage of that hair follicle through the upper epidermis dermis. Does that make sense? So that's telling you the direction it's going through. So what you want to do is center and angle the punch on the blush, because the blush is telling you the direction. So if you don't do that, you center on the curl, on the upper curl, you'll transect. Look at the image on the left. If you follow the curl, you'll cut off that bottom portion. On the right, you'll see that I ignore the curl, and I'm actually going not with the curl, and I'm following the direction of the blush. Can you see that? Yes? Here's a slide that shows you the blush a little bit better. Can you see that bluish color? I'm looking, now this is nice because the hair shafts are straight, but there's always a little curl. Have your eyes focus on the blush, or at the entry of the skin, because that's where the hair shaft is going straight, with the exception of African American. All other ones that have not a hard curl, look for the blush, follow that angle. So, and center the punch on that. Okay, make sense? Yes?
What about for African Americans?
In general, it's all different, because it depends on how hard the curl is. I don't have a ton of experience with it, to be honest with you. I don't do a lot. So there's two things you can do. One is if you look at this curl like this, if you go this way, you're going to transect. So you need to go bigger, like a 1 millimeter or 1.05 versus a 0.95. I usually use a 0.95. And go more perpendicular to capture the back end of the curve. The other thing you're going to hear when I talk about feel is you're going to actually feel the glide of it, and just wait for a moment when I explain that as a separate topic. But on the curve, if you see the curve this way, you know it's going to curve back. So if you loosen your hand grip and feel the suction of the movement, it will actually curve you. And once you start to feel the curve, you can actually arc it under the skin to follow the curve of the graft. So you're not just going straight perpendicular, but you don't want to go and see the curl, see the angle up here, just follow it, because you're going to transect. So you want to just glide with it, and you can follow that curve, okay? So the next thing is the feel, and this is the one that's so hard to teach. It's how do you teach feeling? Well, I'm going to teach you what you should be feeling. So why is feeling so important, and what are you feeling for? You need to release the erector pili muscle. You heard that from the very first lecture. The erector pili muscle is what's preventing these grafts from easy removal. And you've separated the erector pili, you'll see the graft will pop up a little bit. And that's a signal to you that you've probably released it, and you can also feel it. It's a slight resistance give, okay? Now, if you are not feeling it, you're not getting you're not learning the feeling of it. You need to learn the feeling of it. And if you just go radically too deep, you're going to have problems. So even if you're right on angle and you go too shallow or too deep, there are consequences. If you're too shallow, you'll cap it, which means you'll see this in a subsequent slide. You'll just take the top off. Or you'll strip it, and that beautiful perifollicular tissue is gone. You have a denuded strip graft because you're yanking it out, okay? Or you're getting bulge compression because the staff has got to squeeze it to yank it out. And so I always get feedback from my staff. They'll tell me no perifollicular tissue, or weakened means I'm not going to, or too forceful extraction. I want to hear these, because after, I always pull my own first few out so I can get the feeling of what's going on. But after I started to get the speed going, it's up to my staff to tell me if something is not right, okay? And actually, sometimes in the corner of my eye, I'm looking for transection. I'm looking for anything. They're going to call it a T, 1 T out of 3. And if I hear 2 T's in a row, I stop. Something's not right. 1 T is okay, but if I get 2 T's, my angle's off. And the way I stop, I come back and I go around the patient and look at different angles. I may move I may have to go higher or lower, reposition to see because it's three-dimensional. So sometimes I'm just not positioned right, or the head is not right. So just take a second to reposition and look. It'll take you 5 seconds to see where you're off, okay? Because the hairs flow differently. That's why you don't want to jump around, because the hairs flow like this, and they flow like this, and flow like this. So if you're skipping around, you're going to have impossibility of harvesting, not to mention going back and filling those gaps up. So you want to progress. We'll talk about that in this lecture in a moment. So you need to release the AP. You're going to feel a slight give in resistance. How much farther beyond that slight resistance should you go? Generally speaking, you should stop when the resistance gives. That way you don't go too deep. However, sometimes you've released the AP, but you haven't released every dermal adhesion. So sometimes the dermis goes a little bit deeper. So you've got to go a little farther. And you're going to know that because when it's being pulled, you're going to hear stripped or whatever. It means that, hey, I did feel it, but still not quite right. You need to go just a little bit deeper. And you're going to start seeing there's going to be a blood stain on these. There's no depth meter, but once you're starting to use it, you'll see the blood stain will tell you how far to go each time, in addition to just that feedback of feeling and seeing, okay? So you're going to feel an AP release, and AP release sometimes feels like transection. You know, oh, I felt that release. That's because you cut through the graft. So if it's a premature cut like this, that's a transection. If it's a gentle release, then you are most likely to release AP is confirmed by seeing it pop up and your staff telling you, hey, these look good, okay? So you're going to feel that, and that feeling is so important. The other thing you're going to feel, okay, is this is what's cool. This is something, again, I wish someone taught me when I started this. And I've just been, this is going to be the new book. It's really cool. So is loosen your hand grip. This is so critical. A lot of times you're nervous and you're holding tight, you have no feeling. You need to loosen the hand grip. Get closer to the tip of the shaft of this, because if you're here, you're farther away from being able to feel the tip. Does that make sense? So I choke up a little bit on the tip and I loosen the grip. What is really interesting is that, I don't know if this has been reported in literature maybe, is that if you just loosen it and let it go in, it will actually suck the right direction in. It will actually vortex in. So if you, well, autocorrect, I call it. So if you just feel it, you'll feel this. And you'll go, hey, I'm off angle. I need to do this. So if you hold it like this, you're going to feel nothing. It's going to be a brick going in there. You're going to transect. So if you're transecting, reevaluate your angle, reposition your body, your view, 3 things. Your chair, height up and down, your position of your head, and the patient's head, whatever it takes to reanalyze the situation. It'll take split seconds to reanalyze. And the second thing you want to do, loosen your grip. And you're going to feel the movement. And that micro correction, you may not even feel it the first time because you haven't acquired the ability to feel. But when you feel it, you can feel it's an autocorrect going down. Or you're going to feel that it actually sucks like this, like an arc. Your brain will have muscle memory and feel the arc movement, and you're going to replicate a slight arc. Even if it's not African descent hair, you're going to feel a slight arc, and you're going to feel that. And it's so hard to teach this because you don't know what I'm saying until you actually feel it. And when you feel it, you can't unfeel it. Okay? So it will happen that click. Just listen to what I'm saying and work on this. Okay? Okay, so this is the thing: is you want to feel sidewall transections, you want to feel dermal release, you want to feel what it feels like when you transect through a big hair. I usually use 0.95 millimeter for most of my work, unless it's an African American, I may go higher. There's a new thinking, and it's evolving. I think that like what Jim Harris has looked at was high level hypopigmentation with smaller ones, and you may have known the famous study that there was really no difference in smaller versus larger punches. I just want the best graft that I can without the struggle, and so I don't do 8.8s, I don't do 0.85s. I generally do 0.95 almost for everything. I've passed it in more 0.9s, 0.5s, and I think not that much harder, but I think these grafts are healthier and hardier, and I don't know. But that's what I do is a standard 0.95 for most things. So then the final confirmation is you should see the graft pop up just a little bit off the skin by a couple millimeters. Not always, but most times. Now, the other thing you want to do is if the staff are pulling it out and it's just falling out, you've also gone too deep. Now, what's the problem going too deep? Well, grafts splay like this, okay, so that you have a higher chance of transection. You also have a higher chance of hooking and mangling the graft. I'll show you some examples of what that is. But essentially is that torsional injury of the graft with that punch going too deep is going to cause issues with the base looking either hooked, like a fish hook, or mangled, like torsional injury to it. So the staff will say too easy pull, or they'll say the base is mangled, you're going too deep. Okay, so there is a consequence of going too deep. You're going to have higher transection and higher mangled base of the graft. So you want to have them feel modest resistance, like just barely resistance. You don't want them to feel like, oh, it just came out. And you don't want it to be like, ah. Okay, so that's something, again, you should be extracting your own grafts to start so you know what to feel. Because it's not only that you want to feel how it goes, and you want to actually be doing extraction. So semantic purity, just so you understand what I'm saying, extraction, all this, there are two phases. There's incision and extraction. So incision is the cutting, which is what I do. Extraction is what my staff does, but I start the first extraction. It's always with a two forceps pull to minimize damage. And then excision, which is the new lingo now that the ICHRS, International Society of Hair Restoration Surgery, recommends, encompasses the two elements of incision with extraction, hence follicular excision versus extraction because it encompasses both elements. Okay, so when I talk about incision, I'm talking about what the surgeon does, extraction is what my staff does, just so you understand semantically there. So it should pop up. This is just a video, pretty useless, but it just shows you, I don't know if you can see it, it's so small, but you can see how they pop up a little bit. Okay, that's what I mean by pop up. So when you look at the graft on the left, you can see there's a little bit healthier perifollicular tissue. On the bad, it looks very similar, doesn't it? It just has less perifollicular tissue, and your staff should be trained to tell you when they're not having tissue. They'll tell me more tissue. That means I'm not going deep enough. Okay. And then on the other side, these are some examples. Capped basically means the epidermal cap comes off and the graft still sits in situ. That means you didn't go deep enough. You can see hooking on the other one, either angle like a fish hook. It means you've just caused too much torsional injury down deep. And then transection, everyone understands what that means. You're probably off angle and you didn't quite hit it. And then strip means you didn't go deep enough and you're ripping off the tissues and the base looks denudative of good perifollicular tissues. And that feedback is really what your staff is helping you with. Okay. If I'm looking at upper transections, I probably, especially half, I probably discard it. If I've got 2/3 of it, my staff are the ones making the call. I don't go and sort this. But if I've got the majority of it, I will keep it. Now the trick you don't want is you don't want to put 2 into the front hairline thinking it's 1 and then it goes out 2. So if you have a question, if you've got a transected second one, it's probably not a bad idea just to make that into a formal 1 and move it to the hairline. So now we're going to talk about how do you follow a pattern to minimize over harvesting. Okay, that's the next topic. So when you look at the pattern on the left, you see those blue arrows pointing in all different directions. Those tell me that if I take it out, what's around it is blank skin. Does that make sense? And you don't want to have problems. So here's some examples here. If you look at this, the check mark. Okay, so the check marks and the X's on the left mean something different. They're complex follicular families versus simple. If you look at the X's, they're very complex. It's hard for your graft, your punch to get around them without transection. Now, I will actually, to be honest with you, harvest those. I will split it and cleave it off and do a partial follicular family. Even 0.95 can do it. I wouldn't do that for you. You're going to cause transection. So I would look at cleaner elements. Like the check mark shows you that they're tightly bundled. They're not splayed out, and you're going to have less risk of transection when you try to take that. Okay. Now on the right side, it's showing something different. It's talking about distances between hairs. So let's look at the green one on the top left green. If I take that green one out, there's so many surrounding areas. It's very tight. You see what I'm saying? But if I take the one to the right of it, the red one out, I may not take that one out because there's so much space around it. Does that make sense? So when I'm looking at it, I'm looking at two things. I'm looking at general spacing. So if I'm going to an area which is very few grafts and I'm going to go take one out because I want to keep an even pattern, you're going to create a denuded space. Okay. The second thing that I'm looking at, it's not in this design, but it's going to be explained in mine, is I look for how the hairs grow over it. So I'm sitting on the top of the patient looking down. When I take one hair out, I'm thinking, is there a hair above it to cover it? Okay. So that's what every side I make, I'm thinking, do I have a hair above it to cover it? Because if you just take out willy-nilly a whole column, you don't have a problem. So for example, you look at the top portion, you can see that the rows of hairs taken out, that's a mistake. And unfortunately, this is one of my earlier harvests. You can see that there's too much proximity to it. That's not good either. You see what I'm saying? So these are mistakes that you want to avoid. So this is just a schematic of how I look. So this is from the surgeon's view. In other words, top is bottom, bottom is top. I'm looking down on the patient. So as I start to make a harvest, remember, if you skip around, you're going to miss things. You want to stay and move toward things, right? You don't want to just harvest it all. You don't want to skip here and move there because the hairs curve, and you'll see that in a slide in a moment. So I'll harvest one. The next one I harvest, I think, okay, well, that one's far enough away. I've got a hair above it to grow down. Remember, hair above means toward me. It's the bottom of the screen coming down over it. And then as I go forward, I'm thinking, well, this one is okay because I can have that hair grow over. This one is, and so I'm just following this pathway. And it doesn't have to be that sometimes I move a little to the left, move a little to the right, but I'm not making abrupt jumping motions. I'm following in a progressive fashion. And that's really what this is just showing you, how I just go forward. And then in your handout, this is in the book, I've got this. You can't even see it here. It's really small. But you'll have this. You can look at this. This is how I just map out a whole thing so you can see how my brain thinks 1, 2, 3, 4, 5. It's not gospel. It's just how I think about it. And I got lazy putting all the numbers in and I think you don't want to read every number. Those red dots are the ones I would harvest. Okay? I just want you to look at that and think about it. Now, this is the opposite direction. I'm sorry. The top is, think of it, you want to sit on top of the book and rotate it and look down. That's how I'm planning the harvest to minimize over harvesting. And the more you mentally divide that grid down, you can even subdivide that grid because you want to really follow in a very progressive fashion here. And then, as I told you, hairs gently curve. So you want to follow in directions going out. You don't want to just jump around and skip everywhere. It's really important. So this is obviously, this is the cardinal sin. This is the thing that I see almost every week walking through my door because people just don't know what they're doing. Please don't commit this crime. This is very, very sad. So for smaller cases, for example, if it's an eyebrow, I harvest very, very wide to limit the risk of over harvesting in a zone. And this is another example. I think this may have been a scar I was correcting. I decided just to harvest it super wide. If that person needs to comb their hair super, super short, there's very little risk of seeing that hypopigmentation because it's so wide apart. This is a case I was referencing I did last week where I harvested much lower than I usually go because there was a little bit of loss up high, and I was able to cherry pick all his 1s and 2s, and so it's not very evenly harvested because I went in there and picked only his 1s and 2s and a few 3s to get that frontal hairline done, and I went down toward the nape of the neck where he didn't have retrograde loss a little higher so that I can pull more ones and twos, where there are more ones and twos, and I can say farther away from the crown. And again, this is the cherry picking design that's there that I mentioned. This is just to show you again the epidermal cap. We talked about this. If it's not sitting flush, it's a problem. You can see it best if you look to the side and sit on the profile of the patient and look for that. The beard is a very difficult area to start because the beard, the angles go everywhere, and the depth is a little bit more shallow. You've got to feel it, and really that feeling is great. And you think, oh, beard is easy to harvest off the scalp. It's not that hard, but when you're starting out, it can be very challenging because every angle is different. It doesn't start going here and it goes everywhere. One angle is different from the angle next to it. You've really got to have concentration to look for those angle changes. So when I'm doing a beard, I usually harvest on the right because on the right hand it's easier for me to do it, and I move to the left to harvest the left side. Sometimes I have better access still from the right. So as one of the indications I already told you, I do beard to beard, but you must match the caliber, and if I'm doing scalp, it's more of a salvage. So summary here, finishing up here is use high magnification, 8.5 with the xenon light source, Surgitel is great. Look for the blush, ignore the hair curl above it. Reposition if you're not seeing something right. Hold it loose and close to the base here, and feel the movement. And that's so important. Feel the erector pili muscle release, feel the dermal release, feel for possible transection. Look for feedback in terms of, am I too shallow, am I getting hooking, am I getting transection? That's the PF, perifollicular tissue. Think about spacing, think about how far the grafts are from one another, think about the hair that curves over it, and don't skip around. Beard, as I said, is complex directions. Yeah, it's much more superficial in the harvest than you're used to. There's not as much of the deep dermal adhesions, and do not overharvest under any consideration. Of course, this is the sort of encyclopedia of FUE. It's great as a reference, but it's not going to teach you how to do it. That's it. This obviously, with this being like a Norwood 6 going on to a 7, would be not a case I would show you this, but in a way, what you have to pretend is that he is actually not balding here because I would be scared to harvest this close to it. I have to harvest this, and I can't harvest that narrow. But I want you, just for the sake of argument, pretend this is a Norwood, like with a crown up to here, to do the safe, because this really would be a strip. But again, with a shaved head like this, no way I could do it. So let's just pretend that this area is the SDA or safe donor area. Clearly it's not, because you can't go to the periphery of it. I'm just going to pretend it is for the sake of showing you how to mark the area. So the first thing I would do is sort of mark a midline. Okay, that helps me sort of create things symmetrically. And let's say my SDA or safe donor area is here. It clearly is not. This is not safe to do what I'm showing you. And I sort of mark it out, and I sort of mark this side out like this. Okay, and then after I've marked this side out like this, then I'll say, okay, well, maybe I'm going to stop at the helix. All right, and then I'm going to say, well, here he does have retrograde loss. Obviously, I can't go this low, so this would even be wrong. But I'm just pretending he has more hair, but it's easier on a shaved head than trying to draw through hair. So let's say that his hair actually went all the way down to here, and I'm just going to stop right there, okay? So that means this is my design, something like this, okay? And then what I'm going to do is, just for the sake of argument here, look at, this is, 13 centimeters roughly, so I'm going to measure 13-ish, and that's roughly here. And then I'm going to look at the height here. This is roughly, let's say it's 6.5 or 5.5, so I want about roughly 5.5 here. It doesn't have to be exactly precise. And so I'm just marking this out. Now over where it bends toward this area, this lateral, I'm about 3.5, so I'm just going to go and measure this to be about 3.5 here. So roughly, so I just want, again, it's not precise, it's just a way to plan the harvest. And this is, again, this would not be acceptable design for him. It's just teaching you the general ideas here. So then I look at this and think, okay, well, that's where it goes to the lateral extent. And I'm going to sort of draw it there. I'll just see if these are roughly the same. Again, roughly doesn't have to be exactly. And this is about 8. This is about 8. So I'm roughly 8. Then I look at this and think, okay, what was this height? This was about 5.5. Let's just say I do 2.75 roughly, just somewhere in the middle there. Again, it's just, it gets all, and I'm just going to go and divide that like this, divide that in half. Now these are going to be a little narrower, you see here. I probably want to make it a little bit more toward the midline, so I get more even. And then I look at this and I'll say this was 8-ish, right? Did I say 8? So this is about, no, this one here is, yeah, 8, so I maybe divide by 4. But that's going to be too wide one, so I did these 2.5. So 8, if they're 2-ish, let's say I just divide these into 2-ish. So they would be 2, 4, wait, is this 8? No, here. Let's say I divide these into 2, 4, 6, something like this. So here are some examples of the grid, maybe this grid. So this is generally, so this is, I would probably draw the line here to make it a little more even. So these are rough ones, and I would do the same here and draw the 4. So then this would be 1, 2, 3, 4, 8, 16 small grids. This one here, maybe I'll just divide this into 4. And these are bigger grids, but they are less dense. So I just divide this into 4. And so then I have 16 small grids. And these maybe, my grids are usually bigger than this, but this is just to show you an idea. And so this is 16 small grids, 8 bigger grids that are lower density. Okay? That's how, and then I told you how I planned it. I don't have to go over that again if someone wants me to go over that. The one thing I didn't talk about in the lecture very briefly was, what is a safe number you can harvest? You've probably heard the old Manny Merritt 50% rule, which is if you lose 50% of your hairs, that you will begin to see visible baldness. 50% harvest in the back is a very dangerous number for the vast majority of people for a lot of reasons. First of all, when you're harvesting 50%, what Manny Merritt did was he pulled individual hair follicles out. He didn't pull out whole follicular units. When we harvest whole follicular units out. So it's very different from his plucking, okay? Second problem is that it leaves scar tissue behind. Plucking doesn't do it. You take out a full follicular unit, you're going to leave a hypopigment scar behind, and that's going to be more visible. Think of Paul Rose talks about a hairbrush analogy. If you think of a hairbrush, they're individual clusters of like hairs, bristles. Taking a bristle out is different than taking a whole bundle of bristles out because there's more obvious hair loss. So what is it? Is it 25%? Is it 40%? The answer is yes. It could be any of those depending on shingle, color, contrast, all caliber, curl, contrast ratio. There's so many factors involved that it's not a single number, but you've got to look at how to minimize overharvesting. The other problem, and we mentioned it briefly when we were over in the bathroom actually, is that when you're harvesting, the natural tendency you want more grafts of higher caliber, and you're going to pull more 3s and 4s you have, and you're going to leave some 1s and 2s behind. So the natural bias is to overharvest already. So if you hit 50%, it's, first of all, is it 50%, which is not a good number, remember, but if you do that 50%, are you harvesting, you're actually harvesting way more, because if you're harvesting more of those denser grafts, you're actually harvesting maybe 75%. So that's just why overharvesting is such a problem right now. It's the number one problem I see with FUE. Does that make sense? So you watch these live surgery workshops, people harvesting, there is zero educational value, but I just want to see how easy it is to harvest and show you some ideas. But when you start, I want you to remember all the principles I just taught you, and that's what you're shooting for, all right? I've noticed that just watching someone harvest will give you no education. What I need to do is you start feeling those issues, okay? Okay. So everyone needs 2 forceps to remove what these are smooth, which can be harder. Teeth are a little bit easier, but it's okay. And I'll show you how to extract as well. So what I'm looking at when I'm looking here, I will sometimes move around and look at the exit angle, but I remember I'm looking more at the blush underneath, which is a little bit hard to see here, but still I can see where it exits. The key is don't look a few millimeters beyond, look at right the exit point. That's your entry, that's your angle that you need to follow. We're good? So I steady my hand, okay? I'm looking at the exit angle. We're good? I'm gonna turn the Smart React on. Yes. Look, you feel it? I can feel it, and it popped. So you're grabbing it at the top of the base, and you're just cradling it out. So there is a full graft. Good graft. Okay. So you should be able to start to feel this release, and this is great tissue, amazing tissue. Not quite deep enough. No. Sorry, I'm slow with my harvest here, so give me a little more time. Good. Okay. You felt? I can feel it. I can feel it. You can almost see the release. I went a little too deep, but
Oh, I see.
still, see, I've hooked a little bit, but overall pretty good. So, and a little bit of strips. So you're going to start to get the feel for this as you go. Okay, so that feels about right. So I want you to start to feel that. Okay, so this is really good graft quality. I mean, really good grafts. The WOW doesn't have the smart react. I've only been used to it without the rotational component of it. And basically, you can sort of modulate the movement a little bit better, in my opinion, when you're sort of relaxing it, but it doesn't have the smart react. And I haven't used rotation. I don't know how that's going to be. In beards, I like this a little bit better, but I'm a little slower harvester than. I'm a little off center, but let's see. Just, you can feel that release here.
They said that 30% of how
Okay. So these grafts, you can feel both of them and see which one you like. And I encourage you. I know they're both great, and they're both great in different ways. The Trivellini gives me a lot more speed, even though I'm slower. But the WOW gives me a little more feel. But you just have to get used to it. Everything gives you different feeling about it. So I encourage you.
Depth gauges on this?
They're really no. These tell you. No, they're not just tell you what size it is.
Okay.
But really, what you're gonna do. This you don't have blood, but what I usually do, you'll start seeing some blood come up, and it'll tell me how deep. And you just get used to the feel. Once you get used to the feeling of this, it'll tell you how deep to go, and you just replicate that. So I'll be honest with you. You can watch me all day harvesting. You're not going to learn diddly squat. You need to start getting the feeling. What I want to do is come around and help you. If you're getting transection or issues, it's not because of the quality of the tissue. This is amazing tissue.